Uh, Good morning, everyone. I hope you enjoyed yesterday's meeting. We had very many compliments, so thank you all for contributing and thank you for attending. Today, we are starting with our General Assembly, and these are the minutes. So I am going to do 20 minutes of office reports, summaries, and I'm also giving just like final balances for the finances report and sources that contributed. Leila will will give us the voting results, and then we will nominate the offices, the nominees for the different offices. So the past term started in April 2019, and that was at the time when Sudan was going through a very tough time that didn't settle until October 2019. And then soon after that, it was COVID time, so pretty tough. Despite all this and the many closures, we tried really hard to keep up with at least some of the mandate that we put ahead, which included African guidelines, it included registry, and it also included looking at revenues for sustainability of finances in ASID. What happened after that, so in April, we had elected members who were appointed to the offices in Senegal. And at that time, we did not have a vice president. Because there were no proposals for the 2021 conference venue. So we continued for over a year without a vice president. And on the 31st of August 2020, we had a meeting during which we discussed the situation, and Morocco proposed that they can take the 2023 venue. And as such, Dr. Leila Jeddane was appointed vice president, and this was announced on newsletter. Professor Brahim Belaid, who was originally appointed as training office lead, was asked to move from the training office to the Secretary General position at that stage. And then I'm just going to go through some of the activities and some of the things that we've been doing over the past 2 and a bit years. So the first thing that main thing that we did was contributing to the IAPIDS school in February 2021 in Portugal. There was a representation for the senior faculty represented by myself and 2 junior faculties, Dr. Rayan Goda from Sudan and Dr. Anne Barasa from Kenya. It was an excellent opportunity, and I can ensure you that there are really big opportunities for ASID and other sister societies under this umbrella, because it's a very strong, it can make a very strong voice. We settled with the IAPIDS board or the IAPIDS membership that the representation from ASID is going to be by the president, the past president, and the secretary for purposes of mandating and continuity and succession, and for documentation. And then we also, during that period, we contributed to many documents that were effective worldwide for our PID society. We endorsed the essential list of diagnostics requests for the WHO with our other PID collaborate societies under the leadership of IPOPI. And we also contributed to COVID guidance to patients with PID with IPOPI and other societies, other PID societies. I have produced with IPOPI, we have produced a statement and position paper on IVIG during COVID time. Sorry, this one is a mistake. It's actually a joint committee of experts on IVIG with IPOPI. Together, we produced 2 papers, a statement and a position paper on the nadir of IVIG during COVID times. And these are both available on IPOPI website. And we have produced an advocacy statement on IVIG for African countries together with IPOPI, and that's available on our website and has been announced on the newsletter. We have initiated many links with new venues, including links with the Rare Disease International, WHO, through what's known as the Global Network for Rare Diseases. At the level of the society, I'm just going to take some examples from the different offices. Scientific office has done, together with the advocacy office, have done some changes to the newsletter to include, so the cases are not there, but these included education sections with more case reports and presentations on PID to guide our, the new generation of immunologists. The details are available, and the example was set by the sent newsletters. We have also done a bit of ASID directed COVID education through the newsletter, and that was quite useful. And I actually had a couple of comments from physicians about this, that they wanted more of this. So the other thing that we did was the survey, the results of which were presented yesterday by Dr. Ali Sobh. And we also worked on the African guidelines, and we worked on, as I alluded to on my opening speech yesterday, and which will be presented in a bit of detail today. We have formed a core group, and ASID board members were contacted for reviews. And we have also some international advisory board that agreed to give us some help whenever needed. One of the things that happened is that we agreed that we should have a total of 3 or 4 schools that would ultimately lead to an ASID certificate of PID. And this certificate of PID, we propose that should have a stated number of credit hours to standardize it. The first of the schools was a free one that was transmitted through the conference as a pre-conference activity. So that was a huge success. And till Wednesday, there were about 800 hits on the YouTube channel for that. So thank you. Dr. Esser has worked really hard. She's been doing this for a number of years now, but I think eventually we are picking up a success, a tight end of a thread. So for the registry, I think we've done a bit of progress now that we are starting with the guidelines, but we also have got some recommendations to carry on and some communications to do. So we have identified 2 sponsors from the industry who have very strong potential in supporting setting up the registry and funding ASID for its continuity. We've already initiated some links and some communication to do that. We are proposing the liaison with IPOPI, and Monika's just sent me an email saying that this again has been met with a lot of positivity from our team. So she agrees that they will be helping us with tracing patients across the continent to help and improve our pickup rate and registration. So we also propose that the registry portfolio should have like quarterly meetings with the board for updates. And obviously we will need some administrative support for that, and an additional person to help Monika with entry and follow-up. It is a big project, especially at the beginning. It's going to be quite tough to initiate. And we are having a symposium which has been sponsored by Takeda during this conference. Speaker is Nizar, who is a very well-known friend of ASID and has got big experience and has initiated some of the talks on the registry in previous conferences in various discussions. Advocacy-wise, this was quite difficult actually with the COVID and with the low finances. But we did manage to issue 2 newsletters. Not enough, but that's what we could do within the limitations. We had the connections with various societies and the patient groups. We have very strong links with HIE International, and we've contributed to some of their activities in the form of presentations and such. We are being asked to be part of IPIC 2022 and CIS 2022, both of which are really good for advocacy and liaison and collaboration. There was a very successful Kenya A project, and I have to congratulate our Kenyan colleagues for the huge success and advancement that they are making in PID. They've published at least 7 papers since 2019, so that's excellent. Well done, Kenya. Senegal has been active doing some advocacy. They've initiated WhatsApp groups for their patients and organized some activities through their university and the hospital. And they've done some e-learning for PID. So well done, Senegal, again, great achievements. Various countries have done various things, but I have to say not a lot has been done, not as much as we would have wished to have happened, but this is what was manageable within the limitations. Now, finances, I have to say this was really tough, as it always is. We are going to produce a detailed report, and we will circulate that in the newsletter very soon. As this is online, I chose to give you the highlights. So we've had some very good interaction from the industry for the conference and also for the IAPID school. And this just tells us one thing, that we have to have a program and we have to have specific objectives and address according to that. And this will bring in revenue to ASID. So the industry, just for the conference and for the IAPID school, in addition to the JOSI royalties, have produced a credit of about $48,000 US, of which we are expecting to spend a total of about 43,000. So we will be ending up with something in the region between 5,000 to 7,000. I have to say that finances haven't been settled yet because not all the signed contracts with the industry have the transfers are on the way, basically. So we've signed the contract, sent invoices, and we are waiting for the money to come in. But I am happy that we are leaving a little bit of revenue, a little bit of money for the next ASID office. And that will become clearer once we close all the books that are open at the moment. But it is in the region of 5,000 to 7,000, inshallah. So Rayan is working on finalizing that, and she will be sending me the final for endorsement as soon as the conference is over. and then we will be circulating in the handover newsletter. Now, we have a remaining mandate, especially with the finances. We have identified some potential revenue sources. The website have always been a worry when it's actually supposed to be a source of revenue. We have to make use of that, and we have the newsletter. So we are going to mandate those as sustainable revenue producers for ASID to help with at least maintaining themselves, and a little bit more to help with other activities. We also propose, and we mandate this now for sure, because we have announced it in the September newsletter of 2020, and it has now been endorsed by the, well, it has been endorsed a couple of months ago by the current ASID board. We're just waiting some technicalities. One of the major things that I did not actually mention, which is available in the previous slide, is that now we have a memorandum of understanding with the Moroccan Society of Primary Immunodeficiencies, which has been very accommodating throughout the life history of ASID, and we have to appreciate that and thank them for that. So we have a memorandum of understanding with them that states that ASID has an account under their name, but only for ASID. So only ASID ins and outs will go through that and nothing else. And we will be provided, or the coming ASID board will be provided by regular statements. And I have been receiving regular statements for the past 6 months or so. So thank you very much for doing that. Now, this was one major technical issue that we needed to resolve, because before we could actually go for mandating membership fees. And the other one will be the technical issue with the website, the introduction of the, the portal itself. So we will hopefully see that happening within the coming 3 to 6 months. But it is a necessity. We propose something between $30 to $50, but I would say $30 because Africa is quite, African doctors are quite, overstretched, and we are in limited resource countries. And this would at least offer them the free newsletter, discounted memberships with other sister societies within the IFS umbrella, and also the discounted conference and ASID school fees. We think that the ASID schools should bring in a little bit of revenue to cover their own cost, at least, and the certificate cost. So these are the main mandates and the main issues that I chose to highlight in this report. And I think I will end up here to give a bit of time for nominations. If you have any questions, please go ahead. Aziz is now the Vice Secretary, and Leila. What do you think? Do you want to take questions now or at the end?
Yes. Well,
Leila.
it's what is mentioned in the ASID constitution. So normally, the end of the taking over is at AGM.
Yeah.
And as I said, I don't mind taking over now.
Mm-hmm.
Well, we'll coordinate all the women in mandate or something, and so on. So for me, there's no problem. Well, it's what is mentioned in the ASID constitution. So normally, the end of the taking over is at AGM. Yeah. And as I said, I don't mind taking over now. Mm-hmm. Well, we'll coordinate all the women in mandate or something, and so on. So for me, there's no problem. It's what is. There's a lag.
Okay. Okay. So I went to the chat now, and there were no questions. I think we should go with the second presentation. So do you want to share now? I'll end up mine.
Okay.
Hello. The question, I think that the question can be taken at the end of the presentation of Leila. Okay.
Okay. Okay. Thank you. Thank you, Professor.
Okay, so regarding voting results, the votes was open since mid-September, and we closed it yesterday midnight. We got 42 participants in the vote. It's not much, but I think it's about the same amount each mandate. So we had 10 candidates that proposed themselves. So the last candidate was really last-minute candidate. So well, and as you can see, there was each voter could select until 5 people to be in the board. Regarding the vote positions that are still available, we have the secretary, vice treasurer, on advocacy awareness, registry, clinical training, biological training, and research. So 8 positions or 9 positions if we want to put 2 people in the registry committees. Okay. I think it will be 8 because we need to keep the own number of members in the board. So regarding result, we will propose the people with the best result to get the position that they wish. So I think Rayan proposed herself as the secretary. So I don't see any, so are you okay with this position? Okay. So Rayan. Aziz, which position would you like?
Can you show the clinical training if the probably agree?
If you wish. Wim, which position did you like? Would you rather get the clinical training or research? Wim, are you with us?
Yeah, research.
Research. So okay. So I put Aziz in the clinical training. Okay. After that we have Anne. Oh, Anne, can you? Okay. Did you propose yourself for a specific position, Anne? I don't remember. Can you, Omar? Can you open the mic for Anne Balassa? Is she in the spectator?
Anne is in the spectators, I think. Yes. Anne Bararsa.
Okay. So we ask her later. Let me take a look at which position she was. Sorry. Where is our motivation?
Please, can you put it by diaporama for a while? We can see the numbers and the vote.
Yeah. Okay. I'm interested in serving on the board. She did not. She didn't mention any specific. So yeah. Okay. Anne. Ali was asking for registry or training, if I remember right.
Hi, everyone.
Hi.
I hadn't chosen, I'm very well, thank you. I hadn't picked a specific position. Perhaps let me see. I think advocacy, stroke awareness.
Okay, no problem. Good, because it's a position that neither one want.
Okay.
I hesitated. I personally hesitated between clinical and advocacy. So congratulations, Anne. I am very happy.
Yes. Well, I honestly thought you would take advocacy, Aziz, because you have so many fantastic suggestions for all sorts of things. But I'm really pleased, and you are on that. Well done. Thank you.
All right.
Okay. So let's go to Ali. Should I put him in the registry?
Leila, excuse me.
Yeah.
Monika Esser has chosen.
Oh yeah,
Monika.
she's. I think she's been chosen too. Let me see. Oh Monika yeah. Oh, I missed you. Sorry.
I think I just stay plugged in the registry.
I will help you with that to start with. That's fine.
But if we have enough members, I would like to, get Ali on board, and then also for a transitioning process eventually. So if we've got enough members, it would be nice if we can have Ali with me.
If not, I will carry on with you in the registry. How about that? I am old, but if we don't have enough people, I will carry on with you on the registry.
Wonderful. Wow. Okay.
Okay. So with that is Ali and the two candidates from Ivory Coast, Vincent and Madeleine.
Right.
So okay, should I put Ali with the registry and
Tinsy also from?
Yes, we don't have any. Yes, we don't have any biologist for the biological training, so maybe we just keep training as a committee, right? And yes, and should I borrow the
training including the biological training?
Okay. And I think these are the coordinators or the chair of the committees, and perhaps will constitute a committee for each function. Okay.
Yeah. Can we have the vote again? Because I think there are two people. There is Tensi.
Yes.
Ali.
The two. Yes, Ali, and could you Vincent and Madeleine from Ivory Coast.
So those got more of the.
Okay. Should we keep the position of vice secretary and vice treasurers, or should we put them in the office committees?
I think we.
Have we Nahla? Excuse me.
Yeah. Yeah.
You want continue, please?
No, I'm just thinking that it would be good for our Ivory Coast, all the new countries to be involved in active offices, because that's going to, make continuity and succession of ASID better, I think.
Yes, I agree. Excuse me. Continue, Nahla. Excuse me.
Yes. No, that's all I wanted to say. With the vice treasurer, it can be anyone, and the vice secretary can be anyone as well.
Yes,
so,
but Huh?
I mean, I think we have to ask them, are they here?
Please wait in their answer. I want to make a suggestion.
Okay.
Please, Leila, can you show the result again, please?
Yeah.
So there is 2 points very important, is to have a maximum of countries in the board.
Yeah.
This is important. And we must also have some French-speaking people because of the Moroccan Morocco will be the next Congress venue. So who you propose as Leila? Is French speaking, and is there Madeleine? Madeleine is French speaking?
Yes. Yes. Vincent and Madeleine are both from Ivory Coast, so they're French speakers, as well as Najla from Tunisia.
Well, I think that Madeleine is very good. I propose
both if you're looking at voting with it, both are elected. So we just need to put to give them a position, but both could be elected.
I think we put Madeleine. As you know, Côte d'Ivoire could be, as we discussed, a next French sit-in for ASID after an English country. Perhaps, because we must say so. They two are good because they are French speaking, and two they are from Côte d'Ivoire.
Yes, both are coming from Côte d'Ivoire.
Wouldn't it be advisable to have another person also on advocacy awareness? I mean, that is where also a new board member can get in quite nicely.
Perhaps we will constitute committees, and now we ask for the chair of each committee, as it's mentioned in the constitution. So the chair will propose a list of persons who wants to help with her. I think it's a good idea to have a lot of persons in each committee. I think with the success of this Congress organized by Nahla and team, we can have a lot of members. I think I am sure there will be a lot of persons who wants to help and to be involved.
Okay, so should I put Vincent in the training committee and we move the vice treasurer?
Okay. Can I would like to suggest something, please.
Yeah.
So we are going to form committees.
Yeah.
And I can see that there are people in the vote who are very interested and who are very keen. And that's why they nominated themselves. I think we give those who nominated themselves the priority in these committee forming, these new committees. So I think that would be really good to include them in the committees as co-opted members, wherever needed.
Okay.
So people who have not been elected by the vote, okay, should be given, I think they have to be given the opportunity to contribute to ASID committees, the committees that will be formed for advocacy and training and
of course
registry and that. So they have to have the the priority, because they are obviously very keen on coming along. Maybe the vote did not work for them because people did not know them previously or something like that. But I think we should consider them seriously for the committee members.
Yes, as we said last time, chairs. Well, you have the committee chairs that in the board, but they need each committee needs to have their own office with people that are really that are really keen of working with them. So it's not just the committee chairs that will do all the work.
That's right.
Ali already worked a lot with RIM about newsletter, and other people that are not necessarily in the board can work with us on the committee. So there is no the board is is a spokesperson of the committee, but
the committee, absolutely, yeah, that's right. And the board is for the whole, society anyway. Yeah, it's an appointment by the society, so that's fine. Yeah, we agree. Okay.
Okay, so Vincent didn't ask for specific position, if I remember. No, he didn't ask. So I don't know where we should put him.
Okay. After no, there are members of the committee, and we will discuss this in the board after, if you want.
Okay.
Now we must end the board and have the perhaps. Do you think we can discuss the next country? What do you think? Leila Jeddane.
Yes, regarding hosting country, I did a question about it in the board, in the voting result for which country they wanted to host the 2025. Most of respondents, I think it was 21 answer. Including one saying hoping to be on a venue. So good.
So what did they say again? Sorry, I missed that. So they wanted online.
Hoping to be on the venue.
Open.
They wanted a physical meeting.
Of course, everybody wants a physical meeting. We're tired of sitting in front of the computers.
Okay, but so when I typed all the answers, the Kenya and Egypt was the most wanted hosting countries. So if there is anyone from Kenya or Egypt who is willing to take over, it will be appreciated.
Is there a member of the committee from Kenya?
Anne.
Yes.
Anne, okay.
Yeah.
No, so you will be the
next big thing.
The vice president. This is a good idea. What do you think, Naila?
What did you say, Aziz? Sorry,
Anne should be the vice president.
Yeah, excellent. I would love to see that. Definitely.
Oh, good.
Oh.
Well, take your time to think about it. Take your time to think about it. If it's okay with that.
I mean, the only issue is she going to do both? I mean, vice president is an introduction to how the board is going to work, and you will be in the advocacy already. Okay. So how will that work constitution-wise?
Okay.
Constitution experts, Monika, Aziz, and Brian.
What do you think, Reem? Where are you? We are. You are the second in the hosting.
Yeah. I think it's too much to give two positions. She needs to know about the board and the stuff. So
yeah,
I think awareness and advocacy need to go for somebody else. This is what I feel.
Yeah. Why don't we allow one of the French-speaking people to go for the advocacy then? Although I am not going to understand what they say, but that's fine.
For now, Vincent, I still have no portfolio for now. So maybe if he's willing to do the advocacy. Well, maybe we should push it on Anne for now, because she's a great big decision to make. So okay, what I say is think it over. Do you feel ready to host the 2025?
I think he must be an Arabic. He must be an Arabic speaking, because in Wikipedia, the Arabic is the most spoken language of the people, not of the doctors, not of the doctors. In the country, is the most speaking in the country. There is more than 100 million in Egypt and Sudan and North of Africa. So he must be also Arabic speaking. No, what do you think?
No, we need to go. We need to go soon.
We
need to go south. We always in the north. We need to go back to south.
Yeah, we have to.
Ready to
I think
I agree.
I mean, honestly, having Kenya would address one major thing. I think we've lost the communication with Sub-Saharan Africa after the late Professor Chipita. And, you know, getting Kenya, we hope will get more countries from that, you know, area of the continent, you know, into the ASID, you know, into the PID community. And it is closer to Rwanda. It is still close to Ethiopia. We have got, you know, some people who are really keen from Ethiopia, at least 2 or 3 doctors. So I think we can make a good, you know, reviving of that region.
Yes,
I think so. So yeah,
yes.
I'm quite excited. Actually, I didn't. Well, I'm sorry, but I didn't vote for that because I did not see the question.
Neither did I.
Yes, only half of the voting answer to that.
All right.
Okay, so yeah, it's not showing, but Uganda was also mentioned twice.
Right.
Okay. So well, Morocco was mentioned twice, but it's already selected.
And it's enough. It's enough. You've done it once, and you're doing it one more. And I think you should have just, you know, I mean, this was a direct question, isn't it?
Yeah,
it was not like a vote.
Yes, a direct question. It was not mandatory. So
okay.
Yes. Yes.
Yeah.
And are you happy?
I am happy. I am very happy.
Please, your mic is
muted.
Yes, I think we have enough time. If we talk about 2025, and we'd be very glad and willing to host.
Okay.
Fantastic.
So good.
Lovely.
So
you're
good.
so lucky, Leila. Can I become president?
Hmm?
You have a full board. You have a full
Yes.
office. I love president again.
I'm so.
You're so lucky.
Yes.
Okay, excellent.
So,
have your
President,
plan all set for you. Well done. Thank you so much, everyone. You have.
I just so good that I did to put this question.
You did not work hard enough when I was president.
Yeah. Yes, I didn't do it. I didn't think about it at this time. So, okay. I mean, maybe
is there a biologist in the committee? Is there someone who is biologist?
Except me? Except me and him? No.
Hind.
But Hind is already appointed as a treasurer.
Hind cannot do anything else but being a treasurer.
Okay.
Just leave her alone.
Vincent is going to be in trouble
because the clinical I am not a biologist, so can we put someone in the biologist or okay, we can let.
What about Najla?
You have chosen Vincent. I don't.
There was also Najla.
Okay,
Najla al-Makki.
If you want to do the advocacy and leave Vincent in the training, is a better. If you take a look at his motivation letter. Yes, take a look. I know you don't know him, so it was recommended by Alao.
No, he is from Vincent is from where?
Ivory Coast. From Ivory Coast.
Ivory Coast. Okay, I can because he must know the field and the activities to do advocacy, but I can be with him and others in the committee. So one English speaker, we will choose one English speaker and one Arabic speaker also to cover, and perhaps Portuguese is one to cover this. But we can let as this. It's okay. Okay, it's good. I will work with him, and I'm sure he will do a good job. Okay.
Good. Oh, congratulations, Leila. I am so jealous.
Well done.
Well done.
Please, Anne, please excuse me. What's your specialties in? What's your specialties?
Clinical pathology, but I focus mainly, I teach immunology. I've been working in immunology.
Okay, clinical immunology. You are as Nahla.
Pathology.
Pathology. So yes, you know, but you know about biological too. But
okay, no problem. It's good. It's good. We must have also a biologist. Okay, good. It's a good team.
Okay. I think we are running out of time now, but yeah.
Yes,
well
yes, we need to go back to the other session, even though we can get 10 minutes late.
Okay, and now I have to move to the physical venue in the coming half an hour. So I'll see you later.
Okay.
Okay.
Yeah.
Are there any questions, anything on the chat? Can I just double check? Anything that you received on YouTube?
There was one question on the Q&A that I answered.
Okay, so what was that? Okay.
It was about the registry.
Central or country-based.
Yes, yeah.
Yes.
So,
but I don't know in the YouTube if there is any questions. Okay.
okay.
Okay, so welcome to the new board members. And thank you all. And well, I wish that we will do good work. We have lots of work.
Yes, President. One last thing. Can we just agree on the handover date? I feel that we need to finish off and tidy up all our paperwork and give you everything nice and clean. So I thought official beginning of the new board may be 1st of November. So maximum. I think we just have to, I just want to make sure that all the signatures are right, all the paperwork is there, all the folders are together, basically.
I am against
You're
this
not happy?
position. I'm not happy.
Why?
Because it's against the constitution, and Leila is enough mature and experienced to do all what current dossier issues, and as we did every time, Leila is from tomorrow the president of ASID, and you and your great experience, Nahla, you will be always needed to take decisions, and there is no problem. Why will it's not democratic? I want to say so. There is no matter to go against the constitution. Okay.
Go ahead, Reem.
Sorry, I don't think that there is a statement in the constitution to say exactly what is the time for the position. So, right, Leila, Monika, and Dr. Aziz, because I really didn't see a specific statement. So I thought the end of the month is just for Nahla to finish tied up and give it to Leila in a proper way. I don't know. It's just 3 weeks, unless there is there is something.
It's much easier for me to just
it's easier
down to 9.
Exactly.
It's the easier pathway for me. But
we discussed this on the WhatsApp group, and I say my opinion, and I don't think we can go against the constitution.
Well, tidying up is not something. Well, Well, you stay the Congress president, so for all conference admin and so on, okay, that you have to tidy up everything.
Okay.
Is there any other thing that you need to do in the before handing over? I'm not sure.
It's mainly the finances. It's mainly the finances
Well,
at the moment.
finances
Yeah.
is related to it's related to the conference. So
Okay.
you stay in charge of that for the all conference finances. You stay in charge of that.
Right.
So yeah.
Okay. So you're happy. So you're happy taking over.
Yeah.
And new board is starting tomorrow morning.
Tomorrow. Yeah.
Well, it's now really. It's now. So that's fine. Okay.
Fine,
Well,
okay.
this is the easier option for me, to be honest. Yeah, that's fine. Okay.
Yeah.
And I will finish off all the financial stuff with Rayan and maybe with Hind as well.
Yeah. Yeah.
Now.
Of course.
Yeah. So in between me and Rayan to produce the final report, and then we'll just pass it on to you.
Okay.
Send me a list of all the stuff that you need me to hand you if you don't have it. You probably have most of the stuff anyway.
Yeah.
Just send me an email with all what you want me to do, so that I don't forget anything. Okay.
Okay. Okay.
Right.
Send me back your office report so that I check what I missed. Okay.
Okay.
I think so something that I was not aware of, so just to make sure. Okay.
Right. Okay. Yeah, I'll explain them to you. That's fine.
Okay.
Okay. Right.
She was not a candidate. Yeah, but yes, ma'am. Yes, Sohna is a good girl too. Yes, she can help Ahmed for Aziz for the training. So yeah, for the biological side of the training. Do you remember Sohna?
Yes, I remember. I'll contact a lot of many of the biologists in Africa to be involved in this committee, in this section.
Okay. Right. Okay.
Right. Okay.
Okay. So thank you all, and should we move to the main session? Okay.
Yes. Okay. And I'll see you later. Okay. I'll see you later then. Bye. Bye now.
Bye.
Yes. Okay. Hello. Good morning, everyone. I'm very glad to be here with all the colleagues from ASID and all the attendees to this terrific Congress. So far, we had yesterday a very nice day with so many perfect and fantastic presentation. And we're going to start for the moment the selected oral presentation. We'll have 5 presentations for the next hour now. And we encourage you to put all the questions on the chat. And we'll start with the first speaker who will tell us about utility of expanded molecular testing for primary immunodeficiency. I think this presentation is missing, so we skip to the next presentation. And the next presentation is computation analysis revealed by 5 novel mutations in human IL-2 gene related to X-linked SCID. Dr. Babiker, you have the floor and you can start your presentation. Thank you.
Hi, good afternoon, everyone. I'm Dr. Babiker, a clinical immunologist at Elmarsafy Teaching Hospital and a member of Sudanese Organization of Patients with Primary Immunodeficiency. Firstly, I would like to thank ASID to give me this great opportunity. So let's share a screen. I am going to talk about the abstract of computation analysis revealed 5 novel mutations in human interleukin 2 receptors gamma gene related to X-linked severe combined immunodeficiency. These are authors contributed in this paper. The authors declare no conflict of interest. Background: X-linked severe combined immunodeficiency is a rare life-threatening disorder that presents in early infancy with severe recurrent opportunistic infection. The non-classical X-linked SCID has less severe type of disease compatible with life. The classical type has non-functional of interleukin 2 receptors gamma gene, which results in a lack of T and NK and malfunctioning of lymphocytes. While non-classical X-linked severe combined immunodeficiency may have non-synonymous mutations or other potentially non-loss of function, this results in low numbers of T cells while NK and B cells are normal in numbers. The purpose of this study to identify effects of possible pathogenic single nucleotide polymorphisms (SNPs) on structure and functions of interleukin 2 receptors gamma gene as a cause of X-linked severe combined immunodeficiency by using bioinformatics tools. The methods of this study: data on the interleukin 2 receptors gamma gene was gathered from the database SNPs NCBI database. Prediction of damaging effects was done using bioinformatics software such as SIFT, Polyfin, Proven, SNAP2, SNAP and Go, PHD, SNAP, BMute, and iMutant. The effects of the mutations on the 3D structure of the human interleukin 2 receptors gamma gene protein were predicted using RaptorX and visualized by Chimera. This is the workflow of in silico tools for computation analysis of interleukin 2 receptors gamma gene. As I mentioned, information about interleukin 2 receptors gamma gene was gathered from the NCBI database, while protein sequence reference was obtained from Uniport database. Prediction of damaging effect was done by software such as SIFT, Polyfin, Proven, SNAP2, SNAP and Go, PHD, SNAP, BMute, and iMutant, while visualization of the mutations was done by RaptorX Chimera Project Hub. Gene-to-gene interaction was done by GeneMania, while study on the 3UTR done by Polymer database. The results of this study identifying 12 non-synonymous SNPs or mutations, thus significantly alter the structure and function of human interleukin-2 receptors gamma gene protein. 5 of them were identified as novel SNPs, including G305R, C182Y, G114D, Y105C, and Y91C. Moreover, 3UTR region analysis showed 2 SNPs out of 50 were predicted to disrupt messenger RNA binding sites, which affect gene expression. Modeling of mutant structure by Project HOP and Chimera of the novel SNPs of interleukin-2 receptors gamma gene. This picture shows the mutations at Y105C, and this picture shows mutation at the 3182Y, while this picture shows mutation at G114D, and also this picture shows mutation at Y91C, and the last one picture shows mutation at the G305R. This table shows prediction of functional effects of deleterious and damaging non-synonymous SNPs by SIFT, Polyphen 2, Proven, and SNAP2. While this table shows prediction of disease-related and pathological effects of non-synonymous SNP by PhD SNP-Sango and BMute. The last table shows prediction of non-synonymous SNPs impact on protein structure stability by I mutant. This is the gene-to-gene interaction was done by Gene Mania. Conclusion of this study revealed 12 non-synonymous SNPs, 5 of them in the interleukin-2 receptors gene, 5 of them novel in the interleukin-2 receptors gamma gene, 2 SNPs disrupting messenger RNA binding sites in 3UTR region by using different software. These SNPs might be considered as an important factor in causing disease related to the interleukin-2 receptors gamma gene mutations and could be used in the diagnosis of X-linked severe combined immunodeficiency, mainly the non-classical type. I would like to express my acknowledgement to Africa City of Technology, Khartoum, Sudan, for great motivation and cooperation. Dr. Asma Ali Hassan, co-author, Dr. Hari Jassir, co-author, Tibiana Amir Abdel Hamid, co-author, Muhammad Ahmad Saleh is a co-author, Dr. Abdurrahman Hamza for his great support and editing, Dr. Nahla Irwa also for her editing and great support. Thank you.
Health-related quality of life of patients and families with primary immunodeficiency in Malaysia, a cross-sectional study. Introduction. Primary immunodeficiency diseases, PID, are inherited disorders caused by defects in the body's immune system response and function. Prevalence rate of PID in Malaysia is 0.37 per 100,000 population. Health-related quality of life of PID patients in Malaysia is poorly described. The aim of our study is to investigate the quality of life and their associated factors among PID patients and their families in Malaysia. The systematic review demonstrated that health-related quality of life was lowered in PID patients than healthy individuals or other chronic patients, and the emotional domains were the most affected. Home-based subcutaneous immunoglobulin replacement therapy has greatly improved patients' daily activities. Methods. Cross-sectional study was performed from August 2020 to November 2020. The study received approval from Human Research Ethics Committee, USM. Pediatric Quality of Life Inventory Generic Course Scale BCQL version 4.0 was administered in Malay, sent via personal text messaging to patients with PID. Total of 49 PID families have been invited to participate in this study. Data were analyzed using IBM Statistical Package for Social Science SPSS version 25 and Stata SE version 16. Study flow chart: patients and families of confirmed PID diagnosis seen at Pediatric Immunology Clinic, IBPT and HUSM, who are registered members of MyBOBI. Medical records and clinical letters were reviewed with clinical data derived immunological investigations parameters collected. All were invited to answer BCG questionnaire. Data gathered and analyzed using SPSS 25. Results: a total of 41 families and 33 patients with PID answered the questionnaires. Response rate 83.8%. Most of them were male, 31, and receiving immunoglobulin replacement therapy, 28. PID diagnoses were predominantly antibody deficiency, 22, particularly X-linked gamma globulinemia. Mean BCG all of PID patients compared to Malaysian norm. Parents report there is a significant difference in all domains except for the emotional domain. Mean BCG all of PID patients compared to Malaysian norm. Children report there is significant difference in the total score and the school domain. Mean BCG score for ongoing immunoglobulin versus no immunoglobulin. Parent reports there is no significant difference in all domains, but there is an obvious low score for the school functioning for those on ongoing immunoglobulin replacement therapy compared to those with no immunoglobulin replacement therapy. Mean BCG score for ongoing immunoglobulin versus no immunoglobulin. Children report there is no significant difference in all domains. PID families with M40 middle income group reported the lowest total quality of life score compared to those from P40 and T20 background, 58.96 plus minus 13.36 versus 73.48 plus minus 16.46 versus 64.87 plus minus 18.11 respectively, p-value 0.03. Socioeconomic background was found to be predictive risk factors of poorer mean BCG total score reported by parents. Socioeconomic background and ethnic group were the significant predictive risk factors for poorer mean BCG total score reported by PID patients. Discussion. In this study, male accounted for about 2/3 of the patients, 75.6%, as X-linked gamma globulinemia is the most common PID diagnosis in our cohort. Parents of children with PID reported a lower total score of quality of life compared to the parents of normal healthy children. The former also reported a lower total score for all health domains except for emotional, which might indicate difficult parental interpretation for their children's internal feelings. Patients also reported a nearly similar total quality of life score compared to their healthy peers. The only significant difference in self-report was found in school domain when compared to the healthy individuals. Parents of children with IVIG therapy reported low school functioning compared with those of children without IVIG therapy because of the former missed school days for their frequent hospital visits and suffered other health-related problems. Socioeconomic disadvantage was predictive risk factor for poor health-related quality of life. This is because most of the financial supports provided by the government are focused on group P40. Study limitations and future recommendations. One of the limitations of our study was the quantitative nature using a structured self-report questionnaire. The BCG questionnaire was distributed in dual language. This was done to reduce language bias. A future qualitative study would be crucial for dispelling the challenges faced by Malaysian patients with PID and their families. Conclusion: parents and the children with PID, especially those from the middle socioeconomic status, have lower health-related quality of life and school functioning impairment than healthy children. Acknowledgement: we would like to thank participants of this project. We wish to acknowledge University Science Malaysia for the financial and moral support in PID services during the COVID-19 pandemic through the USM 2020 Initiative Project 19. we would like also to announce BCG1 BCG Immunodeficiency Primary Malaysia, BIPOPI, as the partner in our research collaboration. Thank you.
Good morning, everybody. I would like to thank the organizing committee of the ASID Congress for giving me this opportunity to present our work that was presented as an oral abstract. And its title is Inborn Errors of Immunity, Presenting with Invasive Fungal Infections as a Single Center Experience from the Pediatric Allergy and Immunology and Rheumatology Unit of a Children's Hospital and Shams University, Cairo, Egypt. No conflicts of interest. An effective host response against fungal pathogens requires coordinated contribution of both innate and adaptive immunity. Invasive fungal infections constitute a major cause of morbidity and mortality in the immunocompromised host. And we herein describe fungal infections encountered in a group of patients with inborn errors of immunity. Our patients, among 680 patients with inborn errors of immunity, 42 had documented invasive fungal infections, and they were 26 boys and 16 girls with age ranging between 4 months and 13 years. Concerning the underlying immunodeficiency, 40% of the patients had phagocytic disorders. Among those 17 patients, 15 had chronic granulomatous disease, and 24% of the patients had severe combined or combined immunodeficiency. 12% of the patients had underlying immunodysregulation disorders, and 5% of the patients had intrinsic or innate immune defects. Only 2% had predominantly antibody deficiency, while 17% had unclassified or undiagnosed immunodeficiency. Concerning the organs affected by the fungal infections, 52% had mucocutaneous infections, 45% had pulmonary infections, pulmonary aspergillosis, and 19% had bone and joint fungal infections. 17% had intracranial infection with fungi, 10% had hepatic lesions, fungal lesions, and the eye and the intracardiac were the least affected. Aspergillus and Candida species were equally prevalent among the described cases. Each of them was found and documented in 21 patients, followed by pneumocystis jirovecii, and then mucormycosis and exophiala dermatitis in one patient. And here I'm going to show you some of the clinical presentations in our patients. In this one, this girl had a chronic granulomatous disorder with cutaneous fungal granuloma that responded after that to voriconazole. And this is another 2 patients with chronic granulomatous disorder having pulmonary aspergillosis. And this another patient with CGD having a hepatic aspergillus lesion that necessitated surgical intervention due to causing biliary obstruction. And another patient with CGD having, as pointed by the arrow on the left lesion, there was osteomyelitis, fungal osteomyelitis that ended up in a bony defect, as we can see on the picture on the right side. Another patient with a CARD9 defect has cutaneous abscesses with exophiala dermatitis, as shown here in the pictures. And the aspiration of the fungal abscesses revealed the growth of the exophiala dermatitis, as shown on the right side. And here we can see the same patient developing osteomyelitis with significant bony defects, in addition to intracranial lesions that was the cause of the death of this patient. Concerning the antifungal therapy received, amphotericin B was received in around 24 patients among the 42, and voriconazole was received by 31 patients, and posaconazole received by 21.4%, fluconazole in 21.4%, and anidulafungin was limited in availability, so used in 2 patients only, while combined antifungal therapy was required in around 14 patients. However, there was a significant failure in the antifungal therapy in some of our patients. Amphotericin failed in 33%, voriconazole in 35%, posaconazole in 33%, fluconazole in 55%, and idursulfungin failed in one of the 2 patients who received it, and combined antifungal therapy also failed in 35% of our patients, and thus we had a significant mortality rate among the patients, reaching 23 out of 42 patients, which is 54%. We have met several challenges in managing cases with invasive fungal infections, including the delayed diagnosis. There was a significant diagnostic lag before the diagnosis of underlying immune deficiency and diagnosing the presence of fungal infection. So fungal infection disseminated before we can proceed to the hematopoietic stem cell transplantation. The time-consuming fungal culture, the lack of diagnostic laboratory test, and the non-specific radiological picture in several times. 2 large fungal masses that necessitated debulking in our patients, which was needed in 2 of our patients, and difficult to reach fungal infection like those with intracardiac or eyes or bones and brain. Also, there are several factors that are related to the antifungal drugs, including the limited availability, sometimes resulting in interrupted courses of treatment, and the expensive cost for prolonged therapy, whether in the parenteral form or in the oral form. Many drug interaction, especially among chronic granulomatous or severe combined immunodeficiency patients, who usually require to receive the antituberculous treatment together with the antifungal, and the drug interactions might hinder this combination. And the drug side effects, especially hepatotoxicity, was a common problem in our patients. Finally, I would like to deeply thank Professor Raif Jiha and his team in Boston for helping us in the genetic diagnosis of our patients and the interpretation of their data. And also I'd like to thank Professor Casanova and his team for helping us in the diagnosis of some patients. My deep acknowledgement to the Pediatric Allergy, Immunology and Rheumatology Unit founded by Professor Yahya Al-Gamal and helped by all other professors and colleagues. And thanks to all of them. Thank you.
Pediatric Allergy and Immunology Unit, Ain Shams University Center experience in Mendelian susceptibility to Mycobacterium disease. This is Dr. Nisreen Radwan. I'm a lecturer of Pediatrics in Allergy, Immunology, and Rheumatology Unit at Ain Shams University. The objective of my talk is to first identify what is MSMD, then I'm going to share our center experience, and finally, we'll talk when to suspect that your patient coming to your clinic has an MSMD disease. MSMD is a rare group of inherited inborn errors of innate immunity. It has a special predisposition to infection by Mycobacterium organism in an individual who has a normal routine hematological and immunological testing. As outcome is poor, early detection of infection and accurate diagnosis is needed to improve your outcome. The main underlying pathogenesis of the disease is impairment in the production or the response of the gamma interferon. And I'm going to briefly explain to you this figure, where you see that the mycobacterium enters into an antigen-presenting cell, and with the interaction with the DP91, it produces the interferon-stimulating growth factor 15 and interleukin 12p70, where each goes binding to its own receptor in the T or NK cell, and then through the phosphorylation and action of the JAK2 STAT4 TYK, they produce the gamma interferon. This gamma interferon goes binding to its corresponding receptor in the antigen-presenting cell, and then through STAT1 and JAK1, JAK2, they causes the killing of the mycobacterium. So any defect in this pathway will lead to the disease. There have been different genes identified to cause the disease that either in the defect in production or response or both of them. The most common is the interleukin 12 receptor beta 1, and the most widely known is the CYBB that causes the chronic granulomatous disease. They had different patterns of inheritance that could be autosomal recessive, autosomal dominant, and X-linked. The main clinical picture is infection. The most common type of infection is Mycobacterium infection, followed by salmonella, fungal, and viral infection. However, there are some patients who are reported to remain asymptomatic up till adulthood. Treatment Treatment modality depends on the underlying genetic mutation. So if you have an interferon gamma receptor 1 or 2 deficiency, the best is to go for a hematopoietic stem cell transplantation. But if you have an interleukin 12 receptor beta 1 or an interleukin 12 beta deficiency, then it's better to give a prolonged course of antibiotic along with a subcutaneous gamma interferon, a recombinant gamma interferon. However, due to the unavailability of the recombinant gamma interferon in some countries, stem cell transplantation could be the only curative available option for these patients. Interleukin 12 receptor gamma deficiency, it is an autosomal recessive disease. It could be partial or complete defect, and it's the most common type of the MSMD. Based on its level, the clinical phenotype is variable. It ranges from a severe form that may lead to early death in infancy or to an asymptomatic adult. And accordingly, the prognosis is variable. The main clinical picture is infection with the previously reported organisms, and there are some patients who experience non-infectious clinical phenotype as autoimmune manifestations in the form of inflammatory bowel disease, autoimmune hemolytic anemia, vasculitis, others as portal vein thrombosis, and there are some reports that some patients had a positive ANA and some had a low CD4. Then we come to our center's experience. 100 patients were referred to us from the Chest Hospital with disseminated mycobacterium infection following the BCG vaccination at different age group that were not responding to triple antitubercular therapy. They were sent to us to be screened for an underlying inborn errors of immunity. And here we are going to present to you those patients diagnosed with MSMD, apart from those diagnosed with other inborn errors of immunity and CGD. Out of the 100, we had 18 patients suspected to have MSMD based on their clinical and data and normal basic immunological testing. They were 6 males and 12 females. The median age of clinical picture onset was 6.5 months, and the median age of diagnosis was 24 months, and this made a median diagnostic lag of 19 months. 17 out of the 18 patients received the BCG vaccination at birth, part of the routine vaccination program in Egypt. The only patient who did not receive the vaccine had a SIB who died early in life from disseminated mycobacterium infection following the vaccination. 100% of our patients had disseminated mycobacterium infection, 59 experienced disseminated fungal, and 22 experienced disseminated salmonella infection. Other non-infectious clinical picture included encephalitis, autoimmune manifestations, mainly in the form of vasculitis or autoimmune hemolytic anemia, GIT manifestations of diarrhea, vomiting, abdominal distensions, and others, and 2 patients experienced portal vein thrombosis. And these are some pictures that I share for our patient. There is an axillary abscess, baxillotic rash. Finally, we provided to 11 out of the 18 genetic testing, and all of them show to have an interleukin 12 receptor beta 1 mutation. 4 of our patients had a positive family history, and 2 of our patients were given subcutaneous recombinant gamma interferon to control their infection, but this was done for a short course due to unsustained availability and a high cost of the drug. Finally, all our patients come from consanguineous family, mainly from Upper Egypt and mainly from the government Bani Suef, Minya, Asyut, and Sohag. 3 of our patients died out of fulminant infection, and none of them were eligible for transplantation. Here we come to the final part of my presentation. One should think that this patient has an MSMD. You have a patient coming to your clinic with either one of the following infections, as disseminated BCG, other mycobacterium, salmonella, and other intracellular organisms as fungi and virus. Then you screen this patient for his immune system. You find that they have a normal immunoglobulin, normal lymphocyte subset, and normal DHR and nitroblue tetrazolium. Then what should you do? If your center provides genetic facilities, this would be the optimum thing. If not, we could do a flow cytometric assessment for the expression of the interleukin-12 receptor gamma 1, which would be defective in interferon defect and interferon receptor gamma receptor 1 protein. Also, you could use the flow cytometry to assess the phosphorylation of STAT1 in cases of gamma interferon defect and the phosphorylation of STAT4 in cases of interleukin-12 defect. And here comes my take-home message that in our small cohort, interleukin-12 receptor beta-1 mutation was the only elicited mutation. However, we need to do more screening to confirm this finding and determine other possible mutation in Egypt. MSMD has a wide range of clinical picture. Diagnosis of MSMD is quite tricky in countries where no genetic testing and implementation of flow cytometric diagnosis should be started as it's easier and cheaper in our developing countries. And the last thing I would like to do is to acknowledge the Abbas AHS Hospital pediatric team in Cairo, Egypt, and Dr. Casanova and his team in France for providing for us the genetic testing. And finally, the PA team in our university, headed by the former professor, Dr. Yahya Gamal, who formed the first immunology clinic in Egypt and Middle East. Thank you so much.
Bismillahirrahmanirrahim. I'm going to present our work entitled Genotype Phenotype of Mevalonate Kinase Deficiency, a potentially life-threatening disease. This was a study conducted by the team of the Pediatric Allergy, Immunology and Rheumatology Unit in Shams University, Egypt. But first, I would like to thank the scientific committee of the ASID Congress for giving us a chance to present our work. As an introduction to my talk, I would like to give a brief background about the mevalonate kinase deficiency, which is a rare autoinflammatory syndrome caused by mutations in the mevalonate kinase gene. The disease includes a continuum of two phenotypes, what's formerly referred to as hyperimmunoglobulinemia D with periodic fever syndrome, now termed mevalonate kinase deficiency, and mevalonic aciduria. Patients with mevalonate kinase deficiency present with fever, gastrointestinal symptoms, lymphadenopathy, arthralgia, skin rash, and mucosal ulcers. Furthermore, patients with the more severe type mevalonic aciduria can also present with dysmorphic features, prenatal and postnatal growth retardation, as well as neurological and ocular involvement. So understanding the function of the mevalonate kinase enzyme, we have to get a closer look at the mevalonate pathway for cholesterol biosynthesis, where mevalonate kinase works on the mevalonic acid to produce the isoprenoid compounds as intermediate products, and then finally go through the cholesterol biosynthesis. These isoprenoid compounds are very essential for different cellular function, including electron transport, cell proliferation and differentiation, and protein synthesis. So the deficiency of this enzyme is classified according to the level of defect, where markedly reduced enzyme activity is found in patients with mevalonate kinase deficiency, reaching between 1.8 to 28% of the normal level, while almost absent enzyme activity is reported in patients with mevalonic aciduria. So going to the pro-inflammatory state found and characteristic in this disorder, it has recently been identified that serial isoprenoid deficiency leads to the activation of monocytes, macrophages, RHO-A and RAC1 with subsequent interleukin-1 beta hypersecretion and pro-inflammatory cellular biroptosis and apoptosis. In ERO-fever registry, the most frequent combination of mevalonate kinase gene was that causing replacement of valine into isoleucine on protein and isoleucine to threonine heterozygosity occurring in 22% of the patient, followed by homozygosity of the mutation causing replacement of valine to isoleucine in 12% of the patient, and combined heterozygosity for the two mutations had a significantly increased frequency of amyloidosis type AA. However, other rare mutations have been associated with more continuous course of the disease and more severe gastrointestinal and musculoskeletal involvement. So we aimed in our study to evaluate the relationship between the genotype and phenotype of mevalonate kinase deficiency patients. This was conducted at the Pediatric Allergy, Immunology and Rheumatology Unit. It was a retrospective study that included patients who presented with prolonged febrile attacks at very early age, and in whom a diagnosis of mevalonate kinase deficiency was highly suspected. They were genetically tested later on. There were 4 boys and 2 females. Their age at onset has a median of 3 months and ranging between 0.7 to 4 months. Their age at diagnosis has a median of 18 months and ranged between 0.7 to 60 months. They actually presented very late to our unit. Parental consanguinity was positive in 5 patients, and they were all Caucasians, 5 Egyptians, and 1 Syrian. So I would like to demonstrate the clinical characteristics of our studied patients. All patients have continuous course of the disease with exacerbation. They all have fatigue, malaise, and some weight loss that was prominent in the 2 female patients who had severe gastrointestinal involvement. Skin rash in form of urticarial vasculitis was found in all patients, while oral ulcers was present in 50% of the patients. All patients had arthralgia, arthritis, and hepatosplenomegaly and lymphadenopathy. Abdominal pain was the most frequent gastrointestinal involvement in 67% of these patients. So studying the association of mevalonate kinase gene specific mutations to certain clinical features of this disorder and outcome, we started with our first patients who presented at the age of 6 months, but his his age at the onset of his symptoms was at 23 days. His main clinical involvement was arthritis, hepatosplenomegaly, and lymphadenopathy. The detected gene mutation was that causing replacement of histidine into glutamine in protein. This patient had initial good response to anakinra, but shortly he had severe exacerbation ending with macrophage activation syndrome, and sadly he died. His sibling had the same presentation, same age at onset, his symptoms, and same mutation, but he was fortunate enough to diagnose at presentation. And he received anakinra with a very good response. His response to anti-TNF was only partial, and anti-TNF was given in case of lack of availability of the anakinra. The patient achieved remission on anakinra, and he is alive and doing well. Third patient had the same presentation. His age at the onset of his symptoms was 4 months. He presented to us at the age of 1 year. And his mevalonate kinase gene mutation was that causing replacement of the glycine into arginine on protein. Samely, he had very good response to anakinra with partial response to anti-TNF in case of lack of anakinra. He achieved remission on anakinra, and he's alive and doing well. The fourth patient had her symptom at the age of 2 months, but presented to us at the age of 1 year with severe failure to thrive, arthritis, hepatosplenomegaly, lymphadenopathy, and some sort of Crohn's-like picture. She was found to have a mutation causing change of the arginine into stop codon protein. She had no response to anti-TNF and only partial response to anakinra. Sadly, she had severe exacerbation with macroactivation syndrome, and she died. The fifth patient is a female as well, and she has similar yet very milder presentation to patient 4. Her age at the onset of her symptoms was 4 months, and she is the only patient who demonstrated increased immunoglobulin D. She presented to us at the age of 4 years. The genetic mutation was not done. This patient has a very good response to anakinra, and after stoppage of anakinra due to a lack of availability at some time, she was shifted to anti-TNF with a very good response, and she is the only patient who achieved remission on and was able to stop the treatment. She's alive and doing well. The sixth patient had onset of his symptoms at the age of 4 months as well. He had a history of sibling deaths of similar condition of 4 siblings, and he had arthritis, abdominal pain, chronic diarrhea, hepatosplenomegaly, and lymphadenopathy. The genetic sequence revealed no mutation, and he had a very good response to anakinra. This patient presented to us at the age of 5 years, and he achieved only remission on anakinra. He did not respond whatsoever to anti-TNF or anti-IL-6. He's alive and doing well. So in conclusion, diagnosis of the studied patient was based mainly on the clinical features suggestive of mevalonate kinase deficiency. Measurements of immunoglobulin D is expensive and at the same time infrequently elevated. So we cannot rely on it for diagnosis of mevalonate kinase deficiency. Measurement of mevalonic acid during febrile episode should be implemented in suspected patients to have mevalonate kinase deficiency in the future. This might help early diagnosis and allow starting the target therapy. Studying the genotype of the patients and its association with the clinical spectrum of the disease will help to adjust the treatment protocol to avoid life-threatening complications and unfavorable outcome. I come to the end of my lecture, and I would like to acknowledge the team of the Pediatric Allergy, Immunology, and Rheumatology unit that was founded by our late mentor, Professor Yahya Al-Gamal, who is really missed. And special thanks to Professor Raif Jiha and Dr. Janet Cho and all the team for performing genetic sequencing for patient number 3 and number 4. And thank you so much.
Okay, thank you everyone. This was a really interesting presentations, and I know that the section was not so easy because we had really good abstracts. So I invite everyone to look at the e-posters. So we have one question for Dr. Weida. From Bonsom, does the Malaysian government have a specific program to support PIDs patients, and does the patient have a formal organization? Is Dr. Weida on? No, Apparently she's not okay. Apparently she's not with us. So it's a good question. As I understood in the presentation, they do have a patient organization that is MyPOPI. Regarding the first part of the question, I can answer for her. So we'll leave it like that.
There is another question. Yes.
Yes.
Rayan Goda asked, what is the exact capacity in Egypt to be a reference center for genetic and molecular diagnosis in Africa? Are the tests done locally or mostly shipped abroad?
So is any of the Egyptian speaker can answer to that?
Hi, hello, Leila.
Hi. Hello, Nesrin.
Hi. Okay. We do have. We're starting to have our laboratory testing for genetics. We have now the Cairo University. They started doing the WAS sequencing, and also in Children's Cancer Hospital, they are trying to implement the immune deficiency gene panel for diagnosis of patients presenting with malignancy and have a suspect of immune deficiency. So we are starting. I cannot say that we are doing the best, but till now we still send our most of our samples abroad to be analyzed.
Thank you for the answer.
Okay, thank you.
Yeah.
Okay.
Yes, yes.
Okay, if there is no more question, I guess we can. Okay.
Yes.
Okay, sorry. So we wrap up the session. Thank you for all oral presenters. It was really interesting, as I said. Rashida, do you have a final word?
No, I think I just want to tell again that this Congress is very well organized. We had so many presentations, very important for us because we can see how much we are just going forward with PIDs in Africa, and I think this way of sharing our knowledge and experiences is very nice. And we had yesterday and today very fantastic presentation. I would like to again thank all the organizer and the ASID board.
Thank you. Thank you. So let's
is it the morning? It is the morning actually here in Sudan. Good morning, good afternoon, good evening to those who are with us in other zones. I am really excited today to be here with you in this joint session that brings us together in the African Society for Immunodeficiency and the International Nurses Group for Immunodeficiency and the International Patient Group for patients with primary immunodeficiency on this exciting venue to talk about IVIG practicalities from very experienced people. I would like to introduce Anne now to tell us a little bit about what's happening ahead of us. Thank you.
We want to thank the organizers of the ASID 2021 conference for giving us the opportunity to share some of our knowledge and experiences with you. All three of us are members of the International Nursing Group for Immunodeficiencies, INGID. My name is Anne Gardulf, and I will present a summary of the history of the use of immunoglobulins. My colleagues, Sarita Workmann and Gabriele Strotmann, will then share their experiences of administration of immunoglobulins to adults and to children. The history of our use of immunoglobulin starts already at the end of the 1890s. That is about 120 years ago, when immunoglobulins were used as immunotherapy to cure patients that had serious bacterial infections. 60 years later, we learned how to use immunoglobulins for replacement therapy, and another 30 years later, immunoglobulins were found to be of great help to many patients with autoimmune diseases, what we call immune modulating therapy. Already in 1894, Emil von Behring cured a diphtheria patient with serum from animals previously immunized to diphtheria. Horses were often used as they have a large volume of blood. During the 1930s, methods to extract antibodies from the placenta were developed. So for the first time, we had access to human antibodies. The true story of replacement therapy starts with the Second World War. The United States were fighting on two fronts, and the need for blood for wounded soldiers was enormous. The US National Research Council asked the biochemist Dr. Edwin Cohen to identify a stable blood derivate or substitute, and the American Red Cross began collecting blood. And here you can see nurses doing so. Dr. Cohn set up a method to fractionate the proteins in the blood, and in 1941, he received a grant of $10,000 for large-scale production of albumin. The albumin could be freeze-dried and used as blood substitute in the field. He also found that by fractionating the proteins in human blood, immunoglobulins could be identified and used. The American pediatrician, Dr. Ogden Bruton, identified for the first time that humans may have an antibody deficiency. Dr. Bruton gave the 4-year-old and very sick boy regular subcutaneous injections with immunoglobulins. He could show that the gamma fraction raised and that the boy's health significantly improved. The results were published in 1952 and is the starting point of all the knowledge we have today about replacement therapy in primary and secondary immunodeficiencies. We can look at the history of replacement therapy using a timeline. As mentioned, the original way to give immunoglobulins is by subcutaneous administration, which is very interesting. However, soon after 1952, there was a shift to use intramuscular injections, unknown why. Intravenous preparations were developed already during the 1960s, but gave rise to very severe side effects. It was not until 1980 that the first commercial product was launched, and since then, this is a well-known method. At exactly the same time point, there were a few publications about very slow subcutaneous infusions, 1 to 3 milliliter per hour. Of this reason, this administration method never became widely used. In the mid-80s, I developed a method of rapid subcutaneous infusions to adults and to teenagers, and in 1991, the first results were published. The method quickly became very widespread, and it was also used then to small children. In the article from 1991, the concept of subcutaneous self-infusions at home was presented based on a structured education and learning program for the patients. We have since then seen a paradigm shift towards self-treatments at home and increased patient and parent empowerment. We have also seen a significant improved health-related quality of life for patients, parents, and children with the possibility to self-infuse at home. A few years later, we could demonstrate that the infusions could be given much faster without any increased local reactions, and we call the method express infusions. In 2010, Dr. Shapiro published the first article about rapid, or as you also can say, manual push, where the hand is used instead of a syringe driver. The latest development is the use of facilitated subcutaneous infusions, making it possible to infuse very large volumes of immunoglobulins. So, to summarize, we have the possibility to use two different administration routes: subcutaneous administration and intravenous administration. And when using the subcutaneous administration, we can use a syringe driver to push, we can use the hand to push, or we can use the method of facilitated subcutaneous infusions of immunoglobulins. Now it is exciting to see what new methods and uses we will learn about in the future. Thank you very much for taking the time and sharing it with me. Now I'm very happy and proud to hand over to my colleague, Sarita Workmann from London, UK.
So thank you, Anne, and thank you, ASID, for inviting INGID to present at this conference. My name is Sarita Workmann. I'm a senior clinical research nurse and a clinical nurse specialist at the Royal Free London NHS Foundation Trust in the UK. And I will be talking about immunoglobulin therapy in PID, practicalities and the pitfalls from a UK adult perspective. So, immunoglobulin treatment. Every patient is an individual and will have different levels of prior experience and understanding. This is an important factor when considering immunoglobulin treatment. We use a stepwise approach to determine the best treatment for our patients. So basically that means some patients may start on subcutaneous immunoglobulins. And actually they'll decide halfway through their training, actually, they don't want to do this. They would actually rather have IV. So this is why we do a stepwise approach, and it's a bit of trial and error until we find the right treatment and the right method for our patients. So we need to look at why we are giving the treatment in the first place. We are giving it to reduce infections, optimize IgG levels, and to improve our patients' quality of life. There are various considerations that we need to think about before commencing immunoglobulins. From a clinical perspective, we need to think about the thromboembolic risk, renal failure, hemolysis, potential reactions such as anaphylaxis, aseptic meningitis, and hypersensitivity. We also need to consider venous access, especially for IV patients, and also manual dexterity, especially for our push patients. So practicalities. We need to think about practical and real life scenarios. Most importantly, we need to think about our safety of our patients. We need to look at their work-life balance. Are they really busy and have a hectic life, and so it may be difficult for them to infuse? The work-life balance also means that some patients won't be able to come in for infusions. They definitely want to go to home therapy straight away as soon as possible. We also need to look at their home environment. Do they have lots of animals, or do they have children running around as distractions? We also need to look at their ability to learn and the potential for them to self-administer infusions at home, and if it will be safe. For IV infusions, do they have an infusion partner? We also have to look at the ability of the infusion partner, but also their relationship. Some patients do not want to have infusions at home because they do not want to have a corner with all the ancillaries that they are required to have. And it's a constant reminder that they have a primary immunodeficiency. Some patients don't want their husbands or their wives to infuse them. Sometimes they would like somebody different. Maybe they have a friend, or maybe a mother, or something like that. So it's the family dynamics we also need to look at. Flexibility of treatment. I think this is an important consideration in this day and age. We need to be flexible with our treatments, and people do have busy lives, and so therefore it needs to be flexible, and they need to be able to work their treatments around their lives. Compliance. If patients are happy with their method of administration, they generally are more compliant. If they are unhappy and they don't like doing it, then they become less compliant. They also have fears. They also have fears of responsibility of administering their own medications at home. And this responsibility can be quite big on some patients, and they just don't want to do it. They also may have phobias that they may have to deal with, such as having needle phobias, and they may have to overcome these to enable them to do home therapy. And also they may have had previous experiences, good or bad, doing home therapy. And this is also something that we need to consider when we're looking at doing home therapy or hospital therapy. Pitfalls. Availability. We in the UK are very lucky, and that we have immunoglobulins available to us to administer to our patients. However, we are also aware that some countries don't even have that. And so we are very lucky that we do have the availability of products. cost. We all know that immunoglobulins are expensive, and who's going to fund these? Who's going to pay for these? You know, is it private healthcare? In the UK, we have the NHS, but other countries have different sources of funding. Also, the resources. Some hospitals don't have infusion centres, so they have no choice but to infuse at home. Choice of products. As I say, in the UK, we are very lucky and we have a lot of the IV products and the subcut products to choose from, but many countries won't have that choice. Also, some hospitals may only have one or two brands that they can use. And especially at local hospitals where they don't give immunoglobulins on a regular basis, some hospitals may only have one product, and this is something that we need to consider. As I say, the choice of administration in the UK, we have IVIG, intravenous method, we have SCIG, which is the subcutaneous method. We also have facilitated SCIG, again, a subcutaneous method. So methods, intravenous, IV. So we can have that at the treating hospital, such as the Royal Free. This would be administered by the nurse. Some of our patients live a distance away, so they choose to have their infusions at a local hospital, and we arrange this for them to do this. So they are able to do this. We also train our patients to do IV at home with an infusion partner. And we are introducing having nurses coming into patients at their home, which I will also expand on a bit later. So IVIG is given every 3 to 4 weeks. However, due to COVID changes, some of our patients have now extended this and have a higher dose every 5 or every 6 weeks, so it reduces the amounts of time that they attend hospital. This will usually take anywhere between 2 and 5 hours, depending on the dose. At the Royal Free, we use a drip rate, but at other hospitals, they use a pump to regulate the flow of the immunoglobulins. And as I mentioned earlier, we insist that our patients have an infusion partner, as it is going straight into the vein. So methods, subcutaneous. Here we have some pictures. So one is of the push, which is basically a syringe attached to a butterfly needle, and then the patient will just push the infusion through. There's also the pump method. Again, this is attached to it. The immunoglobulins are drawn up and then they are attached to a pump and they are given over a period of time. And then you also have the facilitated at the bottom there. And as I say, some of the patients will give the push daily, but I will also expand on this a bit later. Some of the patients for the pump will be weekly, and they are both given at home. Facilitated is every 3 to 4 weeks, and this can be given either at a hospital or at home, but these can all be self-administered and not necessarily with an infusion partner. Methods, subcutaneous. There's the push method, as I mentioned earlier. This can be daily depending on the dose. We usually recommend 10 to 20 mL per site as tolerated. We prefer 10 ml syringes, so even if a patient would like to have 20 ml in a site, they will prepare 2 10 ml syringes, and then they will administer the first syringe, disconnect, then connect the second syringe, and then do the next 10 ml syringe. This is because we have actually found that patients trying to push a 20 ml syringe is actually a lot harder, and patients have struggled with this. So therefore, that's why we use the 10 ml syringes. This will take 5 to 20 minutes in total, and some patients may have 30 mils a week, so they may choose to do it on a Monday, Wednesday, Friday. Some patients may have 60 mils a week, so they might do 20 mils on a Monday, 20 mils on a Wednesday, 20 mils on a Friday. Some patients decide to do 50 mils a week, and they will do 10 mils a day, Monday to Friday. So this is very flexible and it's very easy. The pump method, as I've mentioned, is weekly. We are lucky that we have various pump sizes and various syringe sizes. For example, a patient may be on 30 mils a week, and what they will do is they will have a 50 mil syringe. So they can get 30 mils in that, and then they may administer this over 2 sites. Some people may have 60 mils a week, so therefore they would use the 100 mil syringe, and they may decide to do this over 3 sites or 4 sites. And we are lucky that we have the needles that can allow them to do this. This approximately takes 1 hour. And then we have the facilitated, which is given every 3 to 4 weeks. These are large doses. And what will happen is at the beginning of the infusion, first the hyaluronidase will be infused, normally by a push method over a period of time, and then the infusions then the immunoglobulins will be administered, usually via a pump, and this will take 1 to 3 hours, maybe a bit longer. It really depends on how well the patient tolerates this, but also how much they are actually having. So the training program for home therapy at the Royal Free Hospital. So usually we would say for IV home therapy, we would say 6 infusions, and that's with or without their infusion partner. As I mentioned, some infusion partners will actually put in the needle, but some of our patients will do the whole infusion by themselves, and they will just have the infusion partner just in case. And generally speaking, what would happen is on the first infusion, we would demonstrate and very slowly and go step by step what we are doing, explaining every action that we do to the patient. Then on the second infusion, we would ask the patients to prepare the infusion, and then we would put in the needles. And then on the third infusions, they may put in the needles themselves or their infusion partner would. And then by the 6th infusion, generally speaking, they don't need us at all. Obviously, we are observing them and we are assessing them all the time. Some patients may take 8 infusions. Some patients may take 5 infusions to learn it until we assess that they are competent. That's what we would usually do. For subcut infusions via the pump, we would usually say 4 to 6 infusions. This is slightly longer than other centres in the UK. However, we are not able to do home visits for their first infusions, which is why we actually do a couple more infusions just to make sure. And for the push method, we would normally say maybe 2 sessions, and we would do several injections at both of those sessions. Facilitated infusions, again, it would be about 2 to 5 infusions, because also you're using the pump and you're using the push method, so they need a little bit longer sometimes than just a push sort of method. So, however, in recent COVID times, IV home therapy, although it's still ongoing for our existing patients, we haven't really started any new patients on IV home therapy. We've only started a couple of patients, and they've actually come in for 3 or 4 infusions rather than the usual 6. For subcut patients, again, we have reduced the infusion training sessions for the pump to 1 to 2 infusions rather than 4 to 6. And for the push, it's been done in 1 session. And sometimes what we have actually done with the push is that we have administered the IV infusion at a slightly lesser dose, and then we have made up the rest of the infusion by the push method. And so patients have had their sort of last IV and their first push at the same time. For facilitated, we've sort of reduced this to 2 to 4 infusions. And what we do now, which is something that we didn't do before, is we do video sessions for the first maybe 1 or 2 sessions at home, therefore giving support to the patients, especially if they've only done 1 or 2 infusions with us. We have found that actually us doing a video call with them and watching what they're doing and making sure that they do it all right, they've been a lot happier with this. And also because we're doing a lot more video calls with our patients for their clinic appointments, they are actually quite used to it, and actually they quite like it, and they know that if they're ever having problems, they can make an appointment with us and we can watch what they're doing and see if something's going wrong or not. So we've also now are in the process of having a different approach, something to consider. So we know that IV infusions at home are safe with a patient and with an infusion partner. However, there is a big push in the UK to have home therapy, which is the way forward. And so what we have done, we have arranged with the home company for nurses, we have arranged with the home therapy company for nurses to infuse patients at home that do not wish to attend hospital or to infuse themselves or with a partner. So basically what happens is there's sort of different levels that we're offering. So some patients are actually quite happy to prepare their infusion, monitor their own drip rates, but they can't put the needle in. So what we have done is we are arranging for nurses to be able to go around and insert the needle. And as long as the patient does have an infusion partner with them, we are quite happy that the nurse can then leave them. And then what they will do is then they administer the infusion, and then the patients will take out their own needles. If needed, the nurse can come back. The nurses make sure that they are sort of in the area. So if something was to happen, then they can come back quite quickly. There are also an option for a nurse to actually do the whole infusion and actually stay with the patient throughout. This, of course, is an additional cost. And what we are looking at and we are researching is how cost effective this is. And I think on balance, it sort of is, it is cost effective, because otherwise the patients would be coming to hospital, and you've got to think of their travel time and then the time that they're in the hospital for. So it sort of balances itself out. But there are there's several arguments for and against. But it's something that we are introducing, especially in this time when patients really don't want to come for infusions to a hospital. Thank you for inviting INGID to present at this meeting and for taking the time to listen. I hope you have found this interesting. Please do ask us questions at the end of our presentations. I would just like to acknowledge Emily Khan and Andrew Symes for assistance with my presentation. I would like to introduce Gabby Strotmann, who will be presenting the paediatric point of view in Germany. Thank you.
Dear attendants, I'm delighted to talk to you today at the 7th ASID Congress about the practical aspects of subcutaneous immunoglobulin replacement therapy in pediatric care in Germany. Thank you very much for the invitation. I hope you will enjoy my presentation, and I'm quite happy to answer your questions afterwards. The minor indications for immunoglobulin administration are severe combined immunodeficiency, combined immunodeficiency, agamma-globulinemia, hypogamma-globulinemia, hyper-IgM syndrome, hyper-IgE syndrome, IgG subclass deficiency, common variable immunodeficiency, other PID with antibody deficiency, and secondary immunodeficiency. There are 3 different ways to applicate the IgG. Since 1980s, we are only using intravenous, and since 1994, we are using intravenous and subcutaneous. Immunoglobulin preparation goes on like follows. There are about 5,000 human donors. The plasma gets collected in the collection center, then it gets fractionated into different IgG, albumin, and clotting factors. It runs through different viral inactivation steps and variable filtering steps. There are 3 routes to administer IgG. We have the intravenous immunoglobulin administration based in the hospital. We have, that's why I put it in bracket, general practitioner based on intravenous. It's not really common here in Germany. And in Germany as well, home-based intravenous immunoglobulin is not administered due to home care service. What we are doing is hospital-based subcutaneous immunoglobulin therapy, but we are going to train the patients quite early so that they can do it at home. Sometimes we have children who go to a general practitioner who is doing the subcutaneous immunoglobulin, and but normally it is home-based parents and patients doing it on themselves. Which routes are we choosing? What is the preference? And we have children with a very bad vein status. There we prefer the subcutaneous immunoglobulin. We have children with systemic reactions. There we also choose subcutaneous, and we have, of course, the request of patients and parents, or also the request in our medical team to do it, to put patients on subcutaneous immunoglobulin. For the IgG therapy, subcutaneous has a lower incidence of serious adverse effects compared to intravenous immunoglobulin. It is as well efficient, and we have a really good trough level. The quality of life for the patients increased, and the patient's preference is really high. Numerous of studies have demonstrated the acceptability of subcutaneous immunoglobulin as well as the improvements. Subcutaneous at home is very well tolerated. It has an easy handling. It is cost effective. It is frequency given. You can give it daily, weekly, 2 weekly, or with facilitated subcutaneous immunoglobulin, you can have it 3 to 4 weekly. You can do it via a pump or also with manual push. We are in Germany, we are only using a pump. We are not doing manual push with the children. So how we are doing the setting for the immunoglobulin administration when the child got IgG before intravenous, then we start about 14 days after the treatment. And if the child has never had immunoglobulin before and has a really low IgG level, then we are filling up the empty reservoir with 2 or 3 times intravenous. Or we also do it sometimes that we give subcutaneous immunoglobulin during the first week for 2 or 3 times to get a good IgG level. The training in our unit goes on like follows. We train the patients, the parents, relatives, girl or boyfriends. They need at least 3 dates, but if they are not really sure, they can also have more dates. We have no age restriction. The youngest one was 6 months, and the oldest one actually was 81 years old. Sometimes we also have adults who are doing a training in our unit. We have 2 specialized experienced nurses. We explain and demonstrate the correct technique for administration. We explain the storage and the temperature of the IgG. We show them how to prepare the infusion. We do a pump instruction that is caused by the medical product line law in Germany. We show them how to prick themselves, and they get a diary where they can put the batch numbers and also write if there's something is wrong. Then we also show them how to dispose the waste. The infusion sites we are using in children are normally the abdomen and the thighs. We recommend the rotation of the sites, but that's sometimes up to the children what they prefer. The speed depends on the age and the size of the child. The slow speed is about 10 to 20 mils per site per hour. Normal speed is 25 to 30 mils per site per hour. And the fast speed is 40 to 50 mils per site per hour. But I put this fast speed in brackets because now in the last years, we have seen older children who are having subcutaneous quite for a long time. They get a really sort of a skin hardening, sort of granuloma-like, and that is better if they are not doing it so fast. The volume, when the child is under 20 kilograms, we can put 10 milliliters in each side after, lower than, can you skip this? This kit volume. If the child is under 20 kilograms, we can put 10 milliliters into one side. If it's under 40 kilograms, we can put up to 15 to 20 milliliters into one side. And if the child is more than 50 kilograms, you can put up to 30 milliliters in one side. The side effects are really mild or no side effects at all. Here you can see 3 of our children with no or very mild local skin reactions. We are using different pumps and supplies, depends on the healthcare systems, because they vary between different healthcare plans due to the numerous of difficult insurance companies we have in Germany. So we have different pumps in use, we have different tubing sets, we have B3 cut-focated attached to a single trunk connected to the syring. We have different needle sets from 24 to 27 gauge and 6, 9, 12 or 14 millimeters lengths. They all have plastic wings or a clear plastic disc. The needle length depends. If you use a shorter needle for young children and lean BMI patients, that increase the leaking of IgG and stops the irritating at the infusion site. The pros from subcutaneous immunoglobulin is the good tolerability. You have an increased and stable IgG level. It's a good alternative to intravenous. It has the same effectiveness. It is cost efficient. It's a simple handling. The quality of life for the children improved. and we have less or no adverse events. It's a home therapy. It prevents many bacterial and viral infections, and it makes the family and the children independent. Where you have a pro, there's always a contra. Of course, you have to do frequent injections. You have shorter intervals than under intravenous. You have to infuse yourself. Maybe you see local skin reactions. You have a permanent confrontation with the disease. You have a rare doctor-patient contact that is maybe good for the patient, but not really for us. And there's a surplus load for the family system because they have to think of everything, and this disease is always there. Patient training is aimed at reinforcing the patients and their families in order to manage their own problems, which raise the disease in everyday life, independently and consciously. So what are the patient issues? What are they asking us while we are doing the training? They ask for adverse effects. They ask what are we doing on holidays or on journeys, or if we want time off our treatment. Do we need a vaccination? Are we now a severe disability child? Do we have another choice? Can we do something else? Will there ever be a healing? Will this subcutaneous treatment, will this be forever? And we are trying to support the patients, the children, the families. We are strengthening the self-confidence, and we support them. We support the family where we give them emotional support, and also if they want support for a day nursery, kindergarten or school, we help them. Or if they want to let the other people know what their diagnosis is and why they need this treatment, we are also trying to support them. If you would like more information, you can always look at the website from the IPOPI, that's the International Patient Organization, or the ASID, the European Society for Immunodeficiency, or at our site, the International Nursing Group for Immunodeficiency. So thank you for your attention. Please, if you have any questions, I am very happy to answer them. Thank you very much.
Okay, so I am Martine Perjean from the International Patient Organization for Primary Immunodeficiency, and I would like to address a heartfelt thank you to INGID for those presentations, because I think that we have broad and deep idea on IgG therapy, which is very useful because this addresses many of our patients, most of them, in fact. That said, I would like to ask you how to consider the fact that in the world currently we lack immunoglobulins, and especially and in every country in the world there are tension and even shortages, and of course in Africa many countries don't access at all this therapy, this vital therapy. So how to deal with that? Would you have any advice on that? And of course, I'm aware it's a very tricky question and a very global one, but I think this is something that we need to address when it comes to Africa, because the access to this therapy is really, really a problem. I don't know if you have any insight on that, or...
Who wants to go first? Do you want me to start? I can say what we're doing in the UK. So in the UK, well, at our hospital at the Royal Free, we have actually been streamlining some of our treatments. And how we've been doing this is we've been looking at patients' immunoglobulin levels, and we have been looking at their doses. And so if they've actually, we like to maintain our IgG levels at 8. For some of our patients, like the XLA patients, we keep them slightly higher and at 10, for example. But what we've been doing, so if some of the patients, like a CVID patient that doesn't have any infections, and they've got an immunoglobulin, an IgG of 10, and say they are on, I don't know, 30 grams every 3 weeks, we may have reduced this, say, to 25 grams every 3 weeks. And as long as their immunoglobulin, their trough level, their IgG level stays above 8, and they don't have any, more infections than they would usually do. So we've just been reducing some people's doses just a little bit. And as long as they're still, as I say, their immunoglobulins are above 8 and they are sort of infection free to as best they can be, then yes, that's what we've been doing. So we've been streamlining some of our patients. And most patients have been happy with this, to be fair. And they've said, oh, it takes me less time to do my infusion. So yeah. So, and even if it is by 5 grams, every month or something, if you work that out over a year, that could potentially be half of somebody else's dose, if that makes sense. We have also had to swap some of our patients to different products because of availability.
Thank you, Sarah. Indu?
Every month or something, if you work that out over a year.
Yeah, we can see that there is a question in a patient on SCIG who develops a cutaneous ulcer at the site of injection despite changing the needle size goal from 26 to 24. What would you suggest?
As mentioned by Mrs. Strotmann, the needle length is very important, and a very common thing that you can see when there is a problem is that the needle is actually too short. And that may sound a bit strange because, you want to be kind to your patients and use a very small needle, but that might cause local site reactions and problems. So what you have to look at is the size of the needle, as you mentioned here, it had been done, but also the needle length, maybe a bit longer, like 2 mm longer needle. That may sound a bit strange because, you want to be kind.
Thank you, and I think it's a very good advice. And I'd like to hear from Dr. Indu and Dr. Mahlaoui about your experience on that and the question you may have when it comes to access to the product, but also to the device.
Okay. Thank you, Martin. Good morning, everybody. I am Dr. Indu Demdi. I am a pediatrician in Children's Hospital in Dakar, and I am also an assistant professor in the University of Cheikh Anta Diop. Thank you to ASID and to INGID's team for your nice presentation. Thank you to IPOPI, Aisha, Martin, for all you do in PID, particularly in PID children. And I have a question for the use of the immunoglobulin in children generally, because I understand about the presentation, they move from intravenous to subcutaneous for habits because it is easier to use, but in our countries, we don't have habits of immunoglobulin. Immunoglobulin are not available, and sometimes with the cost, parents cannot have it. And it is a very problem in our countries. We have some patients who need immunoglobulin, but it is difficult to have it. And I don't know how to do or what to do to have it, because we have to improve the quality of life of these patients. We have children, very young children who carry complication of PID because of lack of immunoglobulin. When young children develop bronchiectasis or recurrent infection, it is a problem. And I want to talk about it to advocates and to ask to you how to do to help these patients. Please. Thank you very much.
Thank you.
Yeah, that of course is a huge problem. Whew.
This is African problem in many countries. Many countries. And I think that, well, we would like, and this is pretty complicated, but we can see some kind of first signs that it will go. We need to improve blood and plasma collection. This is the very beginning of that, because this is the only way to provide more plasma that goes to fractionation. And this is the first goal. And I think that all together we should advocate on that more and more, so that countries like some in Africa and some in Asia and even in Europe can access this treatment.
Yeah.
And Latin America, I'm forgotten, but this is also the case. This is a huge problem.
Yes.
Dr. Nahla?
Yes, I mean, I was just thinking about home therapy for patients within African setting. We are not supported as well supported with specialized or specialist nurses as the advanced world, but we tend to do most of the work ourselves, so there will be lots of issues. This was something that we needed to do, we were forced to do with some of our patients actually abruptly during the COVID pandemic, and we had to issue them with instruction manuals and make use of local kind of locally available nurses within health centers. It worked for the adults, but obviously I mean for the children, they had to come home. And we have the other difficulty, as Indu said, the shortages. So unfortunately, we did lose quite a few patients of the children. We've lost at least 4 children during the last cut of supply. We do all need to work on, the equity in treatment for all patients, I think. And as Martin said, we really need to advocate for the mini pooling and all the increasing plasma donations and that. So I think this is a venue where we can agree on that and perhaps take it forward. That's what that's what I felt I needed to get out of my chest at this point in time. Thank you. Yeah, thank you.
I think this issue about the lack of immunoglobulins in certain countries is is a problem that we, within the PID Society, we have discussed this for 20, 25 years. And of course, we don't have the answer to the problems. I absolutely agree in that we have to talk about how can we support the blood centers and how to collect blood, etc. I have also worked with the WHO, and I know this is also something that they have highlighted and that they are looking into more and more. So I think some sort of joint activity with the WHO, with the physician organizations, with INGID and IPOPI, I think that could be one way, at least, forward to bring up this, to increase awareness of the problem. Yeah. We have to start somewhere.
Yes, I think we've just been told to move on. You can see a message there. Okay.
Thank you very much to all.
Yeah, I think we can carry on email and get engaged in another session for this. But thank you very much. We really are appreciating your attendance with us. On Martin, sorry about that.
Thank you.
Okay. Okay, thank you. Thank you very much for giving me the floor. I think we have just a new session today. I would like just to congratulate first INGID for this very good, very well done, very well organization, to Nahla, to all groups, because it is very difficult to organize it, because it is a hybrid session. And so thank you very much for IPOPI also to be here to organize session, because IPOPI has a lot African PIDs patient for a long time. So I think we are very happy to have you all in this session, in this IPOPI patient session. So thank you very much. I think we have some discussion today. I think the first one is just to discuss about stigma. It asked me to give you call by stigma. I think I don't know if you have to send some slides or not. Is it true? Is it okay for us, for all? At how many times I think we have two speakers now. I didn't this session. I would like just to highlight some. Let me go to the screen. Okay. Okay. So I would just to talk very briefly about PID cases of stigma. So stigma is a very it's a very big issue for all PIDs. I think for us in Senegal, we don't have many stigma for our PIDs right now. I don't know why. I think it is why it's very important to discuss with all people to know more about experiences coming from several countries about PID stigma cases. So it's very important to learn more about that. We know more about stigma on all. Is it okay? Exactly. Okay. Sorry. Okay. Because this is a technical issue sometimes, but it's very challenging for us just to yes to share our experiences using this technology. So I think it is why I congratulate a lot ASID to organize it, because you need to be very tough to organize this kind of congress, hybrid congress. So I'm just talking about the PID cases. In my country, we don't have many PID stigma cases in our country. I don't know why. Maybe you can have it in other countries, or we have just a few number of PIDs in our country. So I just would like just to share this young boy. This young boy is 8 years, born after two lost siblings. So we have a very strong growth retardations. So a frequent dermatosis. Dermatosis was a very big issue for this country because we got a Wilcott-Aldrich syndrome. So because the dermatosis are on the skin, this student avoid being with him, but he doesn't not present any risk of contamination. But nobody want to be around. It was a very big issue for a young boy, for this boy. And other thing is very important to highlight is just he start going to school after 7 years old.
Please, Professor Tandakha, please, can you be short, because it was not in the program, so we have not enough time. So you can take 2 minutes, please. Merci. Thank you.
What do you say?
Please end in 2 minutes, because we have not enough time. Please end in 2 minutes.
I stopped this presentation. You did.
Yes, in 2 minutes.
Okay.
Good day. I would firstly like to thank the organizers for the opportunity to speak at this conference. I was given this question to address relating to the PIDs and HIV infection. Before I answer the question, I'd like to take you through a series of slides in which I compare the two conditions. Firstly, I have nothing to disclose. I have no conflicts of interest. The history of HIV and PID has followed different trajectories. The first clinical description of HIV occurred between October 1980 and May 1981 and culminated in a publication describing a case series of patients with pneumocystis carinii and pneumonia, and these patients were all homosexual males. The causative agent, HIV, was identified in 1983. Phylogenetic analysis has revealed that HIV originated from simian immunodeficiency viruses in West and Central Africa as a result of several cross-species transmission events from non-human primate species to humans. This applies to both HIV-1 and HIV-2 infections. Furthermore, it is estimated that the first such species transmissions for HIV-1 occurred as early as 1853. And for HIV-2, cross-species transfer happened in the first half of the 20th century. With respect to the PID, the first description of agammaglobulinemia in 1952 by Bruton is considered to be the birth of PID. However, review of the medical literature shows that there are several clinical descriptions of other PIDs preceding this event, going back as far as 1922. The first systematic classification of PID occurred under the auspices of the WHO in 1971, and the recent systematic classification in 2019 included a change in the name from PID to inborn errors of the immunity, and in so doing acknowledging the etiology of the PIDs to be largely genetic or chromosomal in basis. The epidemiology of HIV is well studied as a result of HIV diagnosis being widely available throughout the world, including in all countries of sub-Saharan Africa. And as a consequence, we now know that the epicenter of the global HIV pandemic is in fact Southern Africa. Less is known about the epidemiology of HIV-2 infection, but we do know the countries that have reported cases as depicted in the slide. Furthermore, we know that most cases are still confined to countries of West Africa, where the original cross-species transmission from non-human primate to human beings occurred. Much less is known about the epidemiology of PID because of diagnostic limitations in many parts of sub-Saharan Africa. But what we do know is that the incidence of PIDs is probably highest in the North African countries. And here, certainly from large registries, we do have a clear understanding of the spectrum of PIDs that occur in these countries. To a lesser extent, we have some of that knowledge in South Africa about the spectrum of PIDs in South Africa. With respect to the disease spectrum, it's rather limited for HIV, with infection caused by 2 different viruses, HIV-1 and HIV-2, and giving you a similar clinical spectrum of disease. In addition, more recently, HIV-exposed but uninfected infants have been recognized as a separate entity with specific clinical risks attached to it, as well as immunological studies that have shown disturbances in aspects of the immune function of these children. By contrast, PID is a large group of diseases spread over 10 categories, which cover both immunodeficiencies as well as diseases of immune dysregulation. Let's for a moment explore the concepts of PID and secondary immune deficiency. Primary immunodeficiency, as I've already said, are inherited disorders affecting the development and or function of the immune system. Whereas secondary immune deficiencies occur usually in an intact immune system, and the etiological agent for the secondary immune deficiency will then result in an acquired deficiency of immune function. The secondary or acquired immune deficiencies are not confined to HIV alone, but extend over many diseases and many categories of secondary immune deficiencies, as described on this slide. Now let's for a moment dwell on the immune deficiency of HIV infection. The immunological hallmark of HIV infection is progressive loss or attrition of absolute CD4 count, of CD4 cell number, as well as loss of CD4 cell function. However, the immune dysfunction in HIV extends beyond the CD4 cells and involves other aspects of adaptive immunity, as well as other aspects of innate immunity, as described on the slide. Now, these are the results of an actual case of HIV infection. And these results relate to a child that was investigated by the pulmonology service at our hospital for recurrent respiratory infection and failure to thrive. The initial HIV rapid test was negative, so the attending clinicians proceeded to run off a whole series of investigations looking for other causes of recurrent infection, including this battery of immunological results. What these results show is that there's a high globulin fraction, primarily as a result of a massive increase in IgG concentration and to a lesser extent IgA concentration. Towards the end of the slide, you will see that there's low specific antibody responses to commonly administered childhood vaccines. And in the middle of the slide, you'll see the lymphocyte subset results, showing disturbances of the lymphocyte subsets, notably a very low CD4 cell count. This pattern of high immunoglobulins, low CD4 count, disturbance of other lymphocyte subsets, as well as depressed specific antibody responses, does suggest HIV. And when I looked at these results originally, I suggested that they repeat the HIV test, and indeed, the HIV tests, subsequent tests showed that the child was in fact HIV infected. Let's for a moment dwell on the clinical manifestations of HIV. They include general features such as generalized lymphadenopathy, which is not very commonly found in PID patients. A spectrum of infections that includes infections such as recurrent bacterial infection, which overlaps with some or many of the PIDs, but it also includes other infections that are more common in HIV and less common in PID. Organ or system-specific effects, such as the hematological effects of anemia, neutropenia, and thrombocytopenia. But there are other organ-specific effects found in this and the next slide. Then a spectrum of cancers. Some cancers commonly seen in HIV, such as leiomyosarcoma, or more frequently seen in HIV, such as leiomyosarcoma and Kaposi sarcoma. And then some tumors, such as various types of lymphoma, that are seen in both HIV and PIDs. We see an encephalopathy in HIV-infected children, and it overlaps with encephalopathy seen in some PIDs. But there are some unique features about the encephalopathy of HIV, such as the calcification that one picks up in the basal ganglia of HIV-infected children with encephalopathy. And then there's a spectrum of malnutrition commonly seen in HIV, which culminates in the wasting syndrome in really the extremely affected HIV-infected individuals. But having said all this, and having acknowledged that there is overlap between the PIDs and HIV, at the bedside, when you assess and you identify the combination of features in a particular child, the combination of features often points to HIV and excludes PID in a large proportion of patients with symptomatic HIV. So then HIV, it is possible to recognize it at the bedside in terms of the clinical manifestations in particular patients. And this spectrum and this combination is often different to what you see in children with PID. What about screening? Screening is commonly used in HIV infection, and certainly for pediatric practice, the common time points are in the antenatal period for pregnant women. And here we use antenatal screening to identify HIV-infected women, but also to identify HIV-exposed infants. And then neonatal and early infancy screening to screen those HIV-exposed children to determine whether they have HIV infection or not. And usually children identified to have HIV infection in that age period are asymptomatic, and we can intervene with therapy before they manifest the symptoms and the clinical disease, as previously described in my last two slides. And this practice is widespread throughout Africa because of the wide availability of HIV tests. By contrast, we do know that universal neonatal screening for PID is possible and is being practiced in some parts of the rich world and would be based on either the TREC assay or the TREC plus KREC assay. And here, screening is done specifically to identify severe conditions in which T cells and or B cell lymphopenia is present. But this practice is not universal, and certainly with respect to the public sector of African countries, we do not do routine neonatal screening. What about the natural history? Certainly with respect to HIV, determinants of the natural history are age at HIV acquisition, socioeconomic status of the patient, and certain co-infections which cause the disease to progress quite rapidly, which allow patients to die quite early. With respect to perinatally acquired HIV infection in Africa, the natural history is well described, And we do know that by the age of 2 years, without antiretroviral therapy, just over 50% of all perinatally acquired HIV-infected children would have died. With respect to PID, the natural history varies according to the PID type. We know that SCID is the most aggressive PID, and the natural history of SCID indicates that without definitive treatment, the vast majority of children will die by 1 year, and all would have died by 2 years. So SCID is probably the PID closely related to, or closely resembling perinatally acquired HIV infection. But having said that, the natural history of SCID follows a far more catastrophic course, resulting in 100% death, certainly by the age of 2 years. A brief word on the treatment of HIV and PID. For HIV, the treatment is largely based on non-curative interventions such as antiretroviral therapy and other support measures. But with those measures, and specifically optimal antiretroviral therapy, one can optimize life expectancy, and certainly for adults with HIV, can largely normalize the life expectancy of the individual. Curative interventions have only been successful in 2 patients who received allogeneic stem cell transplants for cancers that occurred in the course of their HIV infection. And these are specifically from donors, stem cell donors who were homozygous for CCR5 delta 32 mutations. By contrast, when we look at PID, certainly in Africa, non-curative interventions are still the basis of the treatment of most children. But in rich countries, a sizable proportion of children can now be cured with interventions such as stem cell transplant and conventional gene therapy. And on the horizon, in the next few years, we will probably see newer gene editing methods start to play a role and start to extend the curative agenda of the PIDs. So getting back to the question, is HIV and PID aspects of the same coin, 2 sides of the same coin? I would say that that is too simplistic, and I would say no. However, if one wants to retain the coin analogy, then it can be argued quite correctly that the 2 aspects of the coin are the IEIs and the secondary or acquired immunodeficiencies, with HIV being one of many secondary immune deficiencies. The alternate way of looking at the relationship between the 2 sets of conditions is to dispense with the coin analogy and simply regard HIV and IEIs as components of the spectrum of immune deficiencies and diseases of immune dysregulation that also includes other secondary immune deficiencies. I thank you for your attention.
Thank you, Dr. Brian, for this wonderful talk about the similarities between HIV and PID. And it's now my pleasure to introduce you to Dr. Marybeth Maritim from Kenya. She's a board-certified and experienced consultant physician in infectious disease, tropical and travel medicine specialist at the University of Nairobi. And she will present us an interactive case when it's not HIV. So Marybeth, go on. Thank you.
Thank you. Thank you very much. And I would like to convey gratitude to the Congress organizers for giving me this opportunity to share this case that we managed way back. And thank you, Brian, for that very elaborate introduction that really sets the precedent for what I'm about to share with you. And also just to highlight, I think in the pediatric population, one of the differential diagnoses that someone would have when a patient presents with, for example, recurrent infections, you would think about primary immunodeficiency and also think around HIV, particularly in sub-Saharan Africa. In the adult setting, however, it may not be the same because we don't see a lot of primary immunodeficiency manifestations that are presenting for the first time in adulthood, maybe in late childhood. But in adulthood, one of the things we would consider is other secondary causes of immunodeficiency, really, rather than primary immunodeficiency. So I have no conflict of interest to disclose, and this is the outline of my presentation. I was asked to prepare 2 cases. However, I was able to only get 1 case, and we'll make the maximum out of that 1 case and just highlight the important things and really set the stage in terms of what do we need to do for our part of the world to evaluate these patients further based on some of the gaps that I identified within my case. So I'll have the introduction and then present the case, discuss the case, and provide us with a conclusion. I was given 40 minutes. I may not use up the entire 40 minutes, but this will allow us to really have more time for discussion. And for those of you who are listening offline, you can share your thoughts and enrich the discussion that we will have thereafter. So just by way of introduction, in our country, we have had different approaches of HIV testing services that have evolved over time because we had very good programs since 2004 when we started providing treatment for patients who are diagnosed positive with HIV. Prior to that, we didn't really have widespread availability of treatment within the public health sector. And a lot of patients used to spend most of their income trying to access treatment, and which even involved importing the drugs from the developed world. So we've had different strategies. The PITC stands for Provider Initiated Testing and Counseling, whereby when a patient presents to a facility, the healthcare provider prompts the discussion and offers the patient testing, and the patient would consent and they'd be tested, and based on what the test results would be, then they would either be HIV positive or HIV negative, and thereafter, based on different guidelines that we've implemented over time, some patients would qualify to start antiretroviral therapy if their CD4 counts were very low, less than 200. In the current guidelines, we start all patients on treatment following a HIV test. The diagnostic testing and counseling is whereby in the inpatient setting or even in the healthcare setting, patients who would meet a certain criteria would be offered the test and therefore would be tested based on the presentation. We've had evolution of our guidelines and testing algorithms, and this really have been guided by the global arena where we follow what the WHO recommends. And many of you may have been aware that there were some rapid diagnostic tests that were recalled and new testing algorithms were introduced. So since 2018, which is our latest revision of the national guidelines, we have implemented what is called a test and start strategy for HIV testing. And this is whereby anybody who tests positive for HIV is therefore started on treatment, and all patients who are started on treatment qualify to receive a viral load within 6 months of starting ART. And therefore, with this strategy, more patients are entering care because they are diagnosed fairly early in their illness, and because we don't have a waiting period where patients wait for their immune system to decline. A lot of the patients are starting HIV treatment when their CD4 counts are still high and preserved, and therefore the immune systems are fairly preserved. However, despite this, we still have some patients who present to care late, and these patients manifest in the inpatient setting with a lot of the opportunistic infections, which include tuberculosis, cryptococcal meningitis, recurrent pulmonary infections, pneumocystis jirovecii, pneumonia. So we see a range of opportunistic infections. In this same group of patients also, we see a number of patients who default their treatment and therefore come into the wards with disease progression manifesting as the opportunistic infections that I have already mentioned. So one of the things is that some patients present with negative HIV test results, yet they have signs and symptoms consistent with HIV. You'll find a patient who has wasting, who has fever, but when you do the HIV test, they test negative, and you cannot really explain why they are HIV negative because we hardly think of other secondary causes of immunodeficiency. We've also seen a number of patients who present with signs and symptoms consistent with cryptococcal meningitis. When we do the test, the lumbar puncture, they actually test positive on the cryptococcal antigen test in the CSF. And most in sub-Saharan Africa, the commonest cause of underlying cause for cryptococcal meningitis still remains HIV. Unlike in the developed world, where you have Cryptococcus gattai that can even affect immunocompetent people. So we are normally at a loss when we have such patients who have cryptococcal meningitis and test negative for HIV because we are not even able to determine whether it's cryptococcal gattai that they may be having as a cause of their cryptococcal meningitis. So allow me to share this case that I have prepared, and then we'll have further discussion after the case. Sorry. So this, I put this slide here just to remind us of some of the opportunistic infections that we see in patients who have WHO clinical stage 4 illness. And Brian had a similar slide to this, but his slide was focusing on the pediatric population. And some of these diseases are not necessarily very different in the adult population. So we have HIV wasting syndrome, which is defined by severe wasting, loss of more than 30% of body weight within a defined period. We have pneumocystis jirovecii pneumonia, severe recurrent bacterial infections, chronic herpes simplex infections involving the orolabial area, genital, or even anorectal area. But these have to be of more than 1 month's duration, plus herpes simplex diagnosed at any visceral site. Esophageal candidiasis, extrapulmonary tuberculosis, Kaposi sarcoma, cytomegalovirus infection involving the retina, and specific organ infection. CNS toxoplasmosis, HIV encephalopathy, extrapulmonary cryptococcosis, which includes cryptococcal meningitis. And this is by far one of the commonest manifestations that we see, that when the patient tests negative, then we are at a loss what exactly can explain the predisposition in that patient. We also have disseminated non-tuberculous mycobacterial infection, progressive multifocal leukoencephalopathy, chronic cryptosporidiosis, chronic isosporiasis. These two, chronic cryptosporidiosis and isosporiasis, would present mainly with GI manifestations. So they may present with diarrhea, chronic diarrhea, also involvement of the biliary system. So they may present with jaundice as well. Disseminated mycosis, such as extrapulmonary histoplasmosis and coccidioidomycosis. Lymphomas, mainly B-cell non-Hodgkin's lymphoma in the CNS, and then symptomatic HIV-associated nephropathy or cardiomyopathy, recurrent septicemia, invasive cervical carcinoma, and atypical disseminated leishmaniasis. So we see these conditions in our setting, but mainly in the background of HIV. So allow me to share this case. This is AA, a 53-year-old male who worked as a long-distance truck driver, and he had been on follow-up in our hospital HIV clinic since 2001, where he received care and treatment and was being followed up. In 2017, he presented for one of his follow-up clinics, and he requested for reevaluation. And this is because he had received a negative HIV test result done in another facility. So back to his initial illness. So his illness began in October 2011, where the patient had presented in a facility in Busia, which is one of our border towns in the western part of Kenya, at the border between Kenya and Uganda. At that facility, he presented with a 3-day history of difficulty swallowing, productive cough, and the cough was productive of blood-stained sputum, 3-day history of sore throat, and generalized body weakness, and also was noted to have weight loss, but he could not quantify the duration of this weight loss. On examination, he was found to be pale. He had mild jaundice and wasting, moderate wasting. He had a tachycardia of 100 beats per minute. His blood pressure was low at 79 over 59 millimeters of mercury. However, we could not establish further examination findings in his clerkship notes for that initial visit, but this patient was fairly sick and was resuscitated in that facility. Some of the tests that were done at that facility included hemoglobin, which was low at 7.6 grams per deciliter. His random blood sugar was 4.6 millimoles per liter. So again, this is an important thing to exclude diabetes, because we have a significant proportion of our patients who have diabetes and therefore would present with wasting and other predisposition to other infections and manifestations, including even the wasting. So it's an important differential diagnosis to exclude. And had his random blood sugar been markedly elevated, then we would have additionally done further tests to evaluate for diabetes. His provider initiated testing and counseling for HIV using rapid tests, came back as positive, and the tests that were used as per the guidelines at that time were Determine and BioLine, and both were positive. His ESR was elevated to 144 millimeters in 1 hour. However, in the setting of a low hemoglobin, then the significance of this elevated ESR is neither here nor there. So again, just with that caveat, his hepatitis B surface antigen was negative. Abdominal ultrasound scan revealed a massive splenomegaly with normal echo pattern. His liver and kidneys were normal. There were no ascites. We don't know much about this splenomegaly because clinically, in our training, in our day-to-day practice, we train our healthcare providers to be able to pick up an enlarged spleen on physical exam. But like I mentioned in my earlier slide, the clinical notes were very scanty, and we would have needed additional history to really describe the cause of this splenomegaly in this patient who has weight loss, because we have visceral leishmaniasis in our setting, and it's one of the causes of a big spleen. Other causes would include hyperreactive malarial splenomegaly, but you'd need to take additional epidemiological history to see where this patient comes from. And it's more found in people who live in, particularly children who live in an endemic setting as a response to chronic antigenic stimulation by the malarial parasite in that particular setting. But from the ethnicity of this patient, he didn't really come from malaria endemic area, and therefore we would have needed additional information to work up for this massive spleen and exclude even other conditions like chronic myeloid leukemia. This patient was referred to our hospital for further management, but of priority was for ARV initiation to start his antiretroviral therapy. And this was based on the positive test. So I think one of the things in our setting, when people get a patient with HIV positive, it blocks their mind to think of any other possible causes. And therefore, this patient missed an opportunity to really be fully evaluated way back then. This is 10 years back, looking at what could explain his different presentation at that particular time. So the patient was admitted in our hospital a few days later. That was on 25th of October, 2011. And at that time, the working diagnosis was possible peptic ulcer. There was a splenomegaly that had been picked on ultrasound. And the differential diagnosis at that time was visceral leishmaniasis, potentially also pulmonary TB with disseminated TB, especially because now he had tested HIV positive. And you know, way back then in 2011, our statistics now are different, but at that particular time, we had HIV TV co-infection rates of up to 50%. So again, then back then, this would have been a plausible explanation. However, we know that tuberculosis doesn't give a fairly large spleen per se. It would be a moderate size of spleen. At the hospital, we did further investigations were done, which included a chest radiograph, and the note that was included in the file was suggestive of pneumocystis jirovecii, pneumonia. Sputum for AFPs to rule out TB were negative. At that time, we didn't have the gene expert, so this was really looking at microscopy, acid called fast bacilli under the microscope, and this was negative. The upper GI endoscopy revealed gastrointestinal reflux disease with bile reflux gastritis and peptic ulcer. And the DTC was repeated at the hospital using, again, the same algorithm, determine and bioline, and they were both positive. At that time, a CD4 cell count was done, and the cell counts were quite low, 58 cells per microliter. His hemoglobin, again, was confirmed to be low, and his creatinines were done. I couldn't have the actual reading for the creatinine. Sorry, for the creatinine, but the estimated GFR derived from the creatinine was 110 mils per minute. So I could not get the other information on the hemogram because I needed more information on the other cell lines, particularly in patients who have visceral leishmaniasis. You'd expect a pancytopenia with the reduction in the platelets, the white cells, as well as even the hemoglobin because of the involvement of the reticuloendothelial system, but I could not get the full report because in our hospital, we don't have digitalized records. We actually have paper-based records, and sometimes getting records way back of a patient when you're in 2017 trying to look for records of a patient for 2011 becomes very difficult because sometimes patients get a new booklet for every admission. So during the admission, based on the working diagnosis at that particular time, which was community-acquired pneumonia and working diagnosis of peptic ulcer disease, the patient was started on ceftriaxone together with omeprazole. There was a note of fluconazole being started, but I could not find any rationale, whether the patient had been found to have any evidence of oral candidiasis to support this fluconazole, but I noted that the patient was on fluconazole and then received supportive treatment and was discharged after he improved within a couple of days. So he was discharged for follow-up in the outpatient clinic. And at that particular time, it wasn't really clear whether there was a plan to evaluate the enlarged spleen following his discharge. And there was no other mention really of what additional investigations were done for this particular patient. And I've highlighted in my discussion because this was a gap in terms of evaluating this patient fully. And this could be explained because many a times when healthcare workers find one diagnosis, they want to put everything on that one diagnosis, even when there may be other gaps of other things that can explain the clinical picture in the patient. And therefore, this is really a gap and an opportunity for training and mentorship. So this patient was started on ART on 11th of November 2011. He received our standard first-line regimen at that particular time, which comprised of tenofovir, lamivudine, and efavirenz. And he had good adherence to his medication. He was followed up in clinic. He just missed a few clinic sessions by virtue of his nature of his occupation as a long-distance driver. Sometimes you'd be late for his appointment, but by and large, his adherence was good. He had immunological and virological response to his treatment. And this is just a summary of some of the data I could glean from his file. So we see a CD4 count trending upwards, starting from CD4 cell counts of 58 cells in 2011, rising to 470 a couple of months later on April of 2012, and then rising again almost 1 year later to 578. And then in 2013, 6 months later, rising to 557. And then in 2014, rising all the way up to 788. So clearly we can see he started off with a low CD4 count, but his CD4 counts markedly improved. And normally when we have patients who start off HIV, treatment and we monitor their CD4 count, the improvement in their CD4 count is never this dramatic, because you find a patient when they present late with several opportunistic infections, even the immunological reconstitution following successful ART is not as dramatic as we see in this patient. The lack of data from 2014 to 2017 is because in 2014, we sort of scaled down on the use of CD4 count for monitoring the patients because we were able to introduce the viral load, and therefore availability of CD4 count reagents started to decline. His HP, we have that baseline HB. I don't have any other readings, and that's another gap. And then his creatinines, we see his baseline creatinine. And even when we have the next reading, which was in 2013, the estimated GFR was still within acceptable limits. And we normally, for patients who are on a tenofovir-based regimen, we would actually follow up their creatinines because these are patients who are at risk of renal toxicity, long-term toxicity due to the tenofovir. So one of the guidance and support, programmatic support, is to do the creatinine levels for these patients. In 2014, our guidelines evolved and we introduced viral load monitoring. And we can see from the onset, this patient from 2014 to 2017, his viral load copies were below the level of detection. That's what the LDL stands for. They were below the level of detection. At that time, as per the national guidelines, the monitoring levels, the level of detection was set at 400 based on the machines that we had at that particular time of monitoring the patient. So this patient, from this slide, we can evidently see he was responding well. We can see immunological response. We can see the virological response because he had the undetectable virus all throughout his treatment. So he came back in 2017 for one of his routine clinics, and he said he had been tested a week prior and his results came back negative. And therefore he requested if the clinic could retest him so as to clear any doubts. So this put us at really a very difficult situation because we read about it in the media. A lot of patients, you'll read this in the press that a patient who was on HIV treatment tested and tested to become negative. So when the patient came, we had no choice but to sort of test him. But the only thing is we did not have a very clear guidance because this is not provided for in our national guidelines. Even if you wanted to reevaluate such a patient, what are some of the tests you would have to do? So the clinicians at the facility, they sent him first to do the rapid diagnostic test. And when you read the guidance on the rapid diagnostic test, they're not really meant for testing a patient who you had already tested at the baseline. So they're not tests that you can use on or reliably use for as follow-up of a patient, because most often they are based on their diagnostic criteria, they're not really for follow-up. So the tests that were used for the first response and determine, which are now used in the current testing algorithm, and both of them were, for the first response, it was non-reactive. For the determine, they were negative. And at that time, we couldn't really attach much significance to this, but there was a trend towards negativity. So a blood sample was taken to the National HIV Reference Laboratory, and the request here was to do a qualitative HIV polymerase chain reaction. And this was done on 19th of June, and it came back as negative. So again, everything coming back negative. So the patient, at that time I was consulted, and I really wondered what to do. So I spoke to one of our professors from the Kenya AIDS Vaccine Institute, Initiative, Institute of Clinical Research, and I asked really for his guidance on what do we do for this patient who has discrepant results, because he was initially on treatment following a rapid test that were done several years back, and then he has done several tests that needed to really confirm his status. So we sent him, and they actually agreed to do a number of HIV assays to confirm his status, and the tests were done at no cost to the patient. And therefore, even I cannot say if we had such patients, how much would this test be costed at. So these are the number of tests that were done, some of them based on the rapid diagnostic test, some on ELISA, and still again the qualitative DNA PCR. So His rapid diagnostic test using determine, Unigold, and fast response, they came back again negative. His P24 antigen test came back negative. His HIV ELISA test and 2 tests were performed using the Murex technology and Advia technology, which basically use HIV antigen antibody combinations. They came back both negative. His PCR, qualitative PCR test came back again negative. So in conclusion, based on this test, the report that we received from CAVI was that this patient actually had no evidence of HIV infection at that particular time. So additional tests that were done included the absolute, the CD4 and CD8 cell counts. So the CD4 cell count was 586, which was within acceptable normal limits. The CD8 test was 708. His CD3 was 1266. His CD4 and CD8 ratio was less than 1, but it was quite sort of like not too bad. It was 0.83. His CD4 CD3 test was ratio was 0.46. His CD8 CD3 ratio was 0.56. So I saw in Dr. Bryan's presentation, he had a slide on the pediatric patient, and comparing this case and that case, the CD4 CD8 ratio for Dr. Bryan's case was 0.15 in that pediatric patient who they were ruling out PID, but ended up having HIV. But you can see our ratios were much better than in that particular patient. So the final interpretation of all these tests was that the patient was deemed to be HIV and infected. We discussed this case in our regional HIV TWG, the technical working group, and we reached a conclusion that this patient could stop his ART, but we needed to follow him up in clinic to see if there was going to be a rebound viremia, and to follow him up using possibly qualitative PCR to see if it would convert to being positive, assuming that maybe there was some archived virus somewhere. And at the time when we had this discussion, actually it came up that there were several similar cases to this that were mentioned during that discussion, but there was no clear guidance to the entire team and even nationally on what should we do when we have such patients who test somewhere and then come back and say they have tested negative and they really want to be evaluated. And sometimes some of these cases take a medical legal direction because you have said someone has HIV, they've been taking treatment, and then they turn out to be negative. What do you do? What is the recourse for such patients? So we couldn't conclude, we didn't have a document back then, and even to date, we really don't have a document. And I'm hoping that maybe after this discussion, we can sort of have maybe an African sort of guiding document to help us manage these patients and see what other things can be done to evaluate these patients. What should be done at that particular time when you have the patient, and how do you follow them up? Because there may be other secondary causes of immunodeficiency that this patient need the workup for. So no plan was made to establish if we had any other underlying cause of immunosuppression. The patient was had not and was not doing this to really take a medical legal direction. So he was very excited to be declared HIV negative because of the stigma he had faced due to his HIV diagnosis. However, he was lost to follow up after his heart was stopped. So we've not been able to get him back to clinic to evaluate him since that time. So some of the gaps that are
Can you text her? We can text her.
Let's try and see.
Okay, so I apologize for this technical issue. Seems that Marybeth had some issue with our computer. We hope that she can join us, but if not, we'll go on. Oh, okay, she's joining us. If no, good, good to see you back.
I'm really sorry. I don't know what happened. Let me share my presentation.
Okay. Should we take a look at your last slides, or should we just go to the discussion?
I have three remaining slides that are just part of my.
Okay.
Can you hear me? Yeah, 3 slides.
Yes,
Let me share.
So okay. So okay, just
I'm
go.
actually sharing. Let me just go to the specific 3 slides. And I'll make it fast. Yeah.
Sorry.
So I was saying, one of the gaps that was highlighted. Can you see?
No, you're changing the wrong window. The wrong window.
Oh, sorry.
No, it's okay.
Okay, let me stop sharing. Okay, 1 minute. Can you see my slides now? Can you see?
Yes.
Yes.
Okay. Yeah, this is my third last slide. So the gaps that were identified in this case, which are really points for improvement, includes a clinical evaluation of the patient. So the history and the physical exam, particularly in our resource poor settings where clinical acumen is really very important to even generate a list of differential diagnoses for which, with our limited resources, we can work up the patient. So in this particular patient, with the presentation of weight loss and enlarged spleen, travel history, probably where he came from, visceral leishmaniasis, which is common in our setting, would have been high on that differential list because it presents commonly with pancytopenia, it presents with weight loss, presents with fever, and a large spleen. So we have a clinical criteria that we use and then some additional tests that needed to be done in this patient. And then investigations to rule out likely differential diagnosis early in his illness, like I've talked about the splenomegaly, the weight loss. What would have been the minimum lab investigations that should have been done in this patient, even besides the HIV test that was done? And then another gap was really around the documentation, because we were reviewing this patient 6 years into his treatment, and there were several gaps that were highlighted and lapses in terms of his clinical history. And this can be improved using electronic medical records, because in many of our facilities, we use paper-based records. Even despite using paper-based records, what can be the requirement for documentation at every clinical visit? So introducing sort of clinical excellence and sort of documentation. And then another important thing is really the role of teamwork and close partnerships between the clinical and laboratory teams in evaluation of patients. Because in this particular patient, we had to reach out to our lab teams to even guide us in terms of what tests we needed to do for the patient. But we prioritize our tests around tests to rule out the HIV. And we did not truly work out what could have explained the findings in this patient. So we sort of still did not achieve closure because we couldn't say what it was that could have explained the presentation in this particular patient. And then again, around the rapid HIV diagnostic test, what is the sensitivity and specificity of some of these tests? And how do you manage, for example, a false positive test, a false negative test, and in which patients? For example, had this patient actually had visceral leishmaniasis, could that have explained a false positive HIV test at that particular time? But then how do we explain the low CD4 count that this patient had, that he presented with, that improved thereafter, and yet the patient did not receive specific treatment for visceral leishmaniasis? So what is the role of confirmatory tests for our HIV patients? And then another thing still related to that is the current HIV testing guidelines do not recommend use of rapid HIV diagnostic tests during the follow-up period. So when you have a patient who you suspect has discrepant results, how then do you assess them going forward? And there's no clear guidelines in terms of the follow-up of these patients, like who to test, the ones who test HIV negative after being on treatment, because some of these patients then go around saying that they got cured, or even some of the healthcare practitioners can tell them that they got cured, and therefore this presents a challenge when we know we don't really have HIV cure at this particular time, like a pharmacological cure for HIV. So it's unclear what tests to do and where to send the patients for these tests. And then more importantly is the repercussions and the likely litigation as a result of misdiagnosis and wrongful treatments. And I think there may be a number of cases where there's ongoing litigation. It's unclear, there's unclear follow-up of such patients who present with opportunistic infections and turn out to be negative, like the cases I was talking about, who have cryptococcal meningitis, because many a times in the inpatient setting, we don't even know what other tests to evaluate them for. And then there's need for clear international African guidelines that can be adopted at country level. And I'm hoping through this discussion, I can hear what other countries have done or are doing, and then we can learn from them. So some of the opportunities I identified are around development of clinical algorithms and guidelines for workup of these patients, and also the availability and deployment of rapid diagnostic tests to rule out common infections in our resource-poor settings, such as the workup for these patients. So for example, when patients come and we suspect that they have cryptococcal meningitis, we know that we can use the cryptococcal antigen test. If we suspect that they have visceral leishmaniasis and they meet the clinical criteria, there are certain rapid diagnostic tests like the DAT and RK49-based rapid diagnostic test. For TB, we know that GeneXpert is very useful, but we have to send the appropriate specimen. So if the patient is coughing, you'd send sputum. If you think it's meningeal TB, you'd send CSF. For PCP pneumonia, we don't currently have any rapid diagnostic test that's available. And then additionally, we need to develop—
Doctor, please, 1 minute to conclude. Thank you. 1 minute.
Okay. So training of healthcare workers and then strengthening the interface. So these are my concluding remarks, that in our setting, healthcare workers already have a high threshold to suspect HIV. And therefore, when a test comes back positive, their minds are close to anything else. So other causes of secondary immunodeficiency remain under-recognized, and there's need for clear guidelines of workup of adolescents and adults. I think pediatric, you may have more guidance on that. And then there needs to be a plan of care for management of such patients. So thank you very much for your audience, and I'll stop sharing my screen. Thank you.
Okay, thank you very much, Marybeth, for this presentation. It was really interesting. I think we have 2 questions. Maybe you can do it well. So I was asking if you, or we can explain that both rapid tests was positive twice at the first presentation, not just once, but really both at two tests. So do you have any comment? You or Brian, did you see that? Did you already see that in pediatric patients, Brian?
Okay, so just to try and respond to that, I think it is important to understand where these tests were done. Were they done by the attending nurse or clinician, or were they done in the laboratory? That's number one. Number two, were these 2 tests done on the same sample? So could there have been a mix-up with samples and hence the false positive result? So I think those, and I'm particularly interested to know how you respond to the first question, because certainly at our hospital, even though in our national program, it is encouraged to do rapid testing in the clinic setting, we don't do rapid testing in our clinical areas. We actually refer the samples to our laboratories, and they do it under standard laboratory conditions.
So to clarify, can you hear me?
Yeah, we
can hear me. Yeah. So in our algorithm, these tests are actually done on the bedside by the nurse counselors. So they are done in the ward setting, and it's one sample that is taken on the capillary tube and introduced on the 2 rapid diagnostic tests, and then they're actually done at the same time. So they're done in parallel, not in series, at the same time. And then the other question was around whether they could have been mixed up in the samples. So remember, the first test was done in the border town, which is like 400 kilometers away from Nairobi. The second test was done in Nairobi at a different time. So the 2 tests were done at the bedside at 2 different times. And for the first response of the BioLine and determine tests, there are 2 tests done and interpreted at the same time as per the recommended international algorithm. So I hope that answers your question, Brian, and helps you maybe to explain the phenomenon as asked by Leila.
So I think, my response is that you can't really explain it because there's no real known cross-reactivity with other infections that can give you a false positive result, except, of course, in the setting that I work in, we don't encounter a condition called leishmaniasis. So that's more condition of East Africa or other parts of Africa. So again, the next question is there crossover with leishmaniasis? Did you prove leishmaniasis in your patient? And is there any evidence to suggest that you can get a false positive HIV test in the setting of leishmaniasis?
So I have not come across literature to explain. What I know is that when patients have visceral leishmaniasis, they really have very high antibodies, non-specific immunoglobulins that are produced in response to the infection. But I'm not aware that some of these antibodies can cross-react and give you a false positive test. And remember, when now we were evaluating the patient 6 years later, he didn't have the big spleen, he didn't have anything that now we could work on to try and evaluate for that leishmaniasis. So we sort of like based it that now what is the current situation of the patient. So, and we're hoping that even as we follow up the patient long-term, if there was any evidence that there could have been HIV that was being suppressed maybe by the treatment, by stopping his treatment and following him up, maybe there could have been what we would call a flare where the viral load would go up and now the disease would manifest. Unfortunately, we could not, the patient was not available for follow-up. And
please, doctor, we must end the session. Please excuse us.
Okay. Okay, thank you everyone. There was a last comment on the viral load, but I think it's of course is evident. So let's move on to the second part of the session, and I will give the mic to my colleagues.
Good afternoon. Happy to welcome you all to the second part of the second session about PID and endemic diseases in Africa. In this part, we're going to deal with tuberculosis, which continues to constitute a major burden despite all the preventive and care efforts in Africa. We have top-notch speakers and we're very looking forward to their presentations. So I'm happy to share the session with Professor Aziz Bousfiha, Dr. Gamil Al-Baghdadi. Without further ado, I'd like to I'm honored to present Dr. M Holland. He's the Director of Division of Intramural Research and Chief of Immunopathogenesis Section, NIH, USA. And we're looking forward to his presentation. Dr. Stephen.
Thank you. Try and share my screen. Do you see my slides here? Not yet.
Yes.
Hold on.
They're visible, yes.
No. Now, is that visible?
Yes.
Very good. So thank you very much. I deeply wish that we were all together and I could have a chance to see so many old friends, and I still look forward to making new friends. So I was asked today to talk about BCG and MSMD, and you can see my title, which is quite ambitious, and I'm sure I will not deliver on all of it, but I'd like to try and deliver on a little bit of it. Let me just begin by saying that I come from the National Institutes of Health in the United States, and I want to illustrate that we have 3 campuses here, and these campuses are here in Bethesda, where I work. We have a campus out here in Montana where we do much of our work on coronavirus and Ebola. And then there is another campus here in North Carolina for another part of the Institute. But this is the hospital where I work. It is actually a very small hospital, only about 200 beds, but it's right outside of Washington, D.C. And we try to do bench to bedside work, just as I know all of you do as well. And I want to remind you that we are part of, although we are a national institute, we are really a global institute. And we have fellows and postdocs and rotations for people from all over the world. And I strongly encourage you to reach out to me if you have an interest in trying to do some visiting or training at the NIH. Now, this is an important time to be talking about BCG. This marks the 100th anniversary of the application, not the discovery, but the 100th anniversary of the application of BCG. And I think it is worth remembering that it was on this date, July 18th, 1921, that the first human child was exposed to BCG in Paris. And from that beginning, we have come to a time in which the vast majority of human infants are given this vaccine around the world. And I have to say, to many great positive effects. And I want to just review those for a moment because it gets confused when we talk about BCG. Why is it being given and what do we think it's doing? So just to remember, this article that just came out a couple of weeks ago in the Lancet Infectious Disease Online is really worth taking a look at. But as you might expect, over the course of 100 years, there are now many different kinds of BCG that are in circulation and in use. And we need to keep these in mind when we talk about which BCG is doing which thing in which population. But regardless of which kind of BCG is being used, you can see that the vast majority of the world is either currently using or has recently used BCG vaccination as part of their tuberculosis control program. But even though it was being used for a tuberculosis control program, in fact, BCG has surprising and still, frankly, poorly understood effects that go well beyond the benefits of preventing childhood onset tuberculosis, not adult onset. But what you see here in this paper is that neonatal and infant mortality are dramatically reduced in those who got BCG early in life as opposed to those who did not. And the mechanisms behind this have long been quite important to sort out. They really get to the root of what is the critical set of phenomena that protect us from infection. And the infection, of course, applies to mycobacterial infections. Those are, after all, very important infections. And so here you see that BCG has benefits in terms of the osteomyelitis associated with Buruli ulcer and with non-tuberculous lymphadenitis, a common problem in children. But it also is involved in prevention of a whole variety of early onset causes of death in the neonatal period, as you see here. So those that had BCG versus control, much reduced levels of sepsis, as well as other infections that are clearly not related to mycobacteria per se. So what is really going on here? And there are many studies, and I am not an expert in BCG by any stretch of the imagination, but there are many studies that suggest a significant reduction in all-cause mortality. And here you see a recent review from Nigel Curtis examining the difference between some of the reduction in mortality with BCG Denmark versus BCG Russia, I think based on some studies out of India. But the point here is that BCG has some broad effects. Now, what are the mechanisms behind this? And we think that the mechanism has a lot to do with what is now referred to as trained immunity. I think this is a critically important concept that Mihai Netia and colleagues have been working on. And in general, what this suggests is that there is a different way that BCG vaccination works than, say, many other aspects of vaccination. So whereas classically, we would expect an antigen to stimulate B cells and T cells, leading to antigen-specific expansion, as shown here, expansion of T cell clones and expansion of B cell clones, leading to cell-mediated and humoral immunity. In fact, what's going on here is a change in the set point or in the excitability and the respondability of monocytes and macrophages. And so, as shown schematically here, after the first infection, you see a response, but that primes the system to be ready to really respond to a second infection through this activity known as epigenetic reprogramming. So in a more detailed schematic that is in the most recent review, what you see here is that macrophages get infected by Mycobacterium BCG, and this leads to change in the histone marks that lead to gene expression. After the BCG is resolved, those genes still maintain those histone marks, and so are ready to respond at a much faster and a higher level when the cell is re-exposed to now a second or third stimulus. And this enhanced response, as shown over here by this very small part of the graphic that includes more methylation on these histones, leads to a more aggressive and successful response. And this, I think, probably does explain why there is so much benefit to BCG in terms of all-cause mortality. But it's not only about the trained immune response, that is the macrophage ability to respond. And in this very exciting paper from the Vaccine Research Center, which is part of my institute here at the National Institutes of Health, they looked at what happens if you give different kinds of BCG to animals, these are macaques, and then follow them with a PET CT. And what you see here is that if you give an animal intravenous BCG and then challenge it with tuberculosis, if you give nothing, animals develop extensive tuberculosis. If you give intradermal or aerosol challenge BCG, animals are not protected from tuberculosis. In contrast, and surprisingly, if you give animals intravenous BCG it really protects them almost completely from tuberculosis infection. And this protection lasts for up to 6 months. Therefore, the question that these investigators had was how much of this is T cell derived and how much of this is macrophage derived. And I'm not going to, this is an illustration of how profound the protection was, both from organisms and from the inflammatory reactions. You see here in the red arrow, all the animals that got intravenous BCG were prevented from developing active infection, whereas those that got any other form of BCG vaccination were not. So that suggests, and in data I haven't shown you, in those BCG vaccinated animals, they had much more robust T cell responses that were mycobacteria specific. So BCG under different circumstances can be macrophage stimulating, can be T cell stimulating, or both, which explains some of its potential benefits. But the topic of MSMD really takes us back to the fact that BCG is not good for all people all the time. And the area of Mendelian susceptibility to mycobacterial disease has overwhelmingly been defined around BCG vaccination and administration. So we know now, over the last 25 years, that mycobacterial control is governed by a very tight pathway that has to do with the infection of macrophages by mycobacteria, the production of interleukin 12 and IL-23 that act on its receptor on T cells and NK cells, the production of interferon gamma, and then the signaling through the interferon gamma receptor. And we know that these are true because there are now 17 genes that have been identified, some of which are shown here, that are critical in the control of mycobacteria. And we know that genetic Mendelian mutations in any of these genes lead to susceptibility to mycobacteria in general, but BCG in particular. So the interaction between interferon gamma and its receptor is, of course, at the very heart of this interaction. And it's one of the few things that we have good understanding of, and now we have some tools to manipulate. So if you are missing the interferon gamma receptor, then you cannot bind interferon gamma. You cannot activate STAT1 that becomes phosphorylated and then goes into the nucleus where it turns on interferon gamma activated genes. And if you're missing interferon gamma signaling, then you cannot increase superoxide, nitric oxide, antigen processing, MHC display, or many of the other things downstream of interferon gamma that we know are so important. And when this happens, there are very severe consequences to the administration of BCG. So in this young girl from Argentina who had interferon gamma receptor deficiency, 3 months after receiving BCG vaccination, she came in with this extensive infection of her axilla that began in a lymph node and then came out through her chest wall. She was cured of her BCG infection, but then went on to develop disseminated M. avium infection and died in adolescence. So this brings me to my story for today that I think illustrates some of these features. This little boy came to us from Peru, where he had been BCG vaccinated early in life, as is true for most Peruvian children. And you can see that he had a lesion on the side of his head that was draining. And it was draining pus that was full of BCG. You can also see that his head is not entirely normally shaped. That is, he's got some hydrocephalus that's leading to problems. And here you can see that he was such a cute and charming boy that our newspapers came to meet him and his mother at our hospital. So what is going on in him? He had a homozygous mutation in the extracellular domain of the interferon gamma receptor 1, that led to decreased expression and decreased responsiveness of his receptor to interferon gamma. And you can see here the consequences of disseminated BCG in his brain. And you can see an abscess, you can see the hydrocephalus, multiple lesions in his brain. In addition to this, he had osteomyelitis of the femur, of the ribs. He had diffuse lymphadenopathy and a significant right chest mass. So now we're faced with the problem of what to do. And it is simply true, as we know from HIV. Can you treat infections in HIV? Of course you can. Can you treat them better if people have T cells? For sure. And so we know that we need immune response and antibiotic therapy in order to be successful. So what would we do for him? Of course, we gave him as many antibacterials directed against the BCG as possible. And we try very hard to avoid using amikacin or streptomycin because of the long-term effects on hearing, which honestly, I think are far more important than the effect on kidney function, which gets much more attention than it deserves. So what do we do for him? His response here in the interferon gamma pathway is inadequate, which is why he is sick in the first place. What else can we do? So Elizabeth Sampaio, who was in my lab at the time, reasoned that, both interferon gamma and interferon alpha activate STAT1. And so here in the interferon gamma receptor, when it's functional, STAT1 homodimers form and go in and activate the nucleus. But it's also true that although the interferon alpha receptor uses both STAT1 and STAT2, there are STAT1 homodimers that form in response to interferon alpha stimulation. And so she reasoned that this might be an approach to try and bypass his defect in the interferon gamma receptor and activate his interferon alpha pathway. And so we gave him his cells in vitro and then in vivo interferon alpha, looking for the formation of STAT1 homodimers. And what you can see here in this patient and several other patients with severe mutations in the interferon gamma receptor is that when they could not respond to interferon gamma, here's CXCL9, which is a chemokine downstream of interferon gamma signaling, CXCL9, CXCL10. Both of these, although we could not activate them with interferon gamma, here is the control, here are our patients, they could not respond to interferon gamma, and yet they did respond to interferon alpha. So this is now our patient's cells ex vivo. That is, we gave him drug and then took his blood to look at his ability to respond ex vivo. And what you see here, excuse me, is that in response to, this is before and after a drug was given. So for the three different chemokines, CXCL11, 10, and 9, he responds beautifully to interferon alpha, even for IDO, another component in this pathway, when we give him drug in vivo. So now we're able to bypass our problem in the interferon gamma receptor with some stimulation through the interferon alpha receptor. Was that effective? Well, so Hannah Lorbacks, who was in the lab at the time, put all this together, and here you can see some of the consequences. This was a young woman with complete interferon gamma receptor deficiency before interferon alpha, after interferon alpha. And here you can see this charming little boy. Here is before interferon alpha, during, and then after. His lesion completely cleared, and he is now 10 years out from this period. You can see that this large right-sided mass in his lung that is involving his bone and quite large, after treatment with interferon alpha for several months, he is completely resolved. Now, he's not all better. He's got problems. It's not easy to have this much infection in your brain for this long, but he is back home in Peru, and we are treating him with azithromycin prophylaxis to prevent his acquiring environmental mycobacteria And I think this is doing quite well. So what to do and how to do it? Well, the first job, of course, is to determine, is the infection that your patient has BCG or tuberculosis? This sounds very simple, but mistakes are made all the time. And the molecular distinction between BCG and TB is not simple. Even in our own laboratory, it takes us several weeks to get that done because we have to go to whole genome sequencing. An easy test is to say, is it susceptible to pyrazinamide if you have in vitro testing being done? And not all of us do all the time. It is not uncommon to have this be erroneously decided. And here is just an example of another girl from Peru who was treated for many months in the United States as drug-resistant tuberculosis. But when we finally got the organism, we realized that she had an underlying Mendelian defect that made her susceptible to disseminated BCG. So then once you know the organism, what do you do next? And this is where it gets very difficult, and it varies from hospital to hospital and, of course, from expert to expert. What drugs do you have and what can you do? I think that it is a general rule that the more drugs you can give for people who have disseminated mycobacterial disease in MSMD, the better. And if you can give an immune stimulant, better even still. It is not worth arguing about which drug is best here. There are newer drugs coming available, things like linezolid or bedaquiline. These are very good drugs. They are very expensive. They are very hard to use. We have a hard time using them long-term because of both cost and toxicity. So I think it is important to say, if it's BCG, don't use PZA and try to use probably everything else you can. If you have in vitro susceptibility testing that you trust, and in the last session we heard about the difficulties of knowing how to trust any laboratory test, but if you trust your assays, then you can use those to guide it. And then I'm trying to figure out what is the underlying defect. I don't think there is a good way to do this other than molecular testing. Molecular testing is the cheapest, the fastest, and the most reliable. It's not always easy to access, but I think it is a simpler thing to do in the long run for all the possible defects than it is to try and do immunologic testing. But we all do what we can, and we do what we have. I separate these out because these defects over here are very interferon gamma responsive. These defects over here may not be, and may require either ultra high dose interferon gamma therapy or interferon alpha if you have access to those drugs. So just to remember that the mutations in the interferon gamma receptor can be very difficult. Sometimes there is the most common mutation in the interferon gamma receptor is actually an intracellular mutation. The boy I showed you earlier had an extracellular mutation. The intracellular mutations in the interferon gamma receptor are the most common, and they lead to a problem in recycling of the receptor. So here the mutated receptor is unable to signal, but it is still able to partner with the authentic receptor, and that blocks signaling. But there are still some authentic receptors left, so those patients do respond to interferon gamma. So that's an important molecular diagnosis to make. It can be made by flow cytometry, recognizing excess interferon gamma receptor 1 on the cell surface. But if you identify that, it can respond to very high doses of interferon gamma, but also can respond to interferon alpha. Remember that a hallmark of the autosomal dominant interferon gamma receptor deficiency, at least in the US and Europe, is osteomyelitis. And so if you see BCG osteomyelitis or non-tuberculous osteomyelitis, you at least want to consider this autosomal dominant mutation in the intracellular domain very carefully. And as I mentioned, you can give interferon gamma if those are the cases, or interferon alpha. So finally, once you decide on the defect and whether you have drugs that you can use that augment immune response, you also have to consider, is hematopoietic stem cell transplantation or bone marrow transplant worth considering? And I think as transplants get better, it makes more and more sense to consider these. These children, these adults, remain at risk for all of their lives. And the opportunity, if you have a good donor and a good center and a willing family, I would strongly encourage the consideration of early transplant. Peter Olbrich and colleagues in ISID are putting together an international survey of all of the recipients of bone marrow transplantation in interferon gamma receptor deficiency. And the overall results now look excellent compared to what results looked like almost 20 years ago, when only about half of the children. I'm sorry, I'm done. I can stop right here.
No, it's okay. Please carry on, Dr. Stephen.
So the key points here are that there is a lot to learn about these infections. And there are many manifestations that go from severe and localized infections to quite disseminated ones. So in summary, I would just say the way to manage these diseases is, number one, be sure it's BCG. If it is BCG, you know you have an underlying problem, whether we can identify it or not. You want to treat it aggressively, and for a long time, you want to try to get a molecular diagnosis of the underlying immunodeficiency. I think it's useful to use cytokines if you have them available, but they are not always available. You want to consider secondary prophylaxis for environmental mycobacteria once people have gotten over the primary infection. I cannot tell you how often I see that fail to happen in practice, and it's quite heartbreaking when children come back with their second or third infection. And then I think that we are moving to a time when we should be considering hematopoietic stem cell transplantation where available for those that have defined defects and have available donors. Lastly, these are difficult infections to treat. And what I do is to reach out to expert consultants around my institution and around the world who have more experience with these than I do, because I don't want to be walking this road alone. It is very lonely and very dangerous. So I will stop there and say happy birthday, BCG. We are not always happy with what you do, but we are very grateful for some of the many things that you have brought us. It's not good that we learned about MSMD from BCG, but it is good that we now know a lot about it and that millions of lives have been saved over the years by stimulating immune response. Thank you very much. I'd be happy to take questions.
Fronts. If anyone has questions, please provide them in the chat box and we'll keep them to the end of the session. I invite Dr. Aziz to present our next speaker, please.
Yes, thank you, Nermeen. Excellent talk, Steve. Thank you very much. It was wonderful. And now I have the pleasure to present Professor Aisha Elmarsafy, my colleague and friend, and a member of the team who has founded African Society. Professor Aisha Elmarsafy is an emeritus professor of pediatrics. She's a former chief of PID units in the pediatric department of Faculty of Medicine in Cairo University. Professor Aisha Elmarsafy will present a talk about Mendelian susceptibility in Egyptian children. So please, Professor Aisha, you can go.
Good afternoon. I'm so glad to present in the ASID meeting the subject of Mendelian susceptibility among Egyptian children. Mendelian susceptibility is caused by rare inborn errors of interferon gamma immunity causing selective susceptibility to weakly virulent mycobacteria such as BCG and environmental mycobacteria. Occasionally, there is the susceptibility to other microorganisms. The first discovered patient with this disease was back 1996, when things were that simple, became much more complex. And this is the last progress in the complexity of this group of disorders, with at least 17 genes being involved. And this is the worldwide susceptibility to Mendelian susceptibility. As you can see, Africa, very little reporting of Mendelian susceptibility of microbacterial disease, namely North Africa, South Africa, and the rest. This is massive underreporting. Mendelian susceptibility to mycobacterial disease has a very wide clinical spectrum, from very mild, even asymptomatic cases, going into the most severe with an early presentation and probably leading to death. In Egypt, in my files with Mendelian susceptibility for mycobacterial disease, I have 34 patients listed. 16 out of those, for 16 patients, we managed to send samples for molecular diagnosis. We already have results for 10 patients with proven Mendelian susceptibility for mycobacterial disease. One is probably Mendelian susceptibility, but results are still pending. And the remaining 5, the material we sent, the result was insufficient DNA. It was not a negative result. So actually, we are correctly suspecting Mendelian susceptibility for mycobacterial disease. Among the 10 patients that for whom we have already some genetic data, a firm, complete genetic diagnosis, as expected, the commonest disorder is interleukin-12 receptor B1 defect. In this group, we have 7 patients. 4 of them are sharing the same mutation. Only 2 of those are brothers. But it seems that this mutation will eventually be one of the common mutations in Egypt. There are 2 others having a different mutation. They are cousins, and one having his own mutation. The other group of diseases of Mendelian susceptibility is the complete interferon gamma R1 deficiency. And in this group, we have 2 patients, 2 unrelated patients. I will present shortly their clinical data. The third group, we have recently identified a patient with partial interferon gamma R2 deficiency in only 1 patient. And this patient will open the way to a wider search for Mendelian susceptibility. We were restricting ourselves to patients with very severe progressive disease. But in fact, we have to widen the search even for milder cases with just BCG complications. So among the classification of Mendelian susceptibility, we have 2 patients in the very severe form, and we have 1 patient in a partial interferon gamma, and 7 patients in the less severe forms. In the severe form of complete interferon gamma receptor deficiency, the presentation should be an initial BCG-related disease, and then throughout life, there will be a major problem with mycobacterial infections, namely environmental mycobacteria, with very little susceptibility to other microorganisms. In contrast to patients with interleukin-12 receptor deficiency, where all the patients initially suffer from BCG-related disease, but after recovering from this initial BCG-related disease, they have very little problems with environmental mycobacteria. But on the other hand, they will start showing problems with invasive salmonellosis as well as other microorganisms such as Candida or others. Let me start by reviewing my patients with interferon complete, autosomal recessive complete interferon gamma R1 deficiency. In this group, we have 2 patients. This patient initially presented at the age of 14 years. She has been suffering from BCG-related disease since she was 3 months old, which progressed into generalized lymphadenopathy and then disseminated disease, pulmonary, bone, and skin. She remained for 19 years of her life receiving anti-tuberculous treatment without control of the condition, and she succumbed to her disease by the age of 90. The other patient, as you can see, this is her radiology at the time of presentation when she was having a massive pulmonary disease which ended up her life. And she was also confirmed as interferon gamma receptor deficiency disorder, which is quite severe, starting early in life and leading to susceptibility to BCG or environmental bacteria without specific susceptibility to other microorganisms and requiring hematopoietic stem cell transplantation for treatment. This is the other group of patients, the commonest one worldwide, and the commonest one in our series, which is mycobacterial disease incomplete interleukin-12 receptor beta-1 deficiency. In this group, we have 7 patients, as I told you, and the clinical picture is quite similar in the 7 patients to the extent that on clinical grounds, we can now suspect the patient that he is having this defect. They all start with BCG-related disease that requires prolonged treatment with anti-tuberculous treatment, but after complete control of the initial BCG complication, the patient no longer suffers from further mycobacterial disorder, but soon thereafter, he will start manifesting invasive infection with salmonellosis. We had cervical salmonella lymph node disease, abscess. We had severe salmonella gastroenteritis or a combination of those. And this will be soon associated with the presence of vasculitic rash and some arthropathy. Even this patient, when he presented, he had a history of BCG-related disease and treatment with tuberculosis, but he presented to us with this rash and arthropathy. And when investigated, he had a wide population of double negative alpha beta. He was suspected to be an ALPS patient. And when investigated by whole exome sequencing, it proved to be an interleukin-12 receptor beta-1 deficiency. The last patient in our series presented when he was nearly 1 year old with BCG-related left axillary lymph nodes with sinus formation that responded initially to anti-tuberculous treatment, but when anti-tuberculous treatment was stopped 3 months later, the disease recurred more aggressively, localized, and producing many sinuses. He was treated again with anti-tuberculous treatment for 2 years with complete resolution this time. And since then, he's not suffering any other complications. He's 5 years old and he's doing well. But this patient opens the way to widening the search for mycobacterial, Mendelian susceptibility for mycobacterial disease, even in mild forms of BCG complications. This is the worldwide distribution of the various genetic disorders causing Mendelian susceptibility. And the findings apply to our findings, where the majority of the patients are interleukin-12 receptor, like our cases. And we also have 1 in this group and 1 and 2 in this group. Interestingly, is the inclusion of a subset of the CYBB, CGD, X-linked CGD patients who manifest only a defect in the macrophages, not in the phagocytes. And because I have 200 CGD patients I'm following right now, so I have some experience with mycobacterial disease in CGD patients as the initial presentation or as the main presentation. In my 200 CGD patients, half of them are NCF1 because we are a country with marked consanguinity. So this is understandable. And half of those patients have their initial presentation or their only presentation mycobacterial disease, any form of mycobacterial disease, gut disease of the spine, pulmonary tuberculosis, skin tuberculosis, osteomyelitis caused by tuberculosis, but commonly it's only tuberculosis. We have mycobacterial infection in the other groups of CGD patients, but much less often than what we actually see in the NCF1 patients. This is an NCF1 patient presenting for the first time at the age of 15 years with endobronchial tuberculosis. This is another patient, but this patient has been suffering since she was born with a BCG-related axillary lymph node, generalized lymphadenopathy, invasive tuberculosis, including peritoneum, pulmonary, and finally pericardial disease. And this patient was found to be a CGD CYBA defect. This is another patient presenting for the first time, and this is her only infectious disease. She has an NCF1 deficiency. She and her brother are presenting with this massive tuberculosis of the skin. This is another patient who presented the same with tuberculosis of the skin at a rather older age, and she was found to be an NCF1. In conclusion, CGD must always be ruled out in any patient presenting with significant atypical mycobacterial or BCG-related disease. Whether CGD will be included as a genetic cause for Mendelian susceptibility or not, at least it's an important differential diagnosis. Next generation sequencing is virtually our only way of defining the genetic background of those patients and hence understanding their clinical findings. Recently, NGS, with a wide array of genes implicated in Mendelian susceptibility, is currently introduced at Cairo University Children's Hospital. We are actually right now studying our patients using NGS while just starting it. Africa in general is requested to contribute more actively to the study of Mendelian susceptibility, clinical as well as genetic heterogeneity. And I think that will add to our understanding of the disease. I would like to thank all contributing centers to our study, as well as my team and all of my patients. And thank you very much for your attention.
Thank you, Dr. Aisha, for this marvelous presentation with a wide display of different cases. And now I'd like to present Dr. Helena Cornelissen. She is a registrar of hematopathology at the National Heart Lung Institute at Takeda Hospital at University of Stellenbosch. Sorry for the pronunciation. And we're looking forward to her presentation.
Thank you very much. I'm going to share the internet. طبعا أنا امبارح بالمناسبة. All right, so I'm going to get started. If that's okay. Great. Hi, can you hear me better?
Can you mute YouTube and other use only Zoom, please.
Terrible, then you can go to the pre-recording if that's better. Better, sure.
Hi, my name is Helena Cornelissen and I'm a registrar in hematopathology at Takeda Hospital, which is part of the University of Stellenbosch in Cape Town. And today I'd like to discuss Mendelian susceptibility to mycobacterial disease in TB hyperendemic South Africa. I thought I would start off with this acronym SPUR because you'll see I'll use it throughout the presentation, and just wanted to highlight what is meant by it. So the Primary Immunodeficiency Network of South Africa has adopted the acronym SPUR, which stands for Severe or Serious Persistent Unusual and Recurrent Infections. And it's quite nice and easy to use when discussing PID with clinicians as well as patients. It's also easy to remember, especially in South Africa. We have a childhood restaurant called SPUR, and I like their slogan, A Taste for Life. When discussing PID, it really is with patients and clinicians and people who have a taste for life. So I thought I would just start off with a case that kind of sparked the thinking and thought of MSMD in the South African context. So she was a little girl at the time, but she was BCG vaccinated at birth as per South African protocol. She then presented with pulmonary tuberculosis at 6 months, not very unusual for our context. Then again at 8 years. Then a few months later, an image cellulare was cultured. Very, very unusual. She then developed a septic arthritis where image cellulare was cultured. And this you can see was very, very difficult to manage and was recurrent. The team at the time was able to offer her Sanger sequencing a few years later, and then functional immunophenotyping. She then fell pregnant and had a little girl where the same variant was identified early, but unfortunately the baby was vaccinated with BCG at birth and then presented 7 months later with disseminated BCG. She was treated with an intensive regimen and longer duration of therapy given, and is actually doing quite well. So you can see from this case presentation that the infections were severe, they were persistent, difficult to manage, unusual infections, very unusual to have an environmental mycobacterial infection outside of a secondary immunodeficiency, and then these infections were recurrent. So I'm sure the previous two speakers have really discussed and given us a good overview of what is MSMD. I just thought I would highlight a few salient points. So it's a primary immunodeficiency, that is a monogenic defect and results in increased susceptibility to mycobacterial infection. It's important to remember that other primary immunodeficiencies do have increased susceptibility to TB and should be included on the differential diagnosis. And it's typically described as increased susceptibility to polypathogenic mycobacteria. However, NTB complex infection has also been described. And the first clinical description was in the early 1950s, but it wasn't until the mid-1990s that the first genetic etiology of MSMD was described. So I just thought I'd put tuberculosis in a little bit in context. So TB continues to be the largest contributor to death in South Africa, and it's estimated that about 80% of the population is infected with TB, majority with latent TB. And if you compare the number of new cases reported in South Africa, you can see that when we look at the prevalence per 100,000 population, it's much larger than other countries such as India, and much larger, much more than in European or the United States settings. I thought I would just look at the impact of COVID-19 on TB reporting, and here you can see that there's been a stark decline. It's a little bit outside of this discussion, but you know, what has the impact of social distancing had on new TB infections? But I think it's important to just think about what has the impact been on reporting of primary immunodeficiency in South Africa and worldwide. So if we look at Tygerberg in context, you can see that there's really a difference of worlds. Here is a little red flag that highlights Tygerberg Hospital, and a few kilometers up from Tygerberg Hospital is suburbia with lovely living conditions, great water and sanitation, access to healthcare. A few kilometers down is the informal settlement where there's overcrowding, poor sanitation, HIV infection is very high, malnutrition is very high, really suboptimal standard of living here. And consanguinity in the South African context is also very, very rare. So if we look at the contributors to the burden of TB in South Africa, I've highlighted to you that the environment is very contributory. There's also this co-burden of HIV as well as malnutrition. But what effect does PID have? Where does MSMD sit in the burden of tuberculosis in South Africa? Very interesting to look at. And a little bit old now, but in 2016, Prof. Esser looked at the prevalence of TB infections in our primary immunodeficiency cohort, and that here you can see that mycobacterial infections were definitely found in other PIDs and were a burden of disease in our PID cohort. I'm not going to describe this in depth, but just briefly the pathophysiology of MSMD. We know that interferon gamma is a key cytokine in both the innate and adaptive immune responses to viruses and intracellular bacteria. And MSMD is associated with defects in the interferon gamma IL-12 pathway and results in impaired interferon gamma production, as well as abnormal response to interferon gamma. And here you can see highlighted in this diagram that it is a complex pathway, and you can see here some of the genes that have been identified in the MSMD pathogenesis. I really like this table that describes MSMD warning signs. It's usually in childhood, can also present in adolescence and adulthood. They are generally otherwise healthy individuals, and typically they have normal first and second line focused immune investigations. And that they tend to have invasive or recurrent infections with mycobacteria, as well as fungi, parasites, and viruses. Some do present with a family history of recurrent mycobacterial infections. And what I really would like to highlight here is that they can have an undetectable or very low interferon gamma production and interferon gamma release assays. And in South Africa, we actually have quantiferon gold relatively easily available because of our burden of TB. So here you can see that what is described here are infections that are severe, infections that are unusual, and then I'll just highlight in a few cases that infections are persistent and recurrent. So the aim of this study was highlighted by the Pigeon Group, and it was seen that there was a need for cheap and easy to use tools to identify possible cases. Our clinicians are very, very used to treating TB, used to seeing TB, and just try and help create an awareness of possible MSMD. So between 2013 and 2019, patients with SPUR TB infections were recruited through Tygerberg Hospital. with extensive investigation to exclude other PID or other underlying cause for immunodeficiency. The focus was on children between the ages of 5 and 15, the wonder years, where we know that there's lowest risk for progression to active TB. And we wanted to really create some easy to use SPUR definitions. So these were done with literature review as well as in close collaboration with TB experts in our hospital and our setting. So severe infections were defined as uncontrolled or complicated infections. Persistent infections were those infections requiring a longer duration of therapy or those that did not respond to the correct induction regimen. Unusual infections or unusual sites, and those with recurrent infections, particularly those within the 5 to 15-year-old age group. So we developed this little algorithm where patients must have a documented HIV negative result on our laboratory information system. I've discussed the clinical flags, but I just wanted to highlight the laboratory and how important the microbiology laboratory is in identifying any interesting cases. Patients then had basic laboratory screening, expanded immune functional screening, and then we were very lucky to be able to work in collaboration with a PhD student to do functional immunophenotyping. It's not routinely available. And then patients were selected for next generation sequencing with functional verification if required. And then results were fed back through genetic counselor, and the management plan was decided through close collaboration with immunologist, pediatrician, TB specialist. So if we look at the demographics of the population, males predominated. Median age of presentation was 2 years old, majority presenting younger than 5 years. There was a median number of documented bacterial infections of 2. And then that SPUR infections that led to molecular diagnosis had a sensitivity of about 78%, which is very, very low. However, it does provide promise. So if you look at this table, these are not all of the patients in our cohort, but I did want to highlight here that there is a varied phenotypic presentation, that typically the routine laboratory investigations were normal. However, some did present with an anemia. I've highlighted here the cases that presented with environmental bacteria. Majority either had pulmonary presentation or a disseminated TB at presentation. Majority had severe infections. Majority had recurrent infections. And that clinical management was really tricky and difficult to manage infections and required extended treatment regimes, really focused treatment regimes, and some even needing multi-drug resistant or extreme drug-resistant regimens. So here you can see that majority of patients had mycobacterial infections. Majority of patients had severe or persistent infections, and that majority presented with disseminated mycobacterial infections or pulmonary manifestations. If we look at the immunophenotype, unfortunately, not all patients were able to have functional immunophenotyping, but in those that it was performed, all showed an impaired function in the pathway. And in the quantiferon gold, which is an interferon gamma release assay, 2 patients had a negative result, confirmed endomy complex infection, and it suggested defective interferon gamma pathway. So this could be quite useful in the primary healthcare setting or secondary healthcare setting, where a negative result could highlight potential MSMD and flag further immunological investigation. However, it must be said, in the context of a positive result with SPUR infections, MSMD cannot be excluded. So if we look back to the immunophenotype of our case, and I must highlight that this isn't routinely available, this was part of a PhD project, you can see here in comparison to the control, both the mom and the daughter had increased levels of interferon gamma receptor 1 expression, but decreased levels of STAT signaling, which was very low to absent. You you can see the cutoffs here and in comparison to control. So in about just over a third of patients using SPUR definitions for infection, a molecular variant was identified. And in just under a third, a variant of unknown significance in an MSMD pathway was identified. So if we compare this to an Indian cohort that was recently published, median age of presentation was 6 months. Our cohort presented with an older age. This could be potentially due to lack of awareness and clinicians being very used to treating patients with very severe TB purely just because of the burden of TB in our setting. Interesting to note that consanguinity was very high in this cohort. In our cohort, it was not. None of our patients had a history of consanguinity. BCGosis was present in most patients, as well as MTB complex, and that there was a confirmed molecular diagnosis in majority of patients. You can see here that most presented with multi-system involvement, as did our cohort, and that the most common defect was an autosomal recessive interleukin 12 RB1 deficiency. If we look at our cohort, interferon gamma receptor 1 was the most common mutation. And if we go back to our case, she had an autosomal dominant interferon gamma receptor 1 deficiency. So if we look at the management and the approach that was taken in our cohort, is that patients needed aggressive treatment with antimicrobacterial antibiotics, and that was actually one of the most important modalities for management, and that they needed an individualized regimen in close collaboration with a TB specialist, and that the duration of treatment has to be based on the clinical response. We had 2 patients where we considered interferon gamma replacement therapy. However, their social circumstance just was deemed not feasible, unfortunately. We had 1 patient that went on to transplant, but unfortunately demised. And in majority of patients, we've able to manage them quite well with TB prophylaxis, as well as I've mentioned, really intensive therapy to get rid of the infection, or to manage the infection rather. So, it's reported that interferon gamma replacement therapy is very important to consider in these patients, but unfortunately in our context, it can prove somewhat difficult because of the social circumstance, which is not ideal. So recommendations is that the microbiology really should be involved in helping to identify these patients. The family history is very importantly part of the first-line investigations, and it's very important to exclude other PID or other anatomical pathology or other secondary immunodeficiency, and that the quantiferon gold might actually prove useful in second-line testing and is quite widely available in the South African context, and that focused third and fourth-line investigations will need to take place at the tertiary center. So in conclusion, in the context of SPUR infections, in the absence of secondary immunodeficiency, monogenic etiology should be considered. MSMD may actually be more common than previously thought, and that the South African hypendemic setting provides a very interesting context for study. The phenotypic presentation is wide and severe, and abnormal presentation should alert to further investigation. Next generation sequencing is absolutely pivotal to the diagnosis of PID and guides not only classification and diagnosis, but also clinical approach and management. And that variant interpretation when using NGS must be heeded with caution. So that's me, that's what I have to say. Thank you so much for your time. And I'd really like to acknowledge my department, hematopathology, the Division of Medical Microbiology, as well as the Vision Group. Thank you very much.
Thank you.
Thank you, Dr. Helena Cornelissen, for your very informative presentation about MSMD in South Africa and about Tygerberg as well. We'll now get to the questions and the discussion section. The first question is about the risk of developing the disease after a vaccine other than BCG. Dr. Stephen Holland, care to share your answer, please?
So I think the question refers to, is there any chance to get BCG infection after other vaccines? And no, you can only get BCG after BCG vaccine. However, all of the live vaccines do carry risks in people who have the right immune defects. We know, for instance, now that there are many people who have vaccine strain rubella virus in their skin lesions. We're not sure what that means, but it is a warning that we need to always be careful about some of the live vaccines that we're using. And we need to think hard about what happens to people after they get live vaccines. Yellow fever vaccine, for instance, as well. But for disseminated mycobacterial disease, BCG is the only risk. And I think if we keep in mind that there is the risk, we can address those issues as they come up.
All right, thank you. The second question is about whether there's a relationship between MSMD and hyper IgE syndrome.
Yeah, that's a very interesting question. So the role, hyper IgE syndrome, I'm not very, I think as Dr. Cornelissen pointed out and Dr. Elmarsafy, it's very important that we start to talk about genetic defects and to pay attention to the genes in particular. And so, as was abundantly clear in all of these talks, the pathway that we refer to as MSMD, which is very BCG sensitive, is also a pathway that's sensitive to many other organisms, Salmonella, Cryptococcus, and some viral infections. So when you talk about what happens in STAT3 deficiency or Job syndrome, they do have a higher rate of pulmonary mycobacterial disease, not so much tuberculosis, but at least not in the United States, where we don't have that much tuberculosis, as Dr. Cornelissen pointed out, but very susceptible to non-tuberculous infections. I think there is one case report of disseminated BCG in a Job's patient many, many years ago, but in general, that particular mutation in STAT3, the dominant negative mutation, does not predispose to bad BCG disease.
All right, thank you. Third question is about in those with CGD that have been transplanted, is it safe to give them BCG vaccine?
Well, I think I would be very careful about giving any post-transplant patient BCG. I'm not, BCG is very good in infants, or at least its role, its benefit is well shown in very young children. After a bone marrow transplant, I don't think that's the time to be giving BCG. Most of those people will be on prophylactic antibiotics for a long time. But Dr. Elmarsafy may have more comments about what to do in the chronic granulomatous disease context. We don't use it here in the United States, and so we don't give it.
All right, Dr. Aisha, would you like to comment?
Oh, our patients already had their BCG. all the CGD patients already received their BCG. Surely I wouldn't give any BCG for any post-transplant patient.
Okay, our fourth question is about in the prevention of TB, is it possible to use INH as well as HIV infection in HIV infected persons as well? I think that's the question. So for prophylaxis, are we allowed to use INH?
I don't know.
All right.
It's a good drug.
Okay.
We put one or two patients on INH prophylaxis, and it seems to be quite useful.
All right. There's a question on the chat about in South Africa, most MSMD patients do not present with BCG despite vaccination. Do you think this is related to the admixed population and less consanguinity or the BCG strain? This is directed to Dr. Stephen Holland.
Oh, no, I'm deferring that to Dr. Cornelissen.
All right, Dr. Cornelissen, would you like to comment?
The
question, you heard me. Okay, please go ahead.
I think a complicated question deserves a complicated answer, and to be honest, I'm not sure. But yes, I do think it's contributory. And also, as Dr. Glanton was discussing yesterday, we don't have the South African reference genome. So hopefully in space, and hopefully we can answer these questions in the next.
All right. I don't think we have any further questions. Thank you for this excellent session, very informative, and we enjoyed your presentations. And any final comments? All right. Dr. Aziz, any comments?
Dr. Baghdadi, have you a comment?
Yes, I am here.
Predisposition to tuberculosis. Okay, you have done a great work in Morocco and also in collaboration. Have you something to tell us about the predisposition of Mycobacterium? Please, Professor Jamil Baghdadi.
Yes, many thanks, Professor Bosfeha. Oui.
Yes.
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 Yeah. Yes. I will speak. Yes. Okay. Thank you very much. Thank you, Professor Bosfeha. Thanks for all the speakers, Dr. Steve Holland, Dr. Helena, Dr. Nermin. I need to thank very well Professor Bosfeha and his staff for this organization. And I want to ask some question about, because we work with the TB many years, and I want to ask Dr. Helena Cornelissen about the quantiferon of indeterminate results. When you do, sometimes you have patients and you do the quantiferon, TB Gold for the test, and you have sometimes you have indeterminate results. What do you think about this information?
Yes, that is a difficult question to ask. And we had one patient in our cohort who had an indeterminate result, and we were actually very lucky to be able to do more focused functional immunophenotyping. And that patient actually did show a defective response. So I think in the context of an indeterminate result, one should consider, is this the correct result for the right patient, all those normal things that one would do. But especially if the clinical context is suggested, then one should consider, is there a problem in the pathway? So in that case, especially if it fits the clinical picture, I would suggest going on to molecular diagnosis if that's possible. Yeah, I'm not sure if anyone else would like to comment further on.
So if I could just add, I think one very important thing to consider whenever you have an indeterminate response, remember that the interferon gamma release assay is looking for interferon gamma by ELISA. So there are two important ways that can be disordered. One is that the cells are dead, and that's why you have the mitogen assay in the first place. Another is, of course, that the cells just don't work, as might happen in SCID. But I think a more common problem is that there could be autoantibodies in the plasma that are binding interferon gamma. And so the first thing I would encourage you to think about in someone who's got disseminated mycobacterial disease and an indeterminate quantiferon assay is whether they might have an anti-interferon gamma autoantibody. This is much more common in Asians born in Asia, but we're now identifying it in people that are Asian and African and Caucasian. Not many, but that's partly because people haven't looked. And we're very interested in helping with that. If you've got indeterminate samples, people that have disseminated disease that are indeterminate for interferon gamma, please think about that and reach out if you're interested.
Yes, yes. Many thanks, Dr. Stephen Holland, because I thought before that there are interferon gamma, but there are anti-interferon gamma that, and it's why we have indeterminate results or negative results sometimes. And we have many patients, yeah, indeterminate results, yeah.
Indeterminate, not
so we have,
negative.
Yes.
So if you have
not
either
negative.
a negative, if it's a negative or a positive,
yes,
then that
yeah.
means that the mitogen
Yeah.
tube works. In the quantiferon, you have 4 tubes, and if the mitogen tube works and you get a signal,
yeah.
then whether it's negative or positive, then you do not have the autoantibody to interferon. You might have an autoantibody to something else, but not to interferon. But an indeterminate means that the mitogen tube did not work, and that would be a sign to go and evaluate for autoantibodies.
Yeah, okay. Thank you. Thank you very much, Dr. Siva.
All right, thank you all.
Many
thank
thanks,
you all.
Professor Bosfeha. Yeah. Many thanks.
Thank you all, distinguished speakers, for taking the time to join us. Thank you, Dr. Steve Holland, Dr. Aisha Elmarsafy, Dr. Helena Cornelissen. Thank you, Dr. Aziz and Dr. Jamila, for co-chairing. And we'll have a short break and then move on to the third part of the session about PID and endemic diseases in Africa. Thank you all.
Thank you very much.
Thank you.
Okay, thank you very much. Thank you to all participants coming to join us to this important session. We congratulate first this very good organization from the SOUDAN team, led by Nahla. So we are very happy to be here just to share this session with Professor Folke Madeleine. So let me introduce Professor Ahmed Mahlaoui Musa. Professor Ahmed Mahlaoui Musa is a professor of immunology and infectious disease at the Institute of Endemic Disease. He is a physician specialist in internal and tropical medicine and clinical infectious disease. He joined the Institute of Endemic Disease in 2000. Professor Musa has cumulative experience on infectious disease, especially in leishmaniasis. He is now giving specialist consultation in the diagnosis and management of various infectious diseases in Sudan. Professor Musa qualified at the University of Khartoum, University of London, and the Royal College of Physicians in London and Ireland. He was trained in a clinical trialist and monitored by the WHO. He has been the director of the Institute of Endemic Disease, University of Khartoum since January 2011. He's also the head of the Department of Clinical Pathology and Immunology. Prof. Musa acted as chairperson of the Leishmania East African Platform. It's a big man. Prof. Musa has published most of 92 publications in the reputable journal on leishmaniasis and related topics, mainly in infectious disease and tropical disease. Professor Musa is a principal investigator of many projects trying to develop combination therapy for visceral leishmaniasis and also vaccinotherapy for post-Kala-Azar dermal leishmaniasis. His main interest in the development preventive and therapeutic modalities for leishmaniasis, schistosomatitis, and tuberculosis. This is a very big man. Professor Musa, Professor, you have the floor just to give us your presentation. Thank you.
Thank you very much for this kind introduction. And I would like also to thank the organizers for giving me this precious opportunity to shed light on neglected tropical disease, which is leishmaniasis, and also primary immunodeficiency, which is, I consider, also neglected. So we can also add PID as a neglected, disease or diseases in Africa, or specifically in Sudan. So in my presentation, I will talk a little bit about the burden of neglected tropical diseases globally and specifically in East Africa. And I will also take visceral leishmaniasis as a model. And we'll talk about epidemiology and immunopathology of visceral leishmaniasis, and a little bit about the case definition, which is a typical case and the atypical case of visceral leishmaniasis. And then I will talk about the primary immunodeficiency, mainly on the estimates of cases of PIDs, the intersection and overlaps between VL and PID, and I will try to put some criteria for a suspected case of VL and PID, which is not yet, developed. So then I will put some points on the gaps in knowledge regarding the visceral leishmaniasis and primary immunodeficiency. So visceral leishmaniasis is one of the neglected tropical diseases, and WHO has defined neglected tropical diseases as chronically endemic and epidemic prone tropical diseases which have a very significant negative impact of the lives of poor and remain critically neglected in the global public health agenda. 1 billion at risk, 0.5 million die annually. Unfortunately, 50% are in Africa. There is no robust preventive measures. We have tried so many things like vaccines, bed nets, but unfortunately, we did not attain, the goal. and the treatments are far from satisfactory. They are either limited options of treatment, or the available medication are either toxic or takes longer duration for treatment, or sometimes very difficult to afford. They are expensive. The majority of neglected tropical diseases are immune-mediated, and therefore immune suppressed are susceptible to contract neglected tropical diseases. These neglected tropical diseases have negative social and economic impact. Unfortunately, coexistence is the rule. So, for example, you find so many, like more than 3 neglected tropical diseases in the same area. So you can see here, Africa is burdened by neglected tropical disease. So we have like 25 entities in Africa, in Latin America as well, but in Africa, especially the Horn of Africa, which takes the brunt of the prevalence or the burden of the disease. And you can see here Sub-Saharan Africa also involved. Of course, Sudan is one of the Sub-Saharan African countries. So this leishmaniasis, you always call it a silent killer. It is a top priority for control, and then followed by post-caloidal leishmaniasis, which we consider a reservoir of the leishmania parasite, and then cutaneous leishmaniasis. This leishmaniasis varies by region, depending on the ecology, the population density, and also the sandfly, species and so on. The endemic areas are vast, so very difficult to control the vector. We have tried the insecticides for vector control, but the endemic area is very vast, so it is logistically very difficult to, to cover all the area. So in East Africa, the documented 30,000 to 40,000 patients annually, and this needs update because there is also this amount, number is subject to seasonal variations. So the disease is very common after the rainy season, from September up to March, and then the transmission starts from March to June, and then patient will, individuals get infected, and the incubation period will be like 2-3 months, and then the cycle again ensues. The seasonal variation, sometimes the rain is heavy, so this might act against the sandfly population, and sometimes it is dry when the sandflies propagate. In Sudan, there are 8,000 to 12,000 annually, and I have to admit that the new foci started to appear. So in Africa, Sudan is number 1 with regard to number of cases, then Ethiopia, then Kenya, Uganda, and then Somalia, which we don't have proper statistics, South Sudan, and Eritrea. So regarding the epidemiology of GL, 70% of patients are of a mean age of 70 years. And this definitely overlaps with PID mean age. And this is mainly in the endemic areas. But those who are in non-endemic areas, when they travel to the endemic area, so the disease might, the mean age might be more than 7 years. Males are more affected than females, and this is maybe because of the differences and the exposure to the sandflies. There are some important risk factors, which are the age, the younger, the more you have the disease, malnutrition, of course, is very important, and then immunodeficiency, like HIV and maybe primary immunodeficiency. The disease, is fatal in 100% if not treated. And with treatment, the mortality is 5 to 20%, even with good management. I'm talking about the countryside management, where we have some hospitals managing visceral leishmaniasis. So visceral leishmaniasis is an immune-mediated disease, and usually the macrophages are infected by the leishmania parasite. The risk factors are either immunodeficiency, like secondary immunodeficiency, which is mainly malnutrition and so on, especially in children, and HIV or immunosuppressive therapies in adults, and can be primary, which is due to genetic susceptibility. So there are some field observations on VL that the clustering of cases in certain families, and we don't know so far whether this results of the genetic factors or result from the differences in patterns of exposure. And again, the mortality is very high in young children, and we don't know whether this is due to genetic factors, maybe PID, or environmental factors, or both. PICADEL which is post-colorectal leishmaniasis, is common in children, maybe because of genetic factors or environmental factors. That is to say, the exposure to UV light, which is recently wrote about it, and we conducted a study on the effect of the UV light on T regulatory cells in the skin. And the outcome is that UV light, P band 450, propagate the development of Th2 type of immune response, which is related to the pathogenesis of visceral PICADEL, post-colorectal leishmaniasis. So type 1, Th1 type of immune response is protective against leishmaniasis, and the IL-12 is critical in the initiation of innate and adaptive immune responses in leishmaniasis. It induces natural killer cells and T cells to secrete interferon gamma and favoring the differentiation of precursor Th0 cells into Th1 effector cells. Th2 response is more towards propagation of the disease with an increased production of immunoglobulins G, IgG. But we have seen some cases with low IgG, but unfortunately we did not do anything regarding the B cell or the blood plasma cell. We have never did any flow cytometry work to see whether this is due to a low CD, B cells or plasma cells. But from our observation that those with low IgG, they tend to respond poorly to treatments. And you know that immunoglobulins are required by the parasite for internalization into the macrophages. And there is a lot of work has to be done on why low IgG individuals do not respond properly to the standard of care. So during visceral leishmaniasis, the immune response is skewed towards Th2 response, although there is some Th1 cytokines. And this Th2 response usually with increased production of IL-10 and IL-13, although the messages of production of Th1 cytokines like interferon gamma and IL-2 are also present in the lymph nodes, but their expression are inhibited by IL-10. With treatment, there will be reduction in the antigen load, and therefore there will be a waning of the IL-10 effects on Th1, and as a result, there will be an increased secretion of interleukin-12 and interferon gamma and promotion of clonal expansion of cellular immune response. And these are the signs of recovery from visceral leishmaniasis. So if there is any abnormality in IL-12 and interferon gamma at any level, failure of recovery or a relapse may be the outcome of visceral leishmaniasis. And I put this in red ink so as to prepare you for the intersection with the primary immunodeficiency, because we have seen in the literature that there are some cases with, abnormality in IL-12 and interferon gamma. So the typical case of visceral leishmaniasis, a clinical history with fever, weight loss, and nasal bleeds and diarrhea, and no response to antibiotics and antimalarial treatment. Usually the patient receives treatment at home in form of antibiotics and antimalaria until, if they do not respond, then they straight away present to the hospital with hepatosplenomegaly and lymphadenopathy. And I have to mention that lymphadenopathy is very common in Sudanese visceral leishmaniasis. Is like 75% of patients with visceral leishmaniasis have lymphadenopathy, and this might be have a link to the development of post-Caldara dermal leishmaniasis after treatment. So the typical case has good response to standard of care. So the atypical case of visceral leishmaniasis is very difficult to mention any criteria at the time of presentation, but they're similar, but sometimes the spleen might be very massive. And the most important thing is that we suspect a case of visceral leishmaniasis, atypical case of visceral leishmaniasis retrospectively at the test of cure, not at the time of presentation. So any patient with relapse or persistent disease, that is to say failure to clear the parasite, or there is Bara-Caldara dermal leishmaniasis, and by Bara-Caldara that means you develop the patient develops skin rash while on treatment of visceral leishmaniasis, and you can see here the young child with grade 3 picadil all over the body with hepatosplenomegaly, and this is a typical case of Bara-Caldara dermal leishmaniasis, which is not usual. So this definitely rings a bell that relapse, resistant disease, Bara-Caldara dermal leishmaniasis might be in a case of PID. So primary immunodeficiency considered as absence of one or more of immune system components, resulting in poor immune function. The estimates in Sudan as like 8,000 to 40,000 individuals in a population of 40 million. And this information I got from Dr. Nahla, my colleague here, and it may be less than 1% per 1,000. When you consider VL, it is around 40 per 1,000. So there is a high chance to get VL with PID in such a community. So the overlap with VL is if you have, for example, a patient with Th1 defects, which is an import error of immunity, then he will be or she will be susceptible to visceral leishmaniasis, and the disease will be severe or more likely to be persistent. And if there is a Th2 defects, the patient might be less susceptible. Also, as I mentioned, that we don't know whether the immunoglobulins has any immunoglobulin G has any, things to do with the pathogenesis of visceral leishmaniasis, but they are less susceptible to VL, and this is equivocal. So defects in T cell response, that is a cell-mediated immunity, usually makes the individual susceptible to visceral leishmaniasis, and the disease will be severe or persistent. Whereas when there is low antibody, the patient might be less susceptible, but might not respond better to treatment, as I mentioned earlier, and this we call it equivocal. So the suspected cases of VL and PID, the condition is not well characterized at presentation, at the time of presentation, but we always think of VL and PID retrospectively as a test of cure, and this is a working criteria. We did not do any research on that. Failure of parasite clearance, which is sensitive to the medication in vitro. That is to say, there is failure to clear the parasite in vivo in the human body, or most of the time we consider this is parasite resistance. But when you isolate the organism, you will find it sensitive to the medication, and that gives us a clue that the problem is within the host, is not related to the parasite. And second thing is relapse, multiple relapses might be also a defining situation for VL and PID. Death also, death is very common in visceral leishmaniasis. As I mentioned, the fatality rate is 100% is not treated. But even if with treatment, this is 5 to 20%, but death in visceral leishmaniasis PID could be accelerated. And definitely we have, when we suspect, we have to exclude other causes of secondary immune deficiency, like viral screening and malnutrition, especially micronutrients like zinc and so on. So there's some genotypes susceptible to VL, like autosomal recessive, IL-12B40 and IL-12R beta 1 deficiencies. Those two conditions, two abnormalities, were identified
5 minutes to end the session.
In 2 patients with visceral leishmaniasis. Mutations of the same, of IL-12P and IL-12RB1 genes underlie the development of IL-12B40 and IL-12R beta deficiency, respectively. When you consider CVID, it is very common that increased secretion of IL-12 inducing Th1 cytokine response has been described in CVID patients. Conversely, the Th1 response necessary for normal antibody secretion is diminished. T cell abnormalities are also common in CVID, so making CVID more susceptible to develop visceral leishmaniasis. So these are the publications from SOUDAN here, and there are so many loci that determines the susceptibility to visceral leishmaniasis, especially the chromosome 21, 22, Q12, and also the NRAM1 region, and other Y chromosome and so on. So we have 3 cases: a 9-year-old girl presented with massive hepatosplenomegaly and massive pancytopenia, was diagnosed as a case of primary VL in the field.
We are at the end, Professor.
Yeah.
Maybe 5 minutes more.
Yes. in the field and received treatment, which was Pentostam. HIV was negative. A test of cure revealed presence of LD bodies in the bone marrow aspirate, and the parasite was sensitive to Pentostam in vitro. There was minimal improvement. She was referred to Sobeni Visit Hospital, a tertiary setting, and stayed for almost 8 months without benefit for treatment. She received, including interferon gamma. She died of severe pneumonia in the ward. So the lessons we learned this could be a case of VL with PID. Pentostam is not a good drug in such condition. Interferon gamma pathway of actions is defective, maybe at the level of the receptor or the liver. The second case is with hepatosplenomegaly, 7 years with pancytopenia, diagnosed as VL, and received Pentostam, no response, received liposomal amphotericin B, recovered, but no complete regression of the splenomegaly. 6 months later, he relapsed and received again liposomal amphotericin B. Test of cure were negative for LD bodies. He was discharged and was not followed up for up to date, 10 years back. So Ambizome could be the best first line treatments if we know it is VL with PID. Failure of treatment or relapse should ring a bell for combined VL and PID. So a 5-year-old boy presented to the IND, the institute, with stunted growth and massive hepatosplenomegaly and pancytopenia for 4 months. He was diagnosed as a case of VL. Suspicion of PID was made based on repeated chest infections and malaria. He was treated with Ambizome, test of cure negative, but still hepatosplenomegaly, HIV negative. He was discharged. 4 months later, he presented with jaundice and ascites, low albumin level and high transaminase, more than 1,000, with hepatosplenomegaly. He was also positive regarding LD bodies. He was diagnosed as septicemia with VL, negative viral screening. He died in the ICU because of multiple organ failures. So the outcome of VL PID failure of treatment using immune-mediated drugs, resistant disease, relapse, deaths from complications of VL, like we have just seen that septicemia can be a complication, and also public health perspectives. Those VL and PID can be reservoir of Leishmania donovani because they stay with their parasites for long. So the gaps and the way forward, would like to have some criteria for suspected case of PID VL, and would like to see whether we can give patients after recovery from VL some secondary prophylaxis, maybe in the form of Ambizome monthly, and would like also to characterize the PID, the levels of immune errors of immunity, inborn error of immunity. So we have a project that was developed already and working on the logistics at the moment. Investigators from SOUDAN who have records in VL immunology of infectious disease and PID in collaboration with investigators from the US. Final discussion will be in November, very soon, and submission for funding will be to IND. And thank you very much for your attention.
Thank you, Professor Mukadi, for this excellent presentation. Now the discussion is open, and Professor Tandaga, are you some question about this presentation?
Yeah, we have at the end, because we have spent our time. Just a great a big thank to Professor Musa for this great presentation. We are very happy to learn about Leishmania, about Kala-Azar. Yes, I remember a long time ago about that, because it's very, very, very prevalent in the East African countries than in the West African countries. But we learn a lot. The very important thing is just about the immunopathology, because we know more about PIDs, because the immunopathology of Leishman overlap with the PIDs. So we have some possibilities just to see about genetic factors, and environment factors can lead to high mortality in infants. It's a very, very important to know more about that. So we are very, very happy to learn about this your presentation. I don't know if you have any question, Madeleine Folke, or we have to close the session because people are asking me. We have to close it now. If you have any comments, someone say leishmaniasis is a vectorial disease. How or feature leads to quality of it in PID among children? So it is just on contribution. Yep. So not many questions, Professor Musa.
Yeah. Can you say the question again? I didn't get it well.
It's not a question. It's just a contribution.
It is a question. It is a question. It says, as we know, leishmaniasis is a vector-borne disease. How or what features lead to qualify to a PID, to become a PID among children? So the case definition, which is what we have been working on, I think the SPUR criteria in combination with relapse here, right? What do you think, Professor? The case definition for visceral leishmaniasis as a disease of presentation for a primary immunodeficiency disease.
Yeah, they mentioned there is an intersection between the mean age of primary immunodeficiency and visceral leishmaniasis. So the disease can ensue as early as possible because the infection takes place indoors. Sometimes inside the hut, because 25% of infection takes place within the house. So even young children might contract, the infection. And therefore, if you have a young child, 1 year old with PID, he might easily contract the disease because the vector is around.
Yeah. Okay.
Thank you very much. If you have another comments, so if you don't have comments, someone Aziz, no comment. Okay.
Thank you very much. No
thank
comment.
you very much, Professor Musa, for this great presentation. We learned a lot. I think I never know that leishmania is maybe very linked with PIDs. I know, but not in Africa. We don't have enough studies. So I very appreciate the collaboration that you have. We want to make now and to work mainly on this field between overlap between PIDs and leishmania. Thank you very much to all of you participating for this to this meeting. Thank you.
Good afternoon. It's my great pleasure, really, to introduce Nizar Mahlaoui to this Takeda-sponsored session on registries, challenges and opportunities for the African IEI registry going forward. I would like to thank the organizing committee and ASID for this Congress and for the opportunity to host this, all the sponsors, but specifically Takeda for making this session possible. I would particularly like to thank Nizar for being a true friend to ASID, which he's been, and a support since its inception in 2008, because when I asked him, it was without hesitation that he said, yes, I will do this talk. And I think he is perfectly suited to this. He is a consultant at the Pediatric Immunohematology and Rheumatology session of the Necker Children's Hospital in Paris, where he coordinates the French National Reference Center for Primary Immunodeficiencies. So he's got vast experience there. And his research focuses also on epidemiology and clinical aspects of primary immunodeficiencies. He has also been very active as chair-elect in the Society for Primary Immunodeficiencies ASID Registry in the Working Party. And he is the ongoing chair of the medical advisory panel of IPOPI, the International Patient Organization. As if that's not enough, he is also very active as a coordinator of a care transition program for children with chronic diseases going from teenage to young adulthood. So he knows what the problems of this are also as our children progress. So I think Nizar is very well suited to help us to point out what has been done, what can be done, but especially where we can go for really getting good data, getting a profile of PID-IEI patients in Africa, because all the talks have highlighted so far already our lack of what we should know, and with that, where we could help. Thank you very much, Nizar. I look forward to your talk, and then we have time for discussion afterwards, which I encourage people to partake in.
Thank you. Good afternoon, good evening, or good morning, wherever you are. Thank you to the ASID, the African Society for Immunodeficiency, for inviting me. Thank you to Monika, who is chairing this session regarding the registry, and I just wanted to introduce myself very briefly as the past ASID Registry Chair-elect and a member of the steering committee of the ASID Registry. And I think I want to discuss and focus on the challenges and the opportunities for the current decade regarding the African registry for PID. And I will have a short slide deck that I wanted to share with you, and then I think we could discuss amongst ourselves and amongst the attendees the challenges that and the opportunities that we are facing. So I will be very quick on what is a primary immunodeficiencies, or now coming back to the term that was coined in the 70s, which is inborn error immunity. And you can, I think it's very important to understand that these PIDs are rare, but multiple and complex. They need a lifelong management because they are chronic disease, and the prognosis is often severe when misdiagnosed, and we'll come to that during the next slides, or of course if they are not adequately treated. there is a significant burden of disease and burden of treatments, and these patients require high-level management and care. And I wanted to emphasize the fact that we need specialized units, especially with adults, and trained medical doctors in the adult world as well. So IPOPI has built, which I think is a very interesting tool on top of the principles of care that were published in 2014. It's called the PID Life Index. It's an internet-based tool that you can find on the IPOPI website. And as you can see on the top left, among the 6 major dimensions, there's a dimension related to registries. And I think it's really important to come back to what has been published quite a few years ago now, in 2013, and it's the job of our friend and colleague, Professor Bousfiha in Morocco, that was the projections that what we could expect to see as the numbers of patients in Africa, and it's probably around 100,000 patients if we compare the known prevalence in other countries or continents. A recent systematic review from our Iranian colleagues and collaborators compiled the publications from different continents, and I just mentioned, of course, here the reports coming from Africa. So there are Tunisia, Morocco, Libya, Algeria, Egypt, South Africa, Sudan, and you can see the difference in the registered patients, the year of reports, the distribution of the major PID categories, the proportion of genetic diagnosis, as at least when it was mentioned in the reports, and the gender ratio and the consanguinity rate, which is quite different from one country to another. This is a figure that is also in this paper, and this is the distribution at the worldwide level of primary immunodeficiency prevalence from one country to another, based on the reported patients and expressed per 100,000 individuals. And you can see there is a huge variability from one country to another, including in the same continent. For example, late in South America or even Europe. And as you can see here in Africa, there is a lot of country with a gray area, which means that the data were not available as published data, at least. Coming back to the largest PID registry worldwide, which is the European Society for Immunodeficiency 1, encompassing more than 25,000 patients. This plot can be obtained on the INGID registry website, which I think is a very interesting tool for people who are interested in this topic. And I contribute to harmonized in terms of documentation that can be used for yourself. As you can see here, almost one half of the patients fall into the group of predominantly antibody deficiency, 1/4 into the group of combined with other well-defined immune deficiency, 10% with phagocytic disorders, and the remainder is kind of scattered amongst the different PID categories as the IUIS ones. The distribution from one country or one registry to another might differ because of founder effects. Obviously, there are founder effects for some specific diseases in some countries. In Northern Africa regarding HLA class 2 deficiency, for example. Consanguinity is also a factor that might be taken into account. access to healthcare with under diagnosis or over diagnosis or misdiagnosis, and obviously at the end of this chain of factors, there is the under-reporting to the national registries. And we have published in 2017 a field epidemiology work that we performed in France, and showing that we were missing 1/3 of the patients because they were not followed in university teaching hospitals, but they were followed in private clinics or small hospitals. And the main patient group were adults with CVID for 90% of these patients that we've found out. So again, every brick in the field is of importance in terms of understanding how a registry is built and the reports that come out from these registries. So as you can see here, if you can also split up the subgroups into more finer subcategories here, and I just wanted to share what kind of data reports you can come out with your own data in the African registry if you're interested. A very recent piece of data that came out from the INGID registry is the initial presenting manifestations in PID. So you can see these data were performed out of more than 16,000 patients, which is very impressive. And the major message here is that non-infectious manifestations as presenting symptoms were more common than what we previously thought. And the age at onset of symptoms was mostly during pediatric age, but for a significant amount of patients, the first symptoms occurred during teenagehood and adulthood. Obviously, this distribution was different from one PID category to another. But what is really important here is that the infamous 10 warning signs should take into account that these symptoms, and especially non-infectious symptoms, are more prominent. And I wanted to add that the IPOPI, so the International Patient Organization for PID, has done a tremendous job in adding the many immunological biological workup in the second WHO list of essential in vitro diagnostics. And access to a proper diagnosis is key, and I think you can report to that. So for the INGID registry, we worked on working clinical criteria for registration. When you don't have access to a genetic diagnosis, which obviously would give you the definitive PID diagnosis, you can still categorize at the very fine level the patient that you are looking after. And as you can see here, for let's say for CVID, you can see that there are a number of criteria with and, or, and not, some features. And in case the patient doesn't have all of these proper criteria, you can still classify them in a more general category, such as unclassified antibody deficiency, or even sometimes in combined immune deficiency. So this work has been published and here in the JACI in practice in 2019, and we did that for all PIDs, and it's freely available on the INGID registry website, which I alluded to earlier. And we worked on the reclassifications of patients with CVID, and as you can see, pre-clinical, I mean, the patients were classified as CVID before verification and reclassification, and most patients stayed into these categories, but some of them changed and were moved to unclassified antibody deficiency, isolated IgD subclass, combined immune deficiency, and even A-gamma globulinemia. And conversely, some patients who were classified as a gamma globulinemia before these criteria were classified into CVID. And so there is a harmonization, and I think it's very important into getting more quality in the diagnostic groups. So next slide. What about the genetics? Obviously, in the registry, we can document the genetic defect. And as you can see here for CVID, most patients with a CVID were even having a LRBA deficiency, a PIK3CD deficiency, a CTLA4 deficiency. But as you can see, the breakdown of almost 25 genetic defects were also seen in the registry. A little bit more older, in 2014, we published the ISID, the criteria for clinical feature in CVID in the ISID registry. 902 patients. You can see these patients experienced a significant array of symptoms. First of them were infectious symptoms and mostly pneumonia, but also to immunity. Lymphoproliferation, benign proliferation with splenomegaly, and comorbidities such as bronchiectasis and granuloma, enteropathy, malignancy with solid tumor, lymphoma, and allergies as well. So this is very interesting to see from the a large registry what the array of symptoms of patients with different with a CVID, and this is data from a French group. Experience in managing patients with CVID. As you can see, which is interesting, is the median age of occurrence of different symptoms, such as bronchiectasis, autoimmune cytopenia, and the same overall, the same phenomenons that I was displaying on the ISID website, ISID publication, sorry. So up to 60 and or 70 years old, patients with CVID can experience PID-related comorbidities. The US IDNet registry was interested in this paper in the pulmonary disease burden. So different features of pulmonary diseases affecting the airway, the vascular component, the parenchymal component, and others, and the frequency of these features according to major PID category. And I showed a snapshot on the top right of the slide, which for CVID again, and most patients had an airway burden and parenchymal burden as well. So the two major focus. So these are data that you can also get from your registry, depending on how it is designed, implemented, and obviously documented. So really what I wanted to share with you is backbone of, as a registry, what do you want really? Do you want something, a registry with covering all primary immune deficiencies or specific primary immune deficiencies? Do you want a registry that cover children, teenagers, and adults with no age limit, or do you want to focus on some specific age group? Do you want something that is regional or national or continental or subcontinental? I should add as well, as Africa is a very large continent. So this is really key in terms of a network that you want to build and work and start working on. And some specific goals that I want to share with you, and some might be considered as primary, some might be considered as secondary. And there is no here, I didn't put any hierarchy in that. Obviously, I'm very keen into epidemiology, as Monika said in her very nice introduction. And two major epidemiological indicators are prevalence and incidence. So I think that if we are asking ourselves what is the prevalence of PID across Africa or in some country of Africa, we might have some difficulties to address a figure. So I think it is very important to consider this, but not only this, I think the diagnostic rate should be considered as well, and a registry can help measure that. We can measure or estimate the underdiagnosis, but also the overdiagnosis, sometimes in some specific immune deficiencies, such as IgA deficiency. We can fall into, I mean, it's one of the pitfalls of overdiagnosis. The calendar trend in diagnostic delay. Diagnostic delay is very important in rare diseases, including PIDs. So what it is, do we improve can we reduce the diagnostic delay over time for, let's say, all PIDs, but also some specific PIDs such as CVID or SCID even. So this is, well, yeah, so this is a figure on a worldwide map of the genetic molecular diagnosis proportion amongst different registries of PID in the world, and you know, the more red it is, the darker it is, the higher the proportion of genetic diagnosis is. So we don't have data for all our countries, but there is a significant disparity in molecular diagnosis. So what we published from the French registry, which has now more than 8,000 patients, is that the diagnosis delay has significantly been reduced over decades. And these are the decades of birth, but it's also the case for calendar decades here. And it's now around 2 years as a median delay to get a genetic diagnosis across all PIDs. But if you look into more specific PIDs, for the non-CVID B-cell deficiency, this has been really huge for combined immune deficiency, and obviously for SCID as well, since the genes were not known in the 70s or 80s. And I think it is really important to highlight that the role of registries to measure that and help assess that. Other goals is to get more knowledge on the natural history of PIDs, and especially specific PIDs. I think it's very important. Numerous papers are available now on CGD, on hyper-IgE, on other diseases as well, LRBA, CTLA4 deficiency. And I think on another note, comorbidities should be more studies, and the area of infections in all PIDs, autoimmunity, inflammation, malignancies, and other such as allergies should be also more studied. And we see now more and more papers published on these aspects. What about prognosis of PIDs? This is something that we are still wondering. Many patients ask us regarding their prognosis or the prognosis of their children, and also not only diagnosis or natural history, but also the impact of therapies. So description and impact of main therapies such as immunoglobulin replacement, hematopoietic stem cell transplantation, and other therapies as well, such as the targeted medicines. Another aspect on which registries can be very helpful is the health economics, with the aim of getting back to your Ministry of Health, for example, or health agencies, the policy makers, with all the stakeholders, including obviously patient organizations, but other stakeholders as well, to allocate and planify for the resources. So on the diagnostic aspect, laboratories, immunology, microbiology, pathology, but also radiology, and obviously the genetic laboratories, as I mentioned earlier, but also on the therapeutic aspect with the IGRT, HSCT, need to train medical students, so medical schools, but also young doctors that are already working in managing patients in an array of specific medical specialties. To consider these data for the allocation of hospital beds for IG infusions on a daily basis, for example, but also hospital beds for bone marrow transplant, and including specific units for bone marrow transplant in PID patients, adult medicine units, because many of our pediatric patients transition to adult care, and also newborn screening, as it is now implemented in many countries around the globe, such as the USA, but other countries as well. And I think it's a major step. And overall, this will help promote education, information, awareness in each country and in overall on the African continent. So I think it's one of my last slides. The achievable for me, but obviously I would be very I'm very humble here, and I'm keen on getting your insight and discussing with you and continue the discussions that we've been having since several years now. But what I think could be achievable for the current decade is getting an African PID registry at the continental level, based on an informed consent of patients for them to contribute their data, to get a set of criteria for clinical diagnosis and registration. And I think I know that this work has been already started and is ongoing. I think one can consider building a unified electronic CRF, the clinical case form. And I'm happy to share with you what we've been doing at the European level. A governance should be carefully thought and discussed and implemented. Some points here: a steering committee, a regulated access to the database for data entry and for study proposals, and a set of publication rules, which I think should be thought up front. I think a dedicated IT team should be considered, with training in automated data management steps and quality control steps. I think we also need trained staff in healthcare units. Could be medical students or nurses or data entry clerks, or of course physicians. You need to consider reporting on a regular basis on the website, on newsletter, and also obviously to help this ecosystem to work on a 10-year or 15-year process. We need to think about the sustainability and financial aspect is key, obviously, and it's not something that is trivial. I totally concede. So yeah, this is my last slide here, and I wanted to thank you again for inviting me, and I'm really looking after the discussion that we can have now. Thank you.
No, ready?
Ready.
Okay. Yes, Nizar, thank you very, very much. This was an elaborate, comprehensive, and challenging overview of what could be done, what to some extent must be done for us to better care of patients. in a continent where we actually still know very little, despite all the efforts, about what the profile is. And the profile is expected to be complex and very varied. And I just want to say that we must be missing a lot of patients. I mean, that is obvious from all we know. Abdullah Sani's report may even have missed some patients because we do have some more data collection since then. I see some of the reference are a bit older, but overall, I think the figures are not improving dramatically. So when you mention having a registry for Africa, for the continent, this is quite a sort of a daunting enterprise, which we've been trying to address. And I think some regions are far ahead. The North African Rim, I think there's a lot of collaboration with Europe, also especially with France, which has enabled quite a substantial improvement in registries already. Do you think this needs to be done for the continent in collaboration with ISID? Do you think it should be done in sections for different, because we're English speaking, we're French speaking, we're Portuguese speaking, we're all sorts of things speaking, okay?
My feeling is that we should probably think big, even though the reality principle will apply, and obviously is unescapable. And what I mean by this is that if you could start the process of a continental registry with the participation at the early stages of the major countries and the major teams that have been already working a lot on this topic, I think other teams and other countries will join, year after year. For example, at the European level, the ISID registry was created in 2004, so it's been now 16, 17 years, and countries join, little by little, and not all countries or not all medical units are contributing yet. So clearly, the data are underestimated. But I mean, even though if we know this, it's still possible to do very interesting work and to have a significant impact on the policy, on the medical training, on research, including medical thesis, but also research that can be collaborative with different disciplines, the microbiology, the pulmonology, and so on and so on. And so, I mean, this obviously, if you consider that a more subcontinental or regional approach should be decided, maybe try to each group should try to build a set of common variables, because at some point there you should consider merging, and data merging is sometimes tricky, so you don't want to redocument a second time, which is time consuming and a little bit daunting. So overall, that's why I think a continental registry should be started, and it's okay if it's not comprehensive at the very early stages. And if you want to have some knowledge of what we've been doing during the recent years at the European level, it is something that is very easy to share with you and the whole African PID community. We built a level 1, which is quite simple, to a limited set of data. And in case we want to document more features, we build some specific modules for, let's say, a specific PID or a certain PID category, which will probably be documented only by interested people. I mean, not only interested, obviously, people who have time and the resources to do it, but that will not be required. The level 1 is required, but not the so-called level 2. And we called a level 3, which is very specific for research studies, research purposes on a limited amount of time and with specific fundings to answer one or several scientific questions based on the registry and upon building a very specific data set for these research purposes. Obviously coming with financial resources dedicated to this.
I think you mentioned some important points. Think big. You might have to act small, and you need finances. I think these are actually 3 important things. And I've seen some comments, they're not really questions, but there's some comments here that trying to set up the African registry, which we've been going with for a while, it has facilitated that national registries were born. Leila said so, you know, because people did see there is a need for data. And this has happened in Algeria, Libya, and others. And another comment is, yes, we will probably need different levels. I don't know which country this comes from, but that there is a vast discrepancy on the type of explorations, I take it diagnostic, that can be done, and which in many countries is hideously expensive. I'm talking about South Africa because we are required to buy on a dollar exchange for most of our reagents. So it becomes incredibly expensive, especially for functional work. So yes, that is a comment, because that will also mean that regionally you're going to have vast discrepancy between people reporting on different levels. So I like the idea of the differential levels. I think that is important. And I think we will have to decide on the commonalities, as you pointed out, and one of them is language. I mean, it shouldn't be, because you've managed it in Europe, which has got so many different languages. Admittedly, the French registry is very, well represented by French patients, but you've managed to incorporate data from countries with many different languages.
Absolutely.
So yes, I think we can't make excuses, and we know that it's necessary. I think that's the bottom line. We have to somehow make it work. And I think the continent that is lacking most will really also yield a lot of interesting data because of the genetic heterogeneity. And as you mentioned in your talk, genetics is actually becoming feasible as a diagnostic entity, even in Africa. And there's the JMF-funded program with the in vitro panel, which is quite nicely comprehensive now for the more defined, inborn errors of immunity by clinical criteria. And I think, we do need help, though, with all of this, because after your talk, I'm actually sitting here and I'm just thinking, wow, what is the first thing we need to do? And we have gone ahead with clinical guidelines. We will talk about that in the session to follow. But we will have to adapt even those guidelines as we go along to the level of diagnostic that's available in different regions. So there may have to even be, and this is a lot of work, we've just seen on 2 clinical sort of examples, how much work it is to get this right. And everybody is working and doing this, like you've probably also done, still like in their spare time. It's not part of their paid job, So it's more a passion. but we can't do this just on passion. So I do hope, and it looks like we might have industry support for the first time, because you also mentioned this, you need IT support. We need, IT support, and that's expensive, but it's now becoming very available and accessible, as we've seen with the pandemic and with this Congress even. We haven't got the excuse that we all have to meet around a table. But just to be specific about this, what do you do in France? And I know in Europe also, you have people who actually work dedicatedly on this, right? And to collect data from different centers, and you have dedicated IT support. Is that correct?
Yeah, so there are clearly different systems and models. There are, at the European level, there are 300 documenting people working across 200 documenting centers. So it's quite a huge infrastructure. But as you said, with the electronic, it's now not a problem to have that many users. So, for example, in my team at the French registry level, which is a national level, I have a team of 4 data entry clerks that are only doing this, meaning that they travel all over the country and document the captured data based on the medical charts. And then we enter the data directly into the INGID registry. So it's all in English. And then our data, the French data, is sent to us on an automated manner, thanks to our IT team working closely with the IT team of the INGID registry, which is in Germany. There are other models in which a country has its own platform, and the data is sent on a regular basis to the INGID registry IT team in Germany. So this is the other way around, but still it works because of the common data set. At least there are common data sets, and I mean there are common data, although there are some specific data that interest some countries and that are not relevant to the INGID registry. And these people who document could be nurses, could be medical secretaries, could be the physicians themselves, could be medical students. So there is a huge, let's say, an array of people and jobs that can document the INGID registry. So I think it is really easy to document the INGID registry based on a little bit of training and a little bit of quality control, just to come back on some maybe on some misunderstanding on what is the definition of let's say when should you consider that the PID diagnosis has been made, for example. Sometimes when you look at the medical chart, it's not that super easy, but overall you get some insight. And one interesting thing also I didn't mention, but it's also to get a follow-up on the patient data, because there are some registries in which there is only one single data entry point. And for example, 10 years ago, and if you are not updating the data, you are missing a lot of potential events that are interesting. For example, comorbidities or even genetic diagnosis that has been available at the care level, but not at the registry level. So you're still, running behind, and that the data that you present is not totally accurate. I think it is not a major problem at the continental level because of the huge numbers that there are usually. But if you look at a very specific medical unit, that can be an issue if you're not updating your data.
I think you've addressed a crucial point here as well, as you saw from some of the presentations probably that have been showcased. A lot of our patients get lost to follow-up, unfortunately, especially in regions where there isn't a lot of awareness yet. So that will be a tricky one. We might get our case definitions to quite a good point. We will not always have the correct diagnosis. We will certainly not always have genetics available. And hopefully our patients can continue in care, but that is a challenge at the moment, even in centers who have a dedicated service. So that's another one where we have to think in our registries, what do we take now as the standard? We take different levels of patient enrollment. We try and get the same definitions, but it will be at different levels of investigation. And we might have to have like a spot overview, when patients are entered, but we might not necessarily have the resources to see what do they do in a year or 5 years or 10 years. I see that already as a big problem. We have that even in parts of South Africa, to have the resources to follow up the patients and see whether they're alive even or not, So, it will be challenging to get a unified type of picture of Africa. I think it will be very exciting, but it will be on different levels, hopefully with similar diagnostic criteria. I think we have to, for one, decide on one language. You mentioned English as even coming from France. And I mean, that's impressed me. If you can get that right, then I'm sure we can agree on a common language in Africa. And that then gets fed. And you mentioned another point. There is one sort of IT hub, and that's the one in Freiburg, right?
Yeah.
So one will probably have to decide on an IT hub as well for Africa. And funding for an IT hub, because in the end, it will have to be electronic data entry that we're talking about.
Right.
So those are, I think, some crucial points, which obviously also need some funding and a dedicated team. So we have a very small, at this point, registry portfolio in ASID. I can see that we can probably, enroll about 20 collaborators or so to really do this properly. But at least I think we're getting there. We're looking at guidelines. We're also discovering new problems with guidelines as we look for these. And I think it would be wonderful if we have pledged support directly, perhaps from you, as quite an expert and friend of ASID. And you have already prompted guidelines and further developments, at least for awareness to start for the conditions, and with that some data capture. And I think there's goodwill from IPOPI as well, because I believe IPOPI is also represented on the registry, on the ISID registry.
Absolutely.
And I know that we have a lot of patient organizations that are starting to flourish in Africa. I haven't seen any comments on that yet, but I think we shouldn't underestimate patient power in Africa either, as assisting with something like this. There is one question here, apart from a comment that Nala mentioned, that she likes John Laurent Casanova's aspiration model. I think he said 1% is the ideal, the ideology, 99% is perspiration, like with everything. But there was a question here also, was there a pilot run for the ESID registry? Did you pilot this, or did you just go straight in?
Oh yeah, so this is a very, very important. I totally agree with you, and I believe more than happy to accompany the efforts of the implementation of the ASID registry. So in 2004, when the ESID, the European Society Registry, was implemented, I don't think there was a pilot run. We joined them a year after, in 2005. And other countries joined, subsequently as well. What we did is that 10 years after, we completely overhauled the registry, because we were facing underreporting. underreporting because of kind of, a huge data set. So we were seeing too big in terms of data completeness. It was not optimal. So we shrinked it and in the so-called level 1. But my advice to you is to start small. Not small in a bad way, but really, and you can produce a lot of indicators and even perform significant research, and for sure it will be significant for Africa with a set of 60 data, including date of birth and date of last news and date or age group of presenting symptoms and date or age group of clinical diagnosis and so on and so on. So it's not something that is tremendously difficult. I understand that it is work, it is significant work, but I don't think you should consider having a huge data set because in our experience at the INGID level, we failed.
Thank you. I saw the message, so we will wrap up here. Thank you very much, Nizar, for giving us wonderful overview, wonderful insights, how to go forward. And I really look forward to a lot of collaboration on this. And yes, I hope that we can report more at upcoming meetings and also have in-between meetings. So I will be calling on you and on other people, and let's go from here. Thank you so much. Thank you very much, everybody.
Thank you, everyone. Thank you.
Thank you. Bye-bye.
Bye. Hello, everybody. Good afternoon, good evening, good morning, wherever you are. It's my pleasure to be here with you and co-chair with my colleagues, Dr. Shireen, and I'm sorry, I'm lost in the program. So yeah, and Dr. Alemayu, what this session called "What is New in African Inborn Error of Immunity." So we'll have four presentations with a discussion at the end of the session, and unfortunately, I will have to leave the session before the end, and I'm very sorry about that. But it's my pleasure to introduce now our colleague, Dr. Leila Jeddane from Morocco, who will give us her presentation on the new PID diseases in IUIS classification, and for those who might not know yet Leila, Dr. Jeddane is working as a scientific coordinator in the National Reference Laboratory in Casablanca, Morocco, which is a diagnostic laboratory focusing on specialized medical biology. So Leila received her PhD from the Mohammed V University of Rabat, Morocco, after studying PID epidemiology and ataxia telangiectasia mutations in Moroccan patients. Leila has been involved in the ASID since a very long time, since 2011, 10 years now, and she is currently the president-elect of the African Society. She's also the secretary of the Moroccan Society for PID and an associate member of the Laboratory Inflammation, Clinical Immunology and Allergy in Casablanca with our friend and godfather, Professor Bousfiha. So Leila, up to you now.
Thank you. Thank you, Nizar, for this kind introduction. And I need to say no thanks to the scientific committee to give me the difficult task to update you on the last iOS classification in less than 20 minutes. Well, I have nothing to disclose, and I will, sorry if I rush into it. No, the primary immunodeficiencies is now termed as inborn errors of immunity. In the last classification, there was 430 genetic disorders that were included. 64 new disorders were included in the 2019 update, and 26 additional gene defects have been described in an interim update this year, published this year. So I will base my talk on these two publications. I want to begin with the well-known disease that is now included in the IUS classifications. For example, the Loeys-Dietz syndrome was first described in 2005 and is due to TGF-br deficiency. It clinically overlaps with Job-Buckley syndromes. The Whipple's disease that was first described in early 20th century is a gastrointestinal disorder due to Trophobacter with bacterial infections. And recently, it has been described, IR4 mutation has been described as the causative genes of this disease. Going to the genes that present similar phenotypes to already known PID genes, I will begin with the KID genes. So ICOS ligand deficiency is a patient present as TILO, BILO, and KID with recurrent bacterial immunodeficiencies. More recently, the PAX1 deficiency has been described in patients with Homens-like syndrome with no thymus and T-cell deficiency that are not corrected by bone marrow transportation. A lot of new genes have been described in the hyper IgA syndrome spectrum, namely the ZNF341 deficiency that phenocopies the Job-Buckley syndrome, RBN deficiency, IL6R deficiency, IL6ST deficiency in autosomal recessive form, and more recently in dominant negative form. A new gene has been described as a potential cause of trichohepatoenteric syndrome. This is the SCIV2L. So patients show respiratory function, intraocular growth retard, woolly hair, early onset intractable diarrhea. As for the CVID phenotype spectrum, two genes have been included. Two new genes have been included in the last classification, and since then, three other genes have also been described in the interim update. Regarding inflammatory bowel disease, TGF-beta1 deficiency has been added in the last classification, with patients showing recurrent viral infection, microcephaly, and encephalopathy. There's also a description of autosomal recessive mutation in WIPK1 deficiency in patients showing recurrent infection, progressive polyarthritis, and IBD. CD137 deficiency has been added as a potential cause of EBV susceptibility, with EBV lymphoproliferation, B-cell lymphoma, and chronic active EBV infection. Regarding neutrophil defects, SRP54 deficiency has been described as a cause of Schwarzman-Diamond syndrome with neutropenia exocrine pancreatic insufficiency. And a new gene has been added in the autosomal forms of chronic common-warts disease with CBC1 mutations. Regarding MSMD phenotypes, the deficiency in the receptor beta-2 and receptor of interleukin 12 and interleukin 23 receptor deficiency have been described as well as the SPPL2A deficiency. And in the interim update, another two genes have been included in the MSMD phenotype. CIB1 deficiency is also a new cause of epidermolysis versiformis when RF9 deficiency has been described in patient with life-threatening influenza disease that is phenotypically seems like IF7 deficiency. In type 1 interferonopathies, three new genes have been described in last interim update for the Akedi-Gautier syndromes. That is a neurologic syndrome with progressive encephalopathy, intracanal calcification, cerebral atrophy, and hepatosplenomegaly. And a new gene have been included in patients showing pediatric systemic lupus erythematosus. A new gene has also been described in the Condell syndrome with patients presenting panniculitis, lipodystrophy, and autoimmune hemolytic anemia. MCM10 deficiency has been described as a cause of severe CMV infection and with HLH-like biomarkers. It phenocopies the GINS1 and MCM4 deficiencies. And TET2 deficiency has been described as a cause of that LPS-like syndrome with elevated soluble CD25, soluble fast ligand, and interleukin-10 cytokines. MAPK8 deficiency has been described in patients showing presenting with chronic mucocutaneous candidiasis and cognitive tissue disorders similar to Ehlers-Danlos syndrome. And DBR1 have been described in patients showing herpes simplex encephalitis and other viral infection of the brainstem. In the ETM update, SNOR-A231 has also been added as a potential cause of forebrain express HSV1 encephalitis, and 2 genes have been included as a causal of Mollamet's meningitis due to HSV2. No, regarding PID-related genes that were already included and then present now with new phenotype, the RAC2 defects has now been described as an autosomal recessive loss of functions mutation in severe ID phenotype, and gain of function has been described in SCID T-, B-, and K-. The Icarus deficiency has been described with dominant negative mutations in KID with low B cells, with patients presenting opportunistic of infections and increased risks of T acute leukemia. Autosomal dominant form in sorry, I think I'm yes, I'm out of time. Autosomal dominant mutations in FOXN1 haploinsufficiency is described in thymic defects with additional congenital anomalies. Interestingly, this patient can show severe T-cell lymphopenia at birth that normalized by adulthood. And loss of function dominant negative mutations in CARD11 deficiency have been described in upper IgG syndrome with early onset asthma, eczema, and food allergies. IKB mutations has now been described in gain of functions mutations in anidotric ectodermal dysplasia with ID. And dominant negative mutations have been described in STAT5B deficiencies with patients showing only the growth failure and eczema. Also, a specific allele homozygosy in type 2 can present either as MSMD or tuberculosis susceptibility. TCF3 is no included in the classification with autosomal recessive and autosomal dominant form. And autosomal recessive mutations in PIK3CD has been described in autosomal recessive agammaglobulinemia with autoimmune complications. Autosomal recessive mutations have been described as IED deficiency that are lacking on somatic EPI mutations. And autosomal dominant variant have now been included in the FMF syndrome. Autosomal dominant negative gain of functions mutations have been described in NLRP1 in patients presenting palmoplantar carcinoma, corneal scarring, and recurrent respiratory papillomatosis. As for the complement fractions C1R and C1S, autosomal dominance mutations gain of function seems to be related to periodontal Ehlers-Danlos. And there are also 3 new phenotypes that was described since 2019. Loss of functions mutation in LST in the fatal STUR-Wiedemann-like syndrome, the gain of function of CBPE, and gain of function of TAC2 in a severe fatal early onset inflammation syndrome. No going to the completely new disorders with new genes not included in IEI. The polymerase delta deficiency has been required in the CD4 lymphopenic patients. And as other keys, there was also inclusion of the C-well deficiency in kids with low B cells, and FCH01 deficiency and rare apoinsufficiency in other form of kids. More recently, SLP76 deficiency has been required in a patient with kids and low and CD4 lymphopenia. Activity in de novo mutations in NF2L2 have been described in a syndromic kid presenting immunodeficiency, developmental delay, and hypohomocysteine. Regarding the agammaglobulinemia, other genes have been described in autosomal recessive form, ZIP7 deficiency, Hoffmann syndrome in autosomal dominant agammaglobulinemia, and more recently, the FNIP1 deficiency in autosomal recessive agammaglobulinemia patient. SLC7A7 deficiency has been included as a potential cause of familial hemophagocytic lymphocytosis syndrome. In the syndrome with autoimmunity and regulatory T cell defects, three genes have been included in the last classification, namely the IL2RB, DEF6, and FEMT1. More recently, SOX1 insufficiency has been required in patients with recurrent bacterial infections and severe multisystemic autoimmunity. In the predominant susceptibility to viral infections, a lot of new diseases have been described, such as IFN-A1 deficiency, that in patients presenting severe disease caused by yellow fever or measles vaccines. RNA polymerase 3 deficiency seems to be associated to severe varicose infection, and interleukin-18 BP deficiency is associated with feminine viral hepatitis. More recently, NOS2 deficiency has been required in patients with severe susceptibility to CMV-induced disease. In the autoinflammatory disorders, two new genes have been associated with the IBD, and TIM3 deficiencies has been described in the T-cell lymphoma subcutaneous panniculitis-like presentation. More recently, a new gene has been described in patients with recurrent upper respiratory tract infection, skin rashes, abscess, and ulcers. And in the WICA1 autosomal dominant mutation have been described in a patient with recurrent fevers, and X-linked mutations of UB1 has been described in this patient with late adulthood onset treatment refractory. And finally, in the type 1 anti-encephalopathy, new gene OAS1 deficiency has been described in patients with pulmonary alveolar proteinosis. And more in interim of that, CDC42 autosomal dominant mutation is described in patients with neonatal onset of pancytopenia, HLH, and multisystemic inflammatory disease. So thank you to have followed me until now, and take a look at the phenotypical classifications. And I hope to see you in 2 years in Morocco.
Thank you, Leila, for this very comprehensive overview of the novelties
and very watched
in our field. I know it's a lot of work to keep up, because I think there are probably like 20 to 25, if not 30 new genes that are discovered every year, plus the description of a clinical phenotype that is increasing. It's probably giving us a tougher time to tougher experience to finally diagnose our patients, but obviously we are also helped by the availability of the genetic panels that are more and more available, and it's really helping. I don't know if there are any questions in the chat. Yeah, Monika, maybe you wanted to give a comment on the access of the genetic diagnosis in Africa.
Yes, I think this has really highlighted the need for it. I mean, the complexity is overwhelming, and I know that we also had patients with trichohepatic enteric syndrome where we would have never got to the diagnosis, including a post-mortem diagnosis. And it was a tremendous learning curve. And I do hope it becomes accessible. I know that Aziz has really mentioned that genetics should be available in Africa. And I think together with IPOPI and others, we have to lobby for this, okay? Awareness, access to treatment, all this. But if we don't have a diagnosis, we actually don't know what we're treating. And that makes it very difficult to motivate for correct treatment for our patients. And we might even be doing the wrong thing. So we will see how we try to do this with diagnostic guidelines. But I think really, I think we need to lobby that we get access to it. Cost-effective access, because it's also an easy way of getting samples if we have the right MOUs in place. But it's an easy way of getting samples to a laboratory instead of functional work. So it should become more accessible. It must be. Thank you.
Absolutely, yeah. Do you want to comment on that, Leila?
Yeah, well, absolutely. We really need to have this access, and to have local laboratory in Africa to offer that genetics, because it's important for this lab and for the representation in Africa of Africa in the publications. And indeed, when I was looking at the new genes, I say, okay, so many genes have so many forms. You know, we have the autosomal recessive deficiency, the gain of function mutation, the loss of function mutation for the same genes, and phenotypic is really so different. So yes, we really need to have a big panels that are PID panels that are accessible to African patients.
Can I ask you a question? Because I know you're very committed as well in the PID classification mobile app.
Yes.
So how do you plan to implement these new genes in this app?
Well, it will take time, like every, so last time I think we took 6 months to publish the app after the publication of the IUS, and so we need to. What we do is for each mutation or each disease, we look at the whole phenotype that is described. So if we need to cure, for example, the one the new one that we included in the last version should be cured again, because probably the phenotype has changed since then. So we just add every phenotype, every clinical feature that we see, and maybe the patient will have it, maybe not, but it's really a lot of work.
Sure. Thank you for doing this work. I think it's a very appreciated tool around the world. Thank you.
Thank you.
Okay, it's my pleasure to introduce Professor Monika Esser from South Africa. I think that all of us know quite well the effort and the figure Monika Esser, not only in Africa but also in worldwide. Monika Esser was one member, founder member of the ASID, a past president, and now she's working with the registry. I think this is very important. She always encouraged other countries to join into the work in Africa, and she's a member or board member of the IPOPI. She has many publications, very valuable publications from Africa, and that are published international. And I think that whatever I say, Monika Esser is a star in the field of primary immune deficiency in Africa, that we are all proud to have her today with us in this session. Monika is going to present an African IEI guidelines, challenges, and future perspectives. Welcome, Monika. You can.
Hello, my name is Monika Esser. I would like to share with you this talk on African IEI, or Inborn Errors of Immunity Guidelines. Thank you to the organizers for inviting me, and thank you to my colleagues for assisting with the work in this. And I look forward to presenting this to you, and hopefully we will make some inroads on diagnosis of PID-IEI in Africa, where and how to find them. Now, the outline of my talk, I will briefly mention the reasons and the need for Africa-specific IEI diagnostic guidelines, and I refer to IEI as PID interchangeably in this talk. The differences of IEI in Africa, some myths which we need to address, and what do we know about IEI PID in Africa. The approach I will give to ASID diagnostic guidelines for this, and then I will briefly mention the first examples of these diagnostic guidelines, namely ALPS and colitis by our colleagues Rayan Goda and Eley. And these are separate talks in this conference, which I would really invite you to listen to. So the need, first of all, for African-specific diagnostic guidelines in the area of PID. The access to diagnosis and treatment, as we know, is lacking in many parts of Africa. And this is essential for achieving universal health coverage. It should actually be a basic human right for all. Patients with rarer diseases, IEI included, have a greater diagnostic and treatment challenge to face. International guidelines, which we have been using, are not always conversant with the local diversity and with prevalent infectious diseases. And the limitations and challenges of facilities and the disparate social and socioeconomic situations in Africa pose additional challenges. What little is known or published in Africa also leads to a vicious cycle that we don't know what the true need is for facilities and treatment for these diseases. So the lack of applicable diagnostic criteria directly is an impediment to data entry and registries on the true prevalence of these diseases. As we know, rare diseases, of which IEI is one, have challenges. And our specific category, the hallmark of that is not only hypersusceptibility to infections, but also severe autoimmunity, the second most common presentation, inflammatory bowel disease, especially in infancy, dermatological and strange skin manifestations, chronic respiratory conditions such as asthma and bronchiectasis, which may manifest the end stages of these diseases already, malignancy. We know that over 400 million people are infected and that at least half of them are children. So for the not so rare, about 1% of the population may in fact be affected worldwide. The diagnostic delay for PID is known to be in the range of 4.8 years. But what about Africa? The delay may be far longer even. 30% of IEI-affected children will not survive to their 5th birthday. What about Africa, where up to 50% of children still die from infectious diseases anyway? 95% of rare diseases lack an FDA-approved treatment. And even common diseases lack treatment in Africa. Some of these figures are from the Jeffrey Medal Foundation. And summarizing some of the important items, family history is ultimately very important for diagnosis of these conditions. Collectively, they're actually not rare. An individualized approach is frequently needed, though, which makes it complex. Children are most commonly affected, but adults are also affected. And different and masked presentation is to be expected in Africa. This diagram, a lot of you may know, infection-related deaths were common around the 1900s, especially for childhood. But now survival is well into the 80s in developed nations, while in Africa, survival is still that of around the 1900s in Europe. And the reason why IEIs did not exist, so to speak, in recent times, as in this publication, is that children used to commonly die in infancy from infection. And in Africa, they still do. So we commonly make the excuse and not look for an IEI. So the expanding non-infectious manifestation of PID are well known now: severe allergies, autoimmunity, inflammation, malignancy, and an overlapping of these conditions or these presentations, which can be in a form of IEI. Differences of IEI rare diseases diagnosis in Africa. Are there some myths? Is the greatest lack of IEI awareness truly in Africa? Well, sadly, over 95% of patients are unreported or undiscovered. But underreporting and lack of registries does not mean diagnoses are not made. Anecdotally, a lot of diagnoses are made, but not necessarily reported. Inadequate or poor knowledge and lack of accessible training amongst healthcare professionals. Is that true? Well, it can certainly be addressed, as we've seen with the SARS-CoV-2 pandemic. The feasibility of worldwide electronic media and teaching and communication is surely also evidenced in this Congress, in which we are accessing a lot more people than if we had to do it real time. The lack of access to diagnosis. Phenotypic diagnosis can certainly be made with IOS phenotypic classification and even spot diagnosis with some awareness. We do know that there's substantial phenotypic and clinical heterogeneity with mutations in the same gene seen in quite homogeneous populations, but we do expect to see even greater diversity in Africa. So that may well be true. And 80% of genetic databases are derived from European stock, and African genetic database evidence, as also regional phenotypic presentation descriptions, are lacking and are very needed. So here would be a spot diagnosis with some awareness. Hyper-IgE syndrome, just a question, which variant? This child has dysmorphic features, coarse facial features, thick bushy eyebrows, which cannot be seen so clearly here, lichenified skin lesions of chronic eczema and infections. And we were fortunate in being able to access diagnosis in terms of a genetic variant here through research facilitation with our Pigeon group. This child also had the typical hallmark high IgE, which enabled us to do an NIH score, but that is mostly dependent on clinical features. So with just the description of these recurrent skin abscess, recurrent sinopulmonary infections, the flat warts, the eczema, and if it's available, the IgE, we could say that this is quite likely a hyper-IgE syndrome. And with viral infections, potentially, this would have guided us to hyper-IgE .8 variant. So another spot diagnosis, or a diagnosis that should not be missed, a very serious one, the early onset prototype of severe combined immunodeficiency. And here was a child that presented at 3 months of age with a PJP pneumonia. That should not be an occurrence in a healthy child. This child was previously healthy, was one of a thriving twin. Social circumstances were fine. The child was breastfed and there was no precipitating family history. The peripheral blood lymphocytes were low in this child and repeated low. And this was the big second alerter. This was confirmed then on subset testing, and the child had a T negative, B positive SCID. Also, with third alerter, BCG vaccinated this child, already proceeded to limited early dissemination. So this all is actually almost a clinical diagnosis. We confirmed an IL-2 receptor gene variant on a panel testing. Unfortunately, the child demised despite access to haploidentical stem cell transplant with CMV pneumonitis. So we do know that early diagnosis required, preferably under 2 months of age, for best outcome, and this outcome can be absolutely excellent with early diagnosis. We also have to be aware that leaky variants can be less severe and they can be later onset. And we would like universal neonatal screen, TREC and CREC for all, but these are not available to Africa at the moment, also with a lack of data how frequent they might occur. So we rely on more phenotypic diagnostic criteria base. And again, here we have the help of the IOS criteria. And if we have access to full blood count at least, we can look at these children with infections and low lymphocytes. Environmental factors in South Africa or Africa, there are different socioeconomic circumstances, vastly different. Healthcare availability challenges exist throughout Africa. There are differences in infections and different types of infections exposures. There are differences in gut microbiomes and determinants of delay till or until no diagnosis is achieved, and the complications thereof distort the clinical phenotype with presentation of a late diagnosis. But delay is significant, even in resource settings, due to lack of awareness. So where do we find PID reported globally in Africa? And this, fortunately, to the efforts of a recent publication by Abul Hassani, shows us where we have data recording and where we have some registries across the world. The gray shaded areas are with those basically lacking any evidence. So it is quite clear from this that the red are the ones where data and registry recording is taking place, such as North America, especially South America, regions of it, and Europe and Australia. And Africa, sadly, big underreporting is evidenced. Molecular diagnostic capacity to some extent mirrors where diagnoses are being made. North America, Europe, some of the Middle Eastern regions, some in Australia, some in Southern Africa, but it is limited. And with that also the lack of access to correct diagnosis. The prominence of autosomal recessive disorders in this publication is also interesting, showing where consanguinity and its effect on genetic diagnoses is quite prevalent. And this could easily be 20% of the world population, and certainly impacts on the type of genetic diseases that we would expect. Predominant antibody deficiency reporting on the databases is reflected right across the world, and including Southern Africa. For most of Africa, it's not known too well, but I think with consanguinity, especially in the North African region, that might be different. So this summary from the slide of Reem Al-Feki from the presentation of African IEI in 2018, very nice slide and collection of data from 17 countries and 40 responses, shows that the pattern of PID in Africa is also significantly antibody deficiency, but a lot of the reports reflected severe combined immunodeficiency and combined immunodeficiency. So the pattern varied across from the south to the north and across other African countries. As you can see here, Southern Africa, more antibody deficiency reporting, and North Africa, a mixture of severe combined immunodeficiency and others. And then also quite nicely, the estimated effect of a project or our teaching projects through ASID on primary immunodeficiency, where even just a few projects made a big difference to the reporting, like is reflected in Sudan and also in Morocco. So the African IEI diagnostic guidelines, the concept was actually born at an informal discussion at Dakar, Senegal, between Nizar, myself, and some colleagues. And the draft outline presentation was already presented at the IPOPI MAP meeting in November the same year. The core task force was approved at an ASID board meeting also in November, but with the excuse of the pandemic that we are experiencing, the first draft document was not presented at ASID as planned in October 2020 in Birmingham. But at last, the guideline format and the first two examples are being presented at the ASID meeting in Khartoum now. So the background to the guideline document, we know that Africa has a unique setting with less than 2% of PID reported for over 1.3 billion people. In fact, the continent that's growing most rapidly. The guidelines to date for increasing awareness and making a diagnosis largely relied on European data and failed to deliver consistent data collection, especially in sub-Saharan Africa. International guidelines, as we know, are not necessarily applicable to many regions in Africa. Here, diagnosis still relies on basic laboratory capacity, often only by the HIV laboratory capacity. The WHO Essential Diagnostic List can be used as a guideline for potentially or what should be available in testing in African countries. And to enable earliest PID-IEI diagnosis and capture of the prevalence and patterns and problems that we have here, African appropriate guidelines must take into account the resource capacity that we have right now in a region and the exposure to regional epidemics and the patterns. Genetic diagnosis, which is rapidly decreasing in price and becoming more available, must be pursued through collaborations wherever possible, as we're expecting many novel variants in Africa. The clinical presentations, as we know in PID, can be very variable, but especially the increased susceptibility to infections in the respiratory tract must be interpreted against the background and the context in which we see our diseases of very diverse social backgrounds. PID should be suspected in the patient with a family history of primary immunodeficiency with a need for IVI antibiotics to clear infections, with 2 or more pneumonias in 1 year, and with especially BCG dissemination in an HIV-negative infant and 1 or repeated liver abscesses in childhood. With the proposed guidelines, awareness must be raised amongst healthcare professions, targeted to meet the specific needs of a region or country. And with work on such guidelines, it is proposed, and it is one of the big aims of this guideline document, that data collection registry information can be facilitated for ASID, with a focus especially on sub-Saharan regions with almost totally deficient data. New also, the new kid on the block, is that the industry and the non-profit organizations show increased interest in furthering data collection, both for commercial and ethical regions. So the methods, a task force has been combined, inclusive of an advisory board, and this was to identify African alerting clinical phenotype to promote locally applicable diagnostic guidelines. The structure of the task was a working group convened per topic, but 22 members proposed of 11 countries, a core group of 3, an advisory panel of 10 people representing 9 countries. The mechanism is that induction meetings are held for working groups, a topic is decided on, 2 sample diseases were chosen and guidelines formulated, and these are yet to be trialed in a practical setting. These trialed guidelines, as for the rollout to several working groups, will then proceed with further topics that will be trialed. The increased patient diagnosis and data or registry reporting is an expected outcome of this. So just briefly, the diagram, which in a cycle goes to end up with established guidelines by review of publications also, especially in Africa, by drafting by an expert, review by experts, and an advisory review. We take as a guideline still the IUAS categories and of the recent publication, and our focus for this was the diseases of immune dysregulation and the two examples quoted. Now, we have to be careful. The IUIS criteria also are a working framework, the best effort for what we know of IEIs and IEI diagnosis now. Substantial phenotypic and clinical heterogeneity are expected, especially in Africa, with possibly interacting genes. Heterogeneity between individuals of the same pedigree could be modified by certain environmental factors and other interacting genes. Distinct mechanisms we know vary, whether it's gain of function, loss of function, for example, as well as the mode of inheritance. And the complex African genotype and other genes and pathways may be relevant for the types of conditions we see here, and we need functional work on this. Literature and case reports of IEI, as stated before, in Africa, very limited, and there is very different environmental exposure. European and North American variants, therefore, reported as likely benign, may in fact turn out to be significant in some of our African patients. So the first ASID diagnostic guideline examples are those of ALPS. We see lymphoproliferation, fevers, cytopenias in Africa, not uncommonly. So could this be an IEI? And this is worked on by Rayan Goda. Another common clinical presentation, potentially of IEI, is infantile diarrhea, or diarrhea in the small child, and recurrent infections. And this is further discussed and elaborated on in the guidelines by Ali Sob. So what are the pointers to IEI PID in Africa, just more generally? We must exclude the locally endemic infectious diseases. Pay attention to family history and consanguinity. We must be aware of early or very early onset of such diseases, for especially the monogenic forms of IEI. Severe, persistent, unusual, recurrent, or SPUR manifestation, that mnemonic holds in Africa as well for infections or other dysregulations. And we must look at different cost-effective available drug regimes that have to be considered in our setting, and we must encourage follow-up for complications and possibly malignancies. So here, for the phenotypic IUIS classification, we have chosen immune dysregulation for the first two examples, and these are immune dysregulation with autoimmunity. And the first one that will be discussed by Rayan Goda is autoimmune lymphoproliferative syndrome. And you can see here chronic adenopathy, splenomegaly, and then cytopenias is what is the hallmark of this condition. And this we see commonly in Africa. Immune dysregulation with colitis, certainly diarrhea, is a common manifestation that we see in children, especially in Africa. I would like to point out this brief comment or short publication by Andarasa from Kenya. It is a very nicely written article on the crossroads between autoimmunity and immunodeficiency in our African setting. So autoimmune hematology is a very important warning sign for IEI dysregulation, and multilineage cytopenias, autoimmune hemolytic anemia, non-responsive, persistent chronic ITP, thrombocytopenia purpura, and autoimmune neutropenia in a patient older than 2 years and or persistent for more than 24 months are very important warning signs. And this publication by Notarangelo et al., and this one, cytopenias accounted for 31.4% of all forms of immune dysregulation. What's important is the relative risk of developing autoimmune hemolytic anemia that is 830 times higher in PID patients than in the general population. And I won't refer further to this, but this is a nice flow diagram. So the take-home message so far is do not miss inborn errors of immunity presenting with non-infectious diarrhea, especially under 6 years of age or in the infant period, persistent cytopenias, especially multilineage, severe rashes, unresponsive to conventional therapy, multisystem autoimmunity, other features of immune deficit, for example, granuloma, as we can see in chronic granulomatous disease, relevant family history, especially with consanguinity. So the summary approach to ASID-IEI guidelines so far, we are on an African journey with African pioneers at last. We must always exclude the common disorders for causes of infections, obviously. We must discuss complex patients in teams with different expertise and consult bedside to bench to the laboratory available and vice versa. We must document patient cases and capture data for future re-evaluation, especially with expanding genetic capacity. We must collaborate with multidisciplinary, often international teams, where pathogenicity of a novel gene defect and variants of unknown significance must be reviewed stringently and must be validated. Treat ethically and responsibly to the best current capacity and follow patients over time and continue learning. As Robert Good said, our patients are our greatest teachers, or as I may add, they are the living laboratory. Thank you, especially to Reem and to Nala and to all my patients who continue teaching me, and to my colleagues who freely share their wisdom and their enthusiasm. Thank you.
Thank you, Monika, for your great presentation. Really, it's marvelous and we enjoyed it a lot. We will save the time and the discussion will be at the end of the session. And now my dear colleague, Tennessee, will introduce the next speaker.
Thank you very much. It's my pleasure to introduce Dr. Rayan Goda. Dr. Goda is a clinical immunology specialist and the treasurer of the African Society of Immunodeficiency. She has a special interest in inborn errors of immunity as well as diseases of immune dysregulation. She currently serves in the Immunology and Allergy Clinic at SOBA University Hospital in Khartoum, Sudan. She's also a member of the Sudanese Society for Clinical Immunology and Allergy. So she will be presenting us on the African guidelines for the ALP syndromes. So I will like to invite Dr. Goda to conduct the session. Thank you very much.
Hello, everyone. I am Rayan Goda. I am a clinical immunology specialist with a special interest in inborn errors of immunity and diseases of immune dysregulation. Currently, I am a research fellow at the Department of Clinical and Experimental Sciences at the University of Brescia in Italy, and I am a member and treasurer of the African Society of Immunodeficiency. Today, I will talk to you about the African guidelines for the diagnosis and management of the autoimmune lymphoproliferative syndrome. Autoimmune lymphoproliferative syndrome is a monogenic primary immunodeficiency disease caused by genetic mutations in genes encoding FAS ligand and caspase-10. The African Society for Immunodeficiency Board formed a committee to address the lack of guidelines for the diagnosis of different primary immunodeficiency diseases in Africa. And this committee of experts constructed a standard operating procedure, or an SOP, for the diagnosis and management of inborn errors of immunity. And they divided all of these inborn errors of immunity into different groups. The first group to be addressed was that of diseases of immune dysregulation, and the first disease to be studied was autoimmune lymphoproliferative syndrome. An SOP was generated, reviewed, and processed by this committee of experts via meticulous checking and reviewing via recurrent online meetings. And expert independent reviewers were consulted to approve these guidelines and its applicability within the region, from within the region and in the region. The objectives of the SOP was to generate guidelines for the diagnosis of diseases of immune dysregulation. ALPS was the first inborn errors of immunity to be studied, and we aim to increase the awareness of PID in Africa, to facilitate common pathways for the diagnosis of ALPS in the low resource setting and the limited resource setting that we all have in Africa. And this will help us identify more patients and activate a primary immunodeficiency database in anticipation of the African PID registry. We conducted a meticulous PubMed search, and we found only around 8 PID reviews, including case reports that included ALPS. Most reviews were national longitudinal cohort analyses of PID centers in Morocco, Tunisia, and in Egypt. We compared these findings to mainly we compared how these centers diagnosed and managed their reported patients to the main criteria that are internationally used for the diagnosis and management of ALPS, which are the NIH criteria and the ASID criteria. I will review the NIH criteria and the ASID criteria. The NIH criteria requires required criteria and an accessory criteria. The required criteria for the definitive diagnosis of ALPS, you have to have both of the required criteria, including chronic, which is more than 6 months, of non-malignant, non-infectious lymphadenopathy, or splenomegaly, or both, with elevated CD3 positive, TCR, alpha beta positive, CD4 negative, CD8 negative, double negative T cells, or just double negative T cells of more than 1.5% of the total lymphocytes, or more than 2.5% of the total CD3 positive lymphocytes in the setting of normal lymphocyte counts or increased lymphocyte counts. The accessory criteria, it includes primary and secondary accessory criteria. The primary accessory criteria includes defective lymphocyte apoptosis in 2 separate assays months apart, and somatic or germline pathogenic mutations in the presence of somatic or germline pathogenic mutations in fast ligand or caspase-10 elevated. And then we move on to the secondary accessory criteria, which include elevated soluble fast ligand levels, or plasma interleukin 10, plasma or serum interleukin 10, elevated plasma interleukin 18, or elevated plasma or serum vitamin B12 level. The presence of typical immunohistological findings on lymph node biopsy, typical of ALPS, autoimmune cytopenia, and elevated immunoglobulin levels, providing that it is it's a polyclonal increase, it's in polyclonal hypergammaglobulinemia, family history of a non-malignant, non-infectious lymphoproliferation with or without autoimmunity. For the definitive diagnosis of ALPS, patients must have both required criteria and 1 accessory criteria. However, ALPS diagnosis is probable when patients have both required criteria plus 1 secondary accessory criteria. However, for the ASID criteria, it's a little bit much more simpler. The diagnosis of ALPS requires at least one of the following clinical criteria: splenomegaly with lymphadenopathy of more than 3 nodes. Both has to occur for more than 3 months. It has to be non-infectious and non-malignant. The presence of autoimmune cytopenia of equal to or more than 2 lineages, history of lymphoma, or an affected family member. Positive history of an affected family member. And then at least one of the following laboratory criteria: increased double negative T cells of more than 6% of the total CD3 positive T cells, or elevated biomarkers of at least 2 of the following: soluble Fas ligand, vitamin B12, interleukin 10, or impaired Fas mediated apoptosis. Given these internationally accredited criteria, we came up with our own African guidelines for the diagnosis of ALPS, which include chronic lymphadenopathy for more than 2 months since the onset of symptoms, splenomegaly plus or minus hepatomegaly also for more than 2 months from the onset of symptoms, autoimmune cytopenia, and positive family history of a similar condition. These are the clinical criteria. We have to, however, if we have a patient with these clinical criteria, we must rule out endemic diseases, infectious causes, TB, HIV, parasitic infections, malaria, leishmaniasis, or viral causes such as EBV and so on. If they are present, we have to, or if we suspect anything, we have to refer the patient to an infectious disease specialist for further diagnosis and for further investigation and management. And if the patient is clear from these endemic causes, then we will do more investigations, mainly through complete blood count, immunoglobulin levels, autoimmune profile, mainly ANA profile, lymphocyte subsets via flow cytometry, including double negative T cells, excisional lymph node biopsy or FNA, plasma, or serum vitamin B12 level. If possible, we can, if we have the means to measure soluble Fas ligand levels of vitamin interleukin 10 or interleukin 18, then we can also measure these. So if the patient has normal or elevated immunoglobulin level, mainly IgG, with positive ANA, consistent lymph node biopsy findings with ALPS, high double negative T cells, serum or plasma vitamin B12 level that is increased of more than 1,500 nanograms per liter, with either high soluble Fas ligand, interleukin 10 or interleukin 18, then the patient is most likely an ALPS patient. If we have a patient that is most likely an ALPS patient in our low resource setting, please treat them as an ALPS patient. Do not hesitate and treat them as an ALPS patient. Check how increased are the double negative T cells. If the double negative T cells are increased at more than 6% of the total CD3 positive lymphocytes, given that the patient has normal or elevated lymphocyte counts, then the patient is an ALPS patient and you have to treat them. So to recap, a patient is diagnosed as having ALPS if he has 2 or more of these clinical criteria and 3 or more of these laboratory criteria providing and including high double negative T cells. The treatment includes a multidisciplinary team approach with hematologists, immunologists, and rheumatology. Patients are to receive corticosteroids, mainly prednisolone, either orally or via IV methylprednisone, which then the patient can be shifted to oral prednisolone to be tapered slowly. In case of refractory disease with autoimmunity, vaccinate the patient and review their vaccination status, give them boosters or give them Pneumovax and Prevnar vaccines, and start giving the patient IVIG. or 1 to 3 dose, high dose IVIG, 1 to 3 doses. Or if that doesn't work, you can give the patient rituximab and consider immunoglobulin replacement therapy after starting rituximab, or you can give the patient rapamycin or sirolimus, and you can also give the patient mycophenolate, mofetil, or cyclosporin. If all of these immunosuppressive agents do not help your patient, consider splenectomy, and if that is unfeasible, you can give the patient cyclophosphamide or even consider hematopoietic stem cell transplantation. Please remember that these drug doses can be modified based on the discretion of the treating physician and the consulted specialist. Collaboration points to address, special points to address. Collaboration is to be facilitated between the different African countries with exchange of expertise between these designated PID centers to facilitate diagnosis through online case consultations, grand rounds, and the ASID newsletter. Later on, patient samples and patients can be actually referred to one of these centers either in Africa or to other international designated PID centers by means of international collaboration. I would like to thank our core group, Dr. Nahla Erwa, Professor Monika Esser, Dr. Rima Al-Faqi, and Dr. Ali Subh, and our independent reviewers, Professor Muhammad Ridha Barbouche, Dr. Nermeen Jalal, and Dr. Ayman bin Mustafa. And special thanks goes to NBI, National Bioproducts Institute, and specifically to Dr. Sagania Moodley for facilitating our core group meetings. And I would like to thank you, and I would like to welcome all your comments and questions. Thank you all very much.
Thank you, Dr. Goda, for a very nice presentation on the African guidelines for the ALPS syndromes. Now we proceed to a discussion by Professor Ali Subh from Egypt. He's a lecturer and consultant of pediatric immunology at Mansoura University in Egypt, and his clinical research focus is phenotypic and genotypic studies of primary immunodeficiency disorders in Egypt and HSCT in primary immunodeficiency. So I would like to leave the floor to him to discuss on the African guidelines for diagnosing and managing immune dysregulation with colitis. Thank you.
Hello, I'm Ali Sorh, a pediatric immunologist in Mansour University Children's Hospital, Egypt. I'm happy to talk to you today about African guidelines for diagnosis and management of immune dysregulation with colitis. The objectives of this work are to estimate the actual burden of immune dysregulation with colitis in African countries, be part of the efforts to build up a registry for important areas of immunity in African countries, establish African guidelines for management of very early onset IPD based on the burden of the problem and available resources. We searched databases for published papers, including review articles, guidelines, case reports, and series for very early onset IPD, and looked specifically for publications from African countries, and communicated personally with physicians giving care for patients with very early onset IPD in African countries. Globally, 20 to 25% of patients with IBD develop intestinal inflammation during childhood and adolescence. A rapid increase in the incidence of very early onset IBD is noticed in many studies in Canada, Europe, Australia, 4 to 15% of pediatric IBD. Al-Husseini et al. Reported a higher prevalence of early onset IBD prevalence and infantile or toddler onset IBD about 9% in the largest multi-center national study of patients presenting with very early onset IBD in Saudi Arabia. In African countries, very few case reports are published from Nigeria, a novel mutation of IL-2 receptor from Mansour University Children's Hospital, Egypt, and some cases from Cairo University, Egypt, published as part of multi-center international efforts of targeted panel gene sequencing for early onset inflammatory bowel disease and chronic diarrhea. Pediatric IBD can be further classified into pediatric IBD if the age started less than 17 years old, early onset IBD if less than 10 years old, very early onset IBD if started less than 60 years old, infantile and toddler onset IBD in kids less than 2 years old, and if it started in the first 28 days of life, it's called neonatal IBD. Genes linked to monogenic IBD can be also classified into impaired mucosal immunity, and the best example is CGD and XIB, loss of tolerance as in IL-10 receptor defect and IBIX, diverse mechanism as in hyperinflammation in LRC4 and stimulation signaling and costimulation as in ICOS, and some may be classified due to epithelial barrier defect. We looked first for the ASID diagnostic criteria for a very early onset IBD, histologically proven inflammatory bowel disease diagnosed with an onset at pediatric age, with the following differentiation of age of onset: infant onset less than 2 years old, neonatal less than 28 days. Plus exclusion of infectious causes, bacterial, viral, parasitic, and at least one of the following: failure to thrive or increased values of calprotectin stool. Based on this and on available resources and endemic disease in African countries, we proposed our ASID diagnostic criteria, which include clinical criteria in the form of rectal bleeding, diarrhea, abdominal pain, perineal disease, failure to thrive, age younger than 6 years, family history of similar condition. and exclusion of other differential diagnoses, especially infectious causes, which are very important in African countries due to high prevalence of many infectious causes presenting with similar presentation like early onset IBD. Also, malabsorption syndromes and food allergy should be excluded. Laboratory criteria include elevated inflammatory markers, fecal or serum calprotectin if available, and note that it's not accurate in infants less than 1 year old. Confirmation of diagnosis by endoscopy and pathology. For confirmation of a diagnosis of IBD, classification into Crohn's or ulcerative, localization, and also assess severity. And then this is our diagnostic approach. After clinical suspicion based on history and examination, exclusion of other causes, radiology and endoscopy to confirm, classify, and assess severity. And then further laboratory evaluation, which may be a clue for the diagnosis of immune dysregulation, like CBC, presence of anemia, neutropenia, lymphopenia, thrombocytopenia, eosinophilia, are all markers of many immune dysregulation disorders. Immunoglobulin levels are very important because we can diagnose agammaglobulinemia, CPID, hyper-IgM, and hyper-IgE as a provisional diagnosis by using immunoglobulin levels. Lymphocyte subsets will help too much in diagnosis of agammaglobulinemia if there is absence or very low level of B cells. Also, severe and combined immunodeficiency can be diagnosed by lymphocyte subsets. Chronic granulomatous disease can be diagnosed by using neutrophil oxidative burst. And some additional functional studies, if available or after referral to specialized centers, like FOXP3, diagnosis of ALPS, XIV, and IL-10 suppression test for diagnosis of IL-10 and IL-10 receptor deficiency. And finally, genetic testing in specialized centers is required in many cases to confirm the diagnosis, to choose the appropriate treatment and definitive therapy. This is also our therapeutic approach for very early onset IBD. If the patient presented in severe condition or critically ill, we'll start with fluid resuscitation, nutritional support, and antibiotics if there is evidence of infection, and steroids. After stabilization or presented from the start with mild and moderate condition, we will start with conventional treatment like amino salicylates, steroids, and nutritional support. In refractory cases, we can add infliximab, except if CGD is suspected or confirmed, because it may increase the probability of flaring or mycobacterial infection. In presence of clinical or laboratory features of monogenic IBD from the beginning or resistant to all lines of treatment, here we should think about monogenic IBD, go to genetic treatment, and start targeted therapy. Examples of targeted therapy are abatacept, which is CTLA-4 fusion antigen, and help in ameliorating many autoimmune features in CTLA-4 and LRB, including inflammatory bowel disease. Vedolizumab and osteconumab also can be used for treatment of CGD. Osteconumab is an anti-IL-23, which is overstimulated in CGD, and vedolizumab inhibit adhesion molecules, so inhibit adhesion of T lymphocytes to the endothelial cells and prevent inflammation. Anakinra, which is an IL-1 receptor antagonist, can be used in conditions with hyperinflammation states like IL-10 receptor deficiency. And finally, bone marrow transplant will be the definitive treatment of many conditions like IL-10, IL-10 receptor, IBIX, Wiskott-Aldrich, SCID, CD40 ligand, XIB, CGD, LRBA, CTLA-4, and LUK8 deficiency. Also part of our recommendations or guidelines, management of complications like failure to thrive, infections, and surgical complications. Patient follow-up should be close intervals at the beginning of treatment, and to receive the biologic therapy if prescribed. and then later on maybe every 3 to 6 months if according to the patient condition. Immunization is a very important point in follow-up and management of patients with very early onset IBD because they receive immunosuppressive treatment and they are still in the immunization age. So immunization status should be checked at the beginning of treatment. If the treatment is not planned immediately, so we can give any remaining immunization 4 to 6 weeks before starting immunosuppressive therapy. If the patient is on steroids, we can start the live attenuated vaccination 1 month after end of treatment. In case of other immunosuppressive or biological, we wait till 3 months, while inactivated vaccines can be given during treatment without any harm. Also, household contact should be vaccinated, either inactive or live active vaccines, but anyone developed varicella rash should avoid contact with the affected child. Patient support groups and leaflets to increase the awareness of patients about the disease, prognosis, outcome, and the treatment lines. Our conclusion or take-home message: very early onset IBD may be the first or sole symptom of underlying PID, so consider it. Possible predictors are an early onset of disease, failure to respond to standard immunosuppressive therapy, consanguinity, increased susceptibility to infections, and concomitant symptoms suggestive of PID. Very early onset IBD diagnosis is challenging, especially in Africa, due to high prevalence of infectious disease with similar presentation. Multi-center collaboration is essential to facilitate early accurate diagnosis, registry formation, and establish guidelines. If IBD causing PID is suspected, early initiation of stepwise immunologic diagnostic that allows assessment of key immunologic function and related disorders advised. Accurate genetic diagnosis is required for assessing prognosis and proper treatment. Monogenic disorders are resistant to conventional treatment and need targeted therapy. The formation of local patient support groups is encouraged. Finally, I would like to thank authors Dr. Emilfi, Dr. Nahla Erwa, Dr. Monika Esser, and also Rayan Goda, who started the journey with me at the beginning of working on the immune circulation disorders. And thanks for all of you.
Well, thank you, Dr. Ali Sobh, for your very nice presentation. And we are now looking for the questions. We'll start the questions. Do we have questions here in the chat room? Yes. Yes, I'm looking for from up down. So it's only one question, and it's where is it? There is one for Kinsey. I think that they have many other things here. Can you read the question, please, because I can't find it here.
Okay. Okay, I will do it.
Yeah, there is a question. Different African regions are at different levels of PID data. How can this be harmonized? So this is the first
This question was for the registry talk. Sorry. No. Yes. So the question is how to differentiate is for Rayan, how to differentiate LPS from the neoplastic disorders.
Usually we depend on histopathology to differentiate between especially lymph node histopathology. And we look for specific markers for autoimmune lymphoproliferative syndrome. But mainly we rely heavily on histopathology in such cases.
other question? Can't see.
No.
May I ask questions?
Please.
Yes, okay.
Yes.
Okay, I'll start with Monika first. You presented the challenges of the identifying primary immune deficiency, or IEI, in Africa. We have, of course, the endemic infections, and we have the malnutrition and many other causes. But would you do you think that this is only because we have the endemic infections, or the lack of awareness, plus the physicians may find that looking for IEI in their cases is a bit rare or a bit difficult to pursue the investigations everywhere? Do we need to tackle other specialties like the hematology, the rheumatology, the other, the ENT, other specialties just to give the awareness about primary immune deficiency?
Yes, Shireen, I think it's all these factors coming together, obviously. It's not just that we can go to the infectious diseases specialist and say, listen, these diseases are hiding amongst all these endemic diseases. I agree with you completely that it's good to create, it's essential to create awareness with all our specialists. As I pointed out, you know, the hematologist would be picking up a lot of our patients. The oncologist would be picking up some of our patients. It's just that it is an additional awareness that has to be created quite strongly. But I think a lot of the patients we will find with our infectious diseases specialists, or with people dealing with infectious disease. We don't have specialists everywhere. That's another thing. It will be at different levels everywhere.
You know, but for any case with, for example, ITP, they go directly to the hematology and they spend time, maybe years, giving treatment and looking for the chronic ITP, and then at last maybe they hear us from anywhere else, and then we say that sometimes the common variable have the ITP, so they start to send us the cases. Okay, you can examine them and you can investigate and look for the CVID. And I'm talking for CVID especially because we have many cases were referred to us from the hematology. And after receiving years of corticosteroids, IVIG, immunosuppressive drugs. So the investigations here is more or less will rely on the genetics, because I think the picture of the cells and the immunoglobulins will be affected by the treatment of a long time, for a long time.
Yes, I mean, I think we agree that we need the help of genetics after the creation of awareness, so that first of all, the questions get asked and the patients get referred. And I think it's at all levels. And I think the pathologists, like in Kenya, the pathologists make a lot of the diagnoses, actually. It's quite interesting. And there it's awareness in the lab. And as you saw with atypical mycobacteria, or environmental mycobacteria, again, the diagnosis can be triggered, or the odyssey can be triggered in the laboratory already. So it really is awareness at all levels, but we can't keep on making excuses that we can't find these patients or that we haven't got access to things. I think it starts with awareness, asking the questions, and then using whatever you have available in terms of diagnostic capacity. And like Jean-Laurent said yesterday, he says there's no excuse. We're always open to communicate, and it just takes an email and we're happy to assist. But it takes extra work. Thank you.
Great, thank you. And any questions for Rayan? Our presentation was excellent, really. And I admired a lot the schematic approach of the guidelines here. And I'd like to ask, how many of the cases with ALPS did they have the hemolytic anemia? Do you know?
I think about, from the publications that I looked at, actually most presented with hemolytic anemia.
Yeah.
Most of the report, as most of the publications were general PID publications, which had actual ALPS cases reported as case reports from the center experience. So most of the main presentation was autoimmune hemolytic anemia. in most of these patients.
And were they coming firsthand or referred to you from the hematology, for example, or the infectious disease? Or
I'm not sure because most of these are, as I said, it's a multi-center experience reports. So
my question is that because we all the time we have the cases of ALPS are suspected to have malignancy, and then they come back because they didn't find anything to support the diagnosis.
The diagnosis of malignancy.
The diagnosis of ALPS. So probably there is a delayed diagnosis in some cases, and but your scheme is very nice. You presented a very nice presentation. I really admired it.
Thank you. We tried to make it extremely approachable and memorable. So that's the goal.
It will be published somewhere because we need it really, and we can distribute it to other subspecialties.
Exactly. Yes. That's the main aim, yes.
Yeah. Thank you, Rayan.
Thank you so much. Thank you.
So, okay, I'm gonna introduce Professor Ridha Barbouche. So we'll start now, or is he on air or not yet? Okay, that's fine. So it's my pleasure to introduce my dear colleague, Professor Ridha Barbouche. Professor Ridha Barbouche is a very known figure, a well-known figure in Africa and worldwide. He's a professor of immunology and assistant dean research at the Medical School University of Tunis, El Manar. And he is the head of clinical immunology department and director of research laboratory at the Pasteur Institute of Tunis. He's also a member of very important and valuable societies worldwide, and one of them is the IUIS. I'm very pleased to introduce Professor Ridha Barbouche, and the mic is yours now.
Okay, thank you so much, Shireen, for this kind presentation. Thank you so much. So it's my great pleasure to be here with all of you. So I think that we have shared 2 fantastic days of science, and I'm trying just to share my screen. Okay. Okay, thank you so much, Shireen, for this kind of introduction. It is a great pleasure to be here with you today, you and all our colleagues, the old and the new friends. These have been 2 fantastic days of science, and it is a great pleasure to see how much we are going forward with this topic of PIDs in our continent, and that's really fantastic. By the way, I did enjoy the colorful presentation for the website and all the work done by, I guess, the whole group. And I would like to thank particularly Nahla, Aziz, and all of those who have contributed in one or another way. So today I'm going to talk about the STAT3-related hyper-IgE syndrome to define that what we have proposed as the new entity, and to discuss molecular basis of these diseases and link with clinical aspects, of course. So as you may certainly know, IgE, high levels of IgE and eczema and allergic manifestation are very common in many primary immunodeficiencies. And it's well known that in atypical complete disorders, or in Omen syndrome particularly, we have significant features on with hyper IgE, increased level of IgE. It's the same in the IPEX syndrome, as you know. And here, probably some effect of regulation plays a role in the increase or the expansion of Th2, which are responsible for the excessive production of IgE. Similar features are observed in very common atopic dermatitis where there is a defective skin barrier that is much more strikingly observed in the Comel-Netterton syndrome. And both are responsible of defect in cytokines on the epidermal level and could be responsible, of course, of excessive response of IgE, but infections as well. We have also the Viscott-Hadrich syndrome, where we have a cellular cytoskeleton defect. It is a little bit similar to what happens to DOC8 in DOC8. And here there is a problem in the synapse, and there's probably a defect of immune responses who are responsible both on the Th2 expansion and the recurrent infections that are observed. So in many of these diseases, we have either allergy or allergy and infections. So what oppose these to the hyper IgE syndrome? Hyper IgE syndrome is a complex disease where we have not only this triad, this characteristic triad with the eczema, the recurrent infection, which affect mainly the skin and the pulmonary tract, but also we have this excessive IgE production. In hyper IgE syndrome, this IgE production is extremely high. We are talking about figures like 100,000 international units per ml. So it's extremely high, not always, but very often it's extremely high. But we have these immunological features in hyper IgE syndrome, but we also have characteristic non-immunological features that I'm going to discuss with you. So the prototype of hyper IgE syndrome is the STAT3 deficiency. This is an autosomal dominant transmission, which is responsible of very complex disease where we have this susceptibility to infections with mainly cold abscesses, what we call cold abscess, because inflammation is not working very well. And as you know, in these patients, there's an impaired IL-6 signaling, which is a major feature of these diseases. So inflammation is not very good, and these are called cold abscesses. So these patients have a lot of abscesses on their body, and their skin is covered with abscesses sometimes. And it's very difficult in terms of clinical features, of course, and treatment. So this IL-6 signaling defect is also responsible in STAT3 deficiency of impaired Th17 development and candidiasis, susceptibility to candida. This is another feature of this STAT3 deficiency. Moreover, we have in STAT3 deficiency, we have an impaired IL-21 signaling, which is responsible of defect of B cell differentiation and class switch, and will contribute to antibody deficiency and unbalanced IL-4 production with excessive IgE production. All of these contributing to the clinical symptoms I've just discussed with you, as well as the eczema. But beside all these infectious and allergic manifestations, which are directly related to a defect of the immune system, we have other clinical symptoms, which are extremely important, extremely severe, very difficult to manage. And particularly, we have skeletal abnormalities with scoliosis, with bone fractures, with connective tissues, with abnormality like hyperlaxity of joints and so on. And these have been referred as well to the STAT3 deficiency through its role in an impaired IL-11 signal transduction. And we know that IL-11 plays a major role in bone formation, particularly through the study of IL-11 receptor deficiency patients. So this is the whole picture of STAT3, which is an autosomal dominant form. And since we have now progressed a lot in terms of molecular tools and identification of other molecules that are involved and genes which are involved in this hyper IgE syndrome, we have been able in the last few years to identify more and more autosomal recessive forms of the disease, which are, of course, more prevalent in our region. And many of the genes I'm going to describe, to cite rapidly now, have been identified in patients from our region, particularly in North Africa. So these are the autosomal recessive PGM3 deficiency. I will go through much more in details. But we have also the autosomal recessive IL-6-ST, the JP130 molecule, extremely important. I will say that later. It is the IL-6 signaling transducer, so it's related to the same pathway as well. We had the description of the anti-autosomal recessive ZNF341 deficiency, extremely interesting regulator of STAT3, and more recently, the description of the IL-6 receptor, the alpha chain, the defect of alpha chain, which is also an autosomal recessive form. So all these are very interesting, very linked, I will demonstrate later, to the STAT3, of course. Two other deficiency, autosomal deficiency with the hyper-IgE have been are out now in the classification of hyper-IgE syndrome. The TYK2 deficiency, which is not always associated with allergy, except in the first patient that's reported, much more frequently, this is mycobacterial disease. And DOC8, of course, you all know, which is now classified as a combined immunodeficiency, although it has some feature of hyper-IgE. So the PGM3 story started, and we have been strongly involved in this for several years now, started with these two families, these two consanguineous but unrelated family, whereby homozygosity mapping and linkage analysis followed by selector-based sequencing, we have been able to identify in the same gene two different mutations. One is a deletion and the other one is a substitution. And these two mutations affect the same gene, which is PGM3. And I will go through the detail of this molecule. So what was interesting in this mutation is that these mutations were hypomorphic, means that you still have some protein. And this is very important because in mice, it has been shown that the homozygous complete defect of PGM3 is lethal. So in this patient, there is still some production. And as you see it here by Western blot, in this patient, we still have some protein which is produced, little as compared to the wild type individual you see here, and heterozygous one as well. But this defect is much less accentuated in those with this substitution mutation. As you can see, these have less protein, but much more than in the first mutation, the deletion one. This has also a much more severe phenotype, clinical phenotype. These patients died for several of them, as you can see here. So we have concluded at that time that PGM3, this enzyme which is involved in the reversible conversion of gluconac-6 phosphate in gluconac-1 phosphate, which is needed to the production of UDP gluconac, an essential precursor of glycosylation, was affected was mutated and responsible of the clinical symptoms. From the glycoparatomic studies we have performed, we have shown that these defects affect the most complex branching of sugars. So not all branching of sugar, the most complex are mostly affected, as you can see here when we compare control with different patients. So, and this is also interesting to know, because this doesn't mean that it's not a very profound defect of glycosylation. Not for all protein, at least, it will affect their function. And particularly the measurement of transferrin, which is used as the glycosylation of transferrin, which is used as a tool to study glycosylation, protein glycosylation, is not affected in these patients. So the final conclusion at that time was that B-allelic hypomorphic mutation of PGM3 deficiency lead to inborn errors of immunity, non-hematopoietic manifestation, and developmental delay. This was new with regard to STAT3. So let's go to the clinical aspects. As you can see here, these patients, these are the first patients we have been reported. Many more have been reported since then. In our hands and in others by other colleagues and investigators. You always have the symptoms that are shared by all hyper-IgE syndrome, and particularly STAT3, the prototype, of course. You have the pneumonia, which sometimes also lung abnormality like bronchiectasis. You have the eczema, the abscess, the candidiasis, a certain level of viral infection in these patients. Infection with Staph aureus, particularly the skin, hyperextensibility of the joints, sometimes the scoliosis for some of them. But we also have the symptoms that are typical of congenital disease of glycosylation, which are developmental delay, psychomotor retardation, and hypotonia. And this was very interesting to note. So there is an overlap. So the question was actually, what functional cellular phenotype could underlie the partially overlapping feature between PGM3 deficiency, a defect in a glycosylation enzyme, and the STAT3, which is a transcriptor factor that has been reported in this Job syndrome or autosomal dominant hyper IgE syndrome. And our hypothesis was very simple. It came out from the paper, an old paper that Mariam, who is contributing significantly to this work and leading it, she observed that this Japanese investigator in the GBC paper a long time ago showed that when GP130 is unglycosylated, it is degraded in the cytoplasm and it does not migrate to the membrane. And this was very interesting for us. So GP130 is the IL-6 signal transducer molecule. It is here, as you can see, the receptor for IL-6 is composed of the two subunits of GP130 and the alpha chain of the receptor, of course. And this protein is highly glycosylated at 9 out of 11 potential N-glycosylation sites. It is involved in the regulation of hematopoiesis, but inflammation, but as well as neural survival and other symptoms which could be linked to what we observe clinically. And its unglycosylated form, as I said, is unstable and does not reach the cell surface. So our hypothesis was that this defect due to PGM3 deficiency may play a role in the impairment of IL-6 STAT3 dependent signaling. So no PGM3, no glycosylation of GP130, so it is not expressed out of the membrane, and all the signaling cascades that comes after is affected, and no STAT3 activation could occur, and no targeted genes could be transcribed. And we have been step by step trying to control and prove our hypothesis. So we started by studying the STAT3 phosphorylation in the cells of these patients after IL-6 stimulation. And we did show that this phosphorylation was affected, as you can see here, as compared to the controls. And we have tested several patients, of course, and controls, of course. This has been further demonstrated by the Western blot studies, where we did show that in patients with the PGM3 deficiency, there is a decrease in phosphorylation of STAT3 as compared to control. And here is our negative control, the STAT3 patients who have a mutation in STAT3 who do not at all phosphorylate STAT3. And as you can see, this is negative totally. So there was a decrease in phosphorylation of STAT3. We did the same thing with another cytokine, a second cytokine, which uses a receptor that uses GB130 as well. So these are GB130 dependent cytokines. And we did show exactly the same. Controls versus patients who do not phosphorylate STAT3 following stimulation with IL-27. But it was important also to demonstrate that in GB130 independent the cytokines, this is not correct, and that phosphorylation is normal. And we did show that with IL-10, as you can see here, IL-10 does not use GP130 molecule in its signaling, and so the activation of STAT3 is strictly normal, as you can see here. And we did it for another cytokine, IL-21, which as well does not use GP130, and we did show that it's absolutely normal. Finally, we did show that the targeted gene SOX3, which is transcribed when STAT3 interacts with the sequences of the DNA, so that it was not produced. This is RNA, so this is RT-PCR, quantitative RT-PCR results. So it was not produced following IL-6 stimulation, but it was normally produced following the IL-10. So it's really due to GP130 defect. To further check our hypothesis, we did look to the expression of GP130 at the surface of the cells, and by flow cytometry, as you can see here, there was a much lower expression of the GP130 at the surface of the cells, and we did show that by Western blot as well, no GP130, and To complete our reasoning, we have tested in a healthy donor the effect of tunicamycin, which is an inhibitor of N-glycosylation. And we did demonstrate that when we add tunicamycin in different concentrations, as you can see here, in time we have the deglycosylation of the GP130, which is at the beginning glycosylated, and the appears in the Western blot the unglycosylated form, which is 100 kD, so smaller than the glycosylated form. And we did demonstrate using the same tunicamycin and IL-6 stimulation that phosphorylation of STAT3 was affected in those patients, as you can see here. So this was a complete set of experiments which led us to put this Jackie paper sometime, yes, 1 year ago, a little bit more than 1 year. And we showed that the effective glycosylation so leads to the effective GP130 or IL-6 stimulate signal transductor molecule expression at the membrane of cells and subsequent GP130 dependent STAT3 signaling defects in PGM3 deficient, linking STAT3 to PGM3 deficiencies. And this has been all further confirmed by the reports of several patients now with IL-6 signal transducer or GP130 deficiency. These are patients with genetic defect. Some are autosomal recessive, some are autosomal dominant. So this really completed our confirmation of our finding. And this is absolutely now recognized in the literature. And as you can see, this is a very nice review, the very recent one, May 2021, where the role of PGM3 in glycosylation of GP130 is recognized, and its role in the transport to the membrane of the protein is really important, shown to be important. Other genetic defects, as I said, IL-6 receptor alpha, GP130, I've just discussed, but also genes that regulate the STAT3 and mainly ZNF341. And this is extremely nice paper that came out from colleagues, some of them present here. And further to that, the TGF-beta signaling effect, which is linked to 2 genetic defects reported, one in ERBIN and one in the receptor of TGF-beta. And STAT3 is absolutely important in the formation of this molecular complex, which is needed, absolutely needed to the action of TGF-beta. And TGF-beta has a major role in the production of IL-4, and so could be responsible of some of the symptoms I've been describing. So now we have a set of genes which are really strictly linked to the STAT3, and which makes sense that we have an entity here. And this is what we have proposed in a recent paper, which came before the last one, which we have been publishing with Aziz in Journal of Clinical Immunology a few months ago, and where we did really propose this novel entity. We know that classification, and we've heard Leila earlier, classification is now still based on the effector of immunity, which is affected. But slowly, with the discovery of so many genes and so many pathways involved, for sure, at the end, we will come with the classification based on the pathways that are involved in this immunodeficiency. And we thought it would be interesting for this complex disease, hyper IgE syndrome, to classify these genes which are related directly to STAT3, as I mentioned, 7 of them: STAT3, PGM3, GP130, IL-6 receptor, the alpha chain, ERBIN disease, the TGF-beta I've just mentioned, and ZNF. So these are regulatory molecules which affect STAT3, and these are constitutive of the pathway itself of IL-6. So it's really important to classify, and this distinguish them from CARD11, common Netherton cell syndrome, and DOC8, which are completely different pathway. May interact with STAT3, but are completely different pathway. And this was accepted some time ago, and I think that it's common sense, as you see. So what is the current and future work? We, beside these nosological aspects, which might not be so much important for our patients, our thoughts are always about how to improve the quality of life of our patients. And these patients are very difficult to treat. We don't maybe have enough time to discuss that, but the prognostic is really poor for them. For STAT3, different attempts have been made, as you know, intravenous immunoglobulin, some bone marrow transportation with not very much good results. For PGM3, some PGM3 patients present like SCIDs. And this is also interesting to say, because sometimes the phenotype is much more complex than we think. And those who presented with SCID have been bone marrow transplanted with relatively good prognosis. But those who live, they live with very, very, very difficult complication because of the bone marrow is affected, and for PGM3, the nervous system and their behavior, their mental retardation. So these are very severe, and bone marrow doesn't improve these aspects. So it's important to find other ways to do things. Furthermore, we know that some of the hyper-IgE syndromes have a very severe eczema, an extremely severe eczema, extremely itchy skin. They have a really poor quality of life. And it's important to think about these things and improve these patients. So this is the IL-6 family receptors and cytokines. And you see IL-11 and its role in the, as I said, in the bone formation. All these receptor of cytokines share GP130 molecule, the red thing here. You see either in 2 copies or in 1 copies for some of them. So OSM, oncostatin, which has a role probably in the neurological features. IL-27, which is a repressor of Th2. Sorry, IL-27, which is a repressor of Th2 and may have a role when it's not functioning normally in allergy, and so on. So it's very important to go further in these details and understand the mechanism that underlie this manifestation and how we can act on this. And one of our hypotheses, we started with IL-27, by the way, because IL-27 is very important, as I said. IL-27 goes through the GP130, one of its receptor molecules, and it will have the role to transduce signal via STAT3, but also STAT1. And via STAT1, it inhibits GATA3, which is the marker of Th2, as you know. So our idea was that maybe the GP130 defect in PGM3 deficient patient affects STAT1 phosphorylation in response to IL-27 and stimulation and induces a skewing into Th2 response and contributes to a high Ig observed. This came from other observation because we know that IL-27 suppresses Th2 cell development and cytokine production. And this has been even proposed as a therapeutic approach for allergic inflammation, but here we have defect in the receptor, of course. But in our 2 observations, the first paper that we had in collaboration with Bodo at that time, and the second companion paper by Josh Milner, it has been shown that there was a skewing in this patient toward Th2 response, and it was nice to think that IL-27 could have that role. So the idea is if GP130 is not there, there is no activation via STAT1, and there is increased GATA3 and increased Th2 level, and lower Tbet and lower Th1 level. So we did a check for some of these aspects and looking for the production of the STAT1, the phosphorylation of STAT1 after stimulation with IL-27. And we did clearly show, as you can see here, that after stimulation with IL-27, yes, there is lower phosphorylation of STAT1, but it's not abolished completely as we would have expected. So probably it's only partially reduced, but we need to do more patients before drawing a definitive conclusion. But for the moment, we think that GP130 independent pathway might partially, other pathways, might partially compensate for this defect in response to IL-27. And we are now doing some RT-PCR studies for GATA3 and Tbet to just check for that. The other hypothesis that looked to us very promising is to use another pathway, IL-21, which does not use GP130. And this is interesting because we can have an immunointervention to treat patients, maybe potentially. So IL-6 defective signaling, our hypothesis was that IL-6 defective signaling due to GP130 defect in PGM3 patients leads to decreased IL-21 production and contributes to high IgE and allergic manifestation. We all know that production of IL-21 depends on IL-6. IL-6 is a major factor that induces the production of IL-21 by T follicular helper cells. And IL-21 has a major role in production of antibodies, and all of you know that. So we started from some observation in the literature. First, when you block the IL-6 receptor in rheumatoid diseases, it has been observed that this reduces IL-21 production and thus increases IgG4 autoantibodies. And IgG4 is an isotype that is linked to allergy like IgE, as you know. The second observation is that IL-21 is indeed a broad negative regulator of IgE class switch recombination in mouse and in human. So this is an important. And last but not least, in human IL-21 and human IL-21 receptor deficiency, it has been shown clearly that there is this switch, increased switch to Th2 and the presence of IgE, high level of IgE. So we did try to check for this hypothesis, and we did stimulate the cells from these patients with IL-6 and different activators, as you can see, different protocol condition. I'm not going through details of that. And we have been looking to IL-6 production. And as you can see here, the IL-6 strongly induces IL-21 production in healthy controls. But when you go here, like here, but when you use a PGM3 deficient patients here, IL-6, so there was a very, very low or absolutely decreased or low level of production of IL-21. So the hypothesis is correct, and IL-6 strongly induces IL-21 production in healthy controls CD4 T cells and linked to this defect in PGM3 deficiency. So we have been a little bit further for this. We have been looking to the induction of C epsilon transcription in the cells with different protocols that have been published earlier. And we have been reproducing these protocols. And we did show that IL-4 induces C epsilon transcription in controls as well as in PGM3 deficient patient, as you can see here. While when we have been to the IL-21, adding IL-21, you see an inhibition of C epsilon transcription that is extremely important, ranging from 90% to 93% in the two groups. So despite the presence of IL-4, so an important suppressor, as you can see here. Furthermore, when we use PGM3 patients, as you can see here, IL-21 inhibited C epsilon expression to 98%, but blocked only partially by 47% the production of the C epsilon expression. These are TPCR, of course. So the conclusion for us was that IL-6 signaling defect in PGM3 deficient patient leads to an IL-21 defective production and upregulates IgE class switching. And this is an important finding. It's not published yet. We are doing more experiments, more patients are being involved, but this could pave the way to potential immunointervention and particularly IL-21 treatment, of course, but these are the first step, the very early steps. So in summary, we have shown that in hyper-IgE syndrome PGM3 deficient patient, the defect of GP130 glycosylation leads to defective expression of the membrane and the obvious alteration of IL-6 signaling. So linking this pathway to the STAT3 pathway and IL-6 family signaling. The defective IL-6 family signaling plays a major role in both probably the immunological and non-immunological manifestation of these 7 STAT3 dependent hyper-IgE syndrome. And there is a lot of work to do now for non-immunological manifestation. And 3, we propose to regroup these hyper-IgE syndrome under the novel entity, the STAT3 related hyper-IgE syndrome. I would like to end to thank all contributors to this work. I would like to thank Mariam Ben Ali, Ruqayya, and Leila Ben Khmis, who were her PhD student, Najla, who did contribute significantly. Mariam has been the leading person for this work. Atfa Sesi, who started the work at the beginning with Bodo, and Imer Ben Mustafa, the senior investigator, very, very, very important for the work in the lab, and Baya, who is the technician, a very good one. I would like also to thank my colleagues from Morocco, Ilham, Leila, and Aziz for their contribution to the paper I've just cited. Thank you to the patients and their family. I would like to thank for their support, the Ministry of Research and Higher Education in Tunisia, the Directorate of International Cooperation from the Principauté de Monaco, and the Chefri Model Foundation for their funding. And thank you for your attention.
Well, thank you, Professor Ridha Barbouche, for your excellent presentation. It's really, really very advanced, but very important. And I have just one question, one small question, because I know that we have to end the session.
Yes, sure.
This type of STAT3 is lethal, I think, by time, because it affects the neurological system with hypotonia
PGM3.
and developmental delay. So would you suggest that for affected families, we have to look for the other siblings, even prenatal or neonatal screening?
Yes, so we have several of these families now in here in Tunisia. We are discussing the PGM3 deficiency, yeah, isn't it?
Yes,
yeah. So PGM3 is a very, very, very complex disease with very poor prognosis, as you said. Many of these patients, they could live to the second decade, sometimes even a little bit more, but it is a poor quality of life because of the infection and because of the mental retardation and the how to say the failure to thrive and so on. So it's very severe, I agree. So we do not have to propose something for the moment. We don't propose something etiological. We have tried. We had 2 clinical essays, one by Josh Milner at the NIH and one in Tunisia with our patients, trying to give them a cream locally for the eczema at least, and Josh tried in vitro to do it on cells, and later on a clinical assay. Since these are a hypomorphic mutation, we still have some enzyme which is there. And we have been showing in the first paper that the activity of the enzyme is still there. It is able to catalyze the gluconac-1 phosphate. So we gave an excess of substrate to these patients, an excess of the substrate of the enzyme, hoping that this will help the enzyme to work and improve their condition. Didn't work. So this was our first attempt. It didn't work in our hands. It didn't work in the hands of Josh. So people have tried bone marrow transplantation in those who have T minus B minus phenotype. But yes, the only approach that we are proposing now is genetic counseling and prenatal diagnosis in the families. We have one mutation which is accounting for most of the patients here in Tunisia. We have a founder effect for one mutation. We have published that. We have published several families now. We have, if you look in the literature, you will find a series from us with several families with very interesting data. And we are doing genetic counseling. That's all what we can propose for the moment for these patients. It's very tough. These are really difficult. Yeah.
Really. Thank you very much, Professor Ridha Barbouche. And now we have to end this session. I don't know where is Tennessee. I think, is Tennessee with me? No. All the chairpersons left except me. So I have to end this session and to thank all the speakers for their eminent and professional way of presentation. And I thank Professor Ridha Barbouche in person because your work is super. And I'd like to thank all the organizing committee. Professor Aziz Bousfiha is with us now. It's very nice having or meeting you today and yesterday. And we'll end this session, unfortunately, but we hope to meet soon again. Thank you very much.
Thank you.
Dear attendees and dear friends, dear speakers and dear moderators, you are all very, very, very welcome. And I really thank all of you for your patience and for contributing to this meeting. We've received phenomenal statistics regarding the attendance, and we've received so many complimenting messages and encouraging thoughts and contributions. Thank you so much for all this. I mean, it's amazing how the COVID situation has isolated us, yet brought us together. So this is fantastic. I can't have more than such big success happening live, and such great interaction between different people. We had the science, we had the clinics, we had it all. I think it was a fantastic program. Thank you so much, Reem. Dr. Rima Fiqhi, head of scientific committee. She has been the figure behind such a wonderful program, and the organization. I mean, it has been complemented so much. We had our backstage sessions, and we also had the live streaming. And here at the backstage, we had both. And it's just been amazing. What can I say, Leila? It's wonderful. Thank you so much. Thank you so much for all the chairing the organization committee, and for doing such a fantastic job leading your team and coordinating with patients. And all those nights we stayed up till 3 and 4 o'clock trying to put together the JOSI supplement. So don't forget, all the abstracts are now published, and the publication is out as a supplement for the conference. So please go and visit those. That's wonderful. I would really like you also to go and visit the website. It will stay on for at least a month. And we will transfer all the things that are currently in it into our main website at ASID. Please visit the website, look at the e-posters, and encourage your society, make a big view and visibility of ASID. We need it to grow and to become stronger. We have a big portfolio ahead of us. We started many, many years ago, and we need the energy and the momentum now. It can only happen with your help and with your energy. So please do that, help us. And before I conclude, I really want to ask everybody to fill in the evaluation forms that will be available to them, because these are going to help us make things even better. And I really hope that next time we see each other physically, or maybe we can have it a hybrid meeting where people can go online and can go on airplanes as well. So I hope things will become better for all of us, and everybody keeps well until we meet again. Thank you so much again and again and again. Can't stop thanking you. And now I am really pleased to hand over to my successor, and who else but the magnificent Dr. Leila Jeddane, our new ASID president. The floor is all yours. Thank you very much, Leila. Go ahead.
Thank you, Nahla, for these kind words. It was not easy, especially today. We had a 10 hours marathon for the program with no stop when you were in the backstage. So really, thank you so much, especially to Sadafat and Omar to follow us backstage. And I absolutely need to thank the outgoing board members, such as Brian Eley, that was a founder member, that was in the board until now. Really thank you for all the time and for all the work that you committed to ASID. Thank you to Indu and Alau. I hope that I will see you in the next mandate. And thanks the one that has the new and the already the member that will stay in the board, like Wim, Aziz, who else? Ryan. I'm really happy to work again with you. it was really wonderful experience, and I'm happy that we continue on that. Thank you, of course. Nahla, of course, of course. Nahla will be. We stay in the board, of course. Monika, the stomach. Monika is Aziz. I've been there since 13 years.
Oh, goodness.
So really since the beginning. So really fact that you still all to us.
Yeah.
And I need to welcome, of course, the new members to the board. So Ali, really thank you, really welcome. I hope that we will get good collaborations. Welcome to Anne Barassa, and to our colleague from Ivory Coast, Madeleine and Vincent. I hope I didn't miss anyone. Hind, oh, sorry, Hind. So is my colleague from Morocco, and she will be the treasurer. And I know that she will do a good work because she's really an energetic girl. So except that. So what else can I say? Really, I'm
the next
yes.
country.
Yes, the next. But we try to have other activity before the biennial meeting. I think we were Winter School is in the Claude. So I'll be happy to see you in 2 years in Morocco. It will be the 15th birthday of ASID. And we'll come back for the first time in Morocco after his birth. So it's a huge
and after
responsibility.
Morocco, Kenya after Morocco, perhaps.
And Kenya after Morocco. It was just decided this morning. And so it's a really huge responsibility to set up this meeting, and I'm really honored that you gave me this opportunity. I hope it will be, of course, physical meeting, but I'm think about the hybrid meeting in the other way this time. So most of people will be in physical, and maybe save some speaker or some people we can follow us on live. So I hope that will be the format of the next meeting. Aziz, do you have any word to say, or is anyone else want to say something?
Yes, two little words, and to say that here in this picture there is 1, 2, 3 founders of ASID, Monika and Ridha Barbouche, 13 years ago. And we still want to move on. So I really want to thank all the work made by Nahla. Nahla was the locomotive. We say locomotive in English? The train, the first in the train, what we call it. Okay, you were in the head of the train, and you made a great job, and with a lot of. It was very nice to work with you. I want to hear Monika and Ridha Barbouche, but thank you for all of you.
Thank you, Aziz.
Thank you. So.
Well, thank you very much to all those who have contributed, and I think it's fabulous to still have 3 of us oldies around. I think it's time to get new energy on board, and I think that's been shown at this meeting. And it's wonderful the way young people have come on board, are taking over certain jobs, because we need people to work on this. So I think this is going to be the big thing, that we get people to really work on this so that ASID continues as a success. And I think the hybrid model is a great way to go forward, because we've certainly increased the numbers of people being able to attend these meetings through the internet. And this has really made it more accessible to Africa. No more excuses. I think here we go. Thank you. Thank you to everybody very much.
Okay, thank you. Thank you, Aziz. Thank you, Monika, for your words. Yes, indeed, we are really, all of us were impressed by the progress that has been made in the field in our continent, and that's really a great pleasure. And I hope that we will keep going forward with all of us united and working together. I think, as Monika just said, I think it's very important that this COVID pandemic did something new, which is good and not good, right? It's different ways to see it, which is good that we have a lot of possibilities of communication, easy way to communicate. Of course, we still need some meeting in person and direct contact, but I think that the society will benefit from small meeting between one and the other Congress that could be done by virtually, I mean, and around one topic. And in the research field, and I was hoping that we can contribute to that aspect. I think it's very important to start some collaboration, some real collaboration, some work done together on one or the other aspect, to try to find some funding to have students going back and forward. And this is extremely important. And this is a new era. This post-COVID era is a new one, and we should adapt to that using particularly the virtual means of communication. Otherwise, I'm really again honored and pleased to be with all of you, old and new friends, and I hope that Tunisia, who is missing in the board this time, will be always part of this venture. And thank you for all what you have done. Thank you so much.
Thank you very much, Ridha. That's wonderful. Very strong words there and clear messages. Thank you so much.
Thanks.
Wim, do you want to have a word?
Where are you?
Wim is the president of the scientific committee. He has done
a wonderful work.
The boss.
Merci.
No,
I want to hear you. You are behind the picture always.
I'm really grateful for everyone of the board, everyone in the scientific committee and in organizing committee. I'm really grateful for Nahla, Leila, Professor Aziz, all the speakers, all the chairpersons, and all the moderators who stayed with us, and everyone who is staying with us till the end, and all the attendees who are staying till the end, just listening to us. I don't know what to say. I'm very overwhelmed by this conference, and I feel that it was a successful conference, and I'm waiting to see the evaluation to see how can we make it much better in the next time, and how can we make it better for every one of you. So hopefully we will continue. And big thank to Nahla, really. Thank you very much, Nahla, for being such a beautiful and successful president. And I know that Leila is going to be just another successful lady. So
yes. May I just add, Reem, it was fantastic. This work that you have started with other colleagues, with Nahla, with Rayan, about the guidelines for the different PIDs is major progress I've seen during this mandate. And I think that you should keep working on that, really, with maybe to enlarge the team. We have been supportive of this initiative, as you remember, and we will be always supportive of that. Iman in the lab, in the clinical department, and as well as Najla and Mariam will be more than happy to contribute to that, those guidelines, which have a part of biology, which is extremely important. So do not hesitate. Really, I think that we should build on that. This is a good start. I've seen that Rayan as well was involved in this, and this very interesting thing.
Yeah. Thank you. Thank you very much, everyone. So we'll meet in. I think we have to carry on with the schools for sure. And I think, Reem, we have to, well, I'm not the president, but Leila, can you ask Reem that we continue, that we're doing like bi-monthly meetings, maybe on case presentations and specific topics, when Ridha can come and overwhelm us with all the science that he has on all the hyper IgE. So maybe we can have some cases straight away on hyper IgE. I think that would be my suggestion for the coming brief meeting. How about that?
Yes.
Yeah.
I think it's a good idea.
Because it's a very common disease, and we've mandated hyper IgE as one of the next guidelines anyway, haven't we?
Yes. Okay.
Okay. Yeah, we have something to do.
Thank you.
Please, Leila, sorry about that. I'm just used to being a president now.
Okay. No problem.
Yes.
No, we had some initiative that were done in this mandate. That's really important, and that to keep going on that.
Absolutely.
So and hopefully we can even broad on it. So we absolutely need to continue.
We had can I just tell them about our little secret meeting that we had on the third day of Eid al-Adha, when we were revising all the conference preparations, and then we decided, well, I told Leila that I would like to carry on with the mandate that I have started, and to help with each and every aspect of it, because I really enjoyed that, actually. And she has a lot to do as well. So I'm looking forward, actually, to the next term. It's less stress with administration and hopefully more energy for science and clinical work.
I think we can continue this board discussion.
Yeah, we can go. Yeah, yeah, where we usually do that. Yeah,
not in live. Okay.
Okay. Yeah. People are probably bored now.
Okay. Omar, can you show yourself, because we really need to thank you. We really. We gave you some last minute. I remember saying, "Okay, I didn't tell you that, but we need that," and you say, "It's possible." So thank you really a lot for this work.
Yeah. So that's Omar. So that's the man behind the scenes who has brought all the scenes to the stage. Thank you so much, Omar. I wanted to take a picture yesterday in my presentation, but then I thought a live representation would be much more impressive. Thank you, Omar. Wonderful. Thank you.
There is no Sudanese music?
Oh, you missed it. You missed it.
Really? You did?
It was in the opening session.
No, that was a film.
I'll send you something on. Oh, you haven't got what's
that was a film, no? That was a short movie, no?
That was a short movie, yes.
The music
can sing for us now.
Oh my goodness.
No, I'm talking about the mambo Sudani, some dancing thing. No.
I'll send you some links on.
Yeah, when I was young, I was burst by this song, the mambo Sudani.
Everybody is.
Do you remember it? It's very old. You probably missed it.
Of course I did. I'm so young.
Yeah.
Okay. Yeah,
so,
I think we can. This was the function of the conference dinner, which we don't have the pleasure of going to. But thank you very much, all of you. And I think we need to conclude, because everybody wants to go and find what they need to do after such a long day. Thank you. And I'll just see if Leila wants to thank you or something like that. It's okay.
Thank you, Nana. Thank you so much, Nana.
I think we're all done. Thank you. Well done.
Thank you, Rayan.
Oh, Rayan, the quiet lady. Yeah.
Okay.
Yes.
Assalamu alaikum.
Okay.
Bye-bye.
Bye.
Bye-bye.
Bye now. Bye.
Bye.